Good morning, everyone. I am very pleased to see so many people here for this second USI YOU Youth Conclave, which is supposed to be a hybrid meeting. So to start the proceedings, I would like to welcome our USI President, Dr. Mallikarjun, sir, to please come on the dais. Dr. Rohit, please felicitate sir with the bouquet. Welcome, sir. I would also like to welcome our Secretary, sir, Dr. Keshamurthy, sir, on the dais. Dr. Zishan, please felicitate Keshamurthy, sir. Thank you, sir. So we would proceed on to a brief inauguration of the program. We would go for a lamp lighting. I would request our President, sir, Secretary, sir, and all the senior members present here to go ahead with the lamp lighting. Sir, please come.
Shubham kurutvam kalyanam arogyam dhanasampadah. Shubham kurutvam kalyanam arogyam dhanasampadah. Shatru buddhi vinashaya deepajyotir namostute. Deepajyotir namostute. Deepajyotir parabrahma. Deepajyotir janardanah. Deepajyotir parabrahma. Deepajyotir janardanah. Deepo hartu me papam. Sandhya deepa namostute. O deepa brahma rupastvam. Jyotisham prabhuravyayah. O deepa brahma rupastvam. Jyotisham prabhuravyayah. Arogyam dehi putranscha. Matim swachham hi me sada. Praverastam samarabhya. Yavat suryodayo bhavet. Praverastam samarabhya. Yavat suryodayo bhavet. Yasya tishte gruhe deepa.
Thank you so much, sir. So, to start the program, I would like to invite Keshamurthy, sir, to give his welcome address. Sir, please.
Thank you, Dilip. Good morning to all of you. President of the Urological Society of India, Dr. C. Mallikarjun. President-elect, Dr. Ravindra Subnis. Past President, Dr. Anant Kumar. Honorary Treasurer, Dr. Anil Varshni. And all the esteemed council members of the Urological Society of India, respected teachers and senior colleagues. It's my pleasure to welcome all of you to the second youth conclave organized by the Youth Organization of the Urological Society of India at Hyderabad. It's a 1.5-day program. I must compliment the young urologists who have crafted a very nice program, which is a mix of scientific content along with non-urological topics, which are out-of-the-box star talks. It's a very interesting program. I would urge all the delegates to be tuned in for this wonderful lectures by the young urologists of our country. The U was conceptualized by the Urological Society of India with the idea to utilize the energy of the young and also mix it up with the experience of the seniors to make our society a more vibrant society. I would take this opportunity to request the U not only to limit their program to conducting programs like this, but you should start interacting with seniors to build yourselves to be the leaders, because you are the future of the Urological Society of India. So you have to start interacting with the senior leaders to imbibe the qualities of the leadership, so that is the concept why the U has been formed, because we need to train the young urologists to become the future leaders. Also spare some of your time to do some charity work which the USI is planning to do under the USI Care to help the downtrodden of this country. I think you need to keep some spare time whenever the USI requests your time. Please give your time to do some charity work. And also start interacting with the trainees, because your inputs for their career opportunities, for their fellowship programs, all these things you need to interact with them and tell them that these are the opportunities, because you have gone through that process and you would be the better persons to tell these residents that these are the opportunities which are available to you. So with these few words, I would congratulate all the you members who have put in this lot of effort to get this program going, and I wish you all the best. Thank you.
Thank you, sir. Going ahead, I would like to invite our President, sir, Mallikarjun, sir, to please come and give his presidential address.
Thank you, Dilip. Dr. Dilip Mishra, convener of Youth Organization of USI, Dr. Jishan, co-convener, and the U Executive. Sincerely appreciate your efforts to conduct this program in association with the USI Executive, with Dr. Keshav Murthy at background and Dr. Sabnis here. Well, I think Keshav has said what you can do about in near future. It's only an attempt. You is basically an attempt to create more leaders. The actual true leaders actually assist in creating more leaders for future. If that doesn't happen, it doesn't go forward anywhere. It will be directionless completely. That's a basic thing which was the reason why you has been started. But in fact, I have my own perception which I want to share with you. Basically, it is not representation of just a youth, few leaders in the youth, but basically I look at you as a representation of the youth in USI. Over a period of time, initially we used to have only 10 or 20 urologists adding to the USI society every year. Now there are 200 people adding to the society. And there are few seniors or few executives who control the whole society. So there is a big disconnect between the young or the youngest to the senior most. And there is a communication gap existing between this. And it takes long time for that gap to shorten. So you should be the thing which decreases that communication gap. Possibly you are the people who carry forward their thoughts, what the youngest generation is requiring it to the next generation beyond you. So we already have 3 generations of urologists actively participating in the USI, and you are this in-between generation which will take care of this communication between this youngest and the eldest. So that will form a better nexus and a fabric inside the society. So taking cue from what Dr. Keshav has left behind, you need to take over the reins over a period of time, so that it requires more creation of more leaders. At the same time, you need to bridge that gap between these two groups of people where there is disconnect, significant disconnect I've seen in my own life in the last 30 years. The disconnect is varied. It's so much now. We don't even know the name of a person and where he comes from who is just 30 years junior to you. It's not possible to understand and have a connect. So I would request all of you to make that efforts to understand what these younger people can require for their near future, and then bridge that and communicate it to the next level so that that bridge can be, or that gap can be closed in future. So I think this, in what way it can be materialized, I think you are better, wiser people to understand, because you passed that phase of life, that youth phase of life, and now you can understand what makes them, that where is that gap. So you should be able to understand it better or analyze it better and see that that gap is shortened over a period of time. Thank you very much for this opportunity, and I hope that this will be a great meet and you will enjoy this presence. And welcome to Hyderabad. Thank you.
Thank you, sir, for your kind words. So good morning once again. I am pleased to see so many people here for the second USI YOU Youth Conclave. This is a hybrid meeting. First one was held last year because of COVID. We had to have it on a Zoom platform, online platform. Now this, we have progressed and we have made it hybrid this time. So I hope next year we will be having a full meeting, which will be on. So it has been a little monotonous seeing all the academics on Zoom. So this hybrid meeting has been planned with all the efforts of Team USI, especially Keshamurthy sir and Mallikarjun sir. USI-U means Youth Organization of USI. We are a youthful part of Urological Society of India. This conclave has been designed to give chance to young members of USI to come up with new ideas and their points of view. This is a hybrid meeting. Few speakers are present here in Hyderabad for their talks live. Few speakers will join live on Zoom for their talks, and few speakers have sent their talks pre-recorded. So it is a complete hybrid meeting with talks in all the formats. Coming back to this program, we have today a total of 44 talks, videos, and debates divided into 5 sections covering most of the interesting areas of urology. All sessions will be monitored by experts who will give their remarks in the end. So it cannot be successful unless we have guidance from the seniors. So we have kept all senior faculty members who will be guiding us in our talks. 4 talks will be delivered by stalwarts and our beloved teachers which are going to be very interesting. And I am very thankful to our Secretary Keshamurthy sir for letting us have this conclave in hybrid format. It's a pleasure, sir. So let's begin this hybrid meeting. I would hand it over to the moderators of the first session, Dr. Rohit Joshi and Dr. Aditya Sharma. Thank you, sir. Dr. Rohit and Dr. Aditya can come on the dais and start the first session.
Good morning, all the seniors and my you friends. Dilip, this has been a hybrid meeting in 2 senses. Number 1 is the format, and number 2 is it's a mix of experience of the seniors and the exuberance of the youth. So it's a hybrid meeting in all the respects. And we have got fantastic speakers in the session, which is named as an oncology session. And before we start the talks, let us virtually welcome the experts, Dr. Ravi Mohan and Dr. Raghunath. And without wasting any more time, we are right on the time, Anand. So let us start with the first talk. And fortunately, the first talk happens to be a live one. So we'll have a flair of a live interaction. So may I now invite Dr. Amresh Mohan, who is from the Hyderabad itself. Amresh, please come forward and deliver your talk.
Good morning, everyone. First of all, greetings from Hyderabad. I'd like to thank USI and the U Council, Dr. Dilip sir and Dr. Zishan sir for giving me this opportunity. So this is a quick overview of the treatment of testicular cancer. So yes, cancer is curable, and this aptly fits for the germ cell tumors of the testis. And this is the famous story of the cyclist Lance Armstrong, who survived cancer and later on won 7 trophies, though later on he became infamous. And with the development of chemotherapy and integration of surgery, so germ cell tumors of the testis have become a model and a paradigm for the multidisciplinary treatment of cancer. So today I'll be taking through the TNM staging and the stage grouping, the International Germ Cell Cancer Collaborative Group risk stratification, principles of management options for seminoma and non-seminomatous germ cell tumors. So the T staging is only known after the high inguinal archetectomy or the radical archetectomy, and hence a pathological stage is assigned. So TIS is nowadays named as the Gcnis, that is the germ cell neoplasm in situ. T1 is without LVI and limited to the albuginia. T2 is limited to involving the vaginalis and involving LVI. T3 is involving the spermatic cord, and T4 is involving the scrotum. So end stage is assigned based on the size and the number of lymph nodes. N1 is less than 2 centimeters or less than 5 nodes. N2 is 2 to 5 centimeters or more than 5 nodes. And even the extranodal extension is assigned pathologically N2, and N3 is more than 5 centimeters. Coming to the M stage, M1A is non-regional lymph nodes and lung mets. M1B is any other distant mets other than the non-regional nodes and lung mets. So coming to the S stage, which is peculiar in the testicular malignancies. So S stage is assigned post-archetectomy, and the 3 tumor markers that are commonly used are LDH, though non-specific, and HCG and AFP with their various limits. So coming to the stage grouping, to simplify, clinically stage 1 is defined as disease clinically confined to the testis. Here the tumor markers are within normal limits. Stage 1S is the different group in stage 1, wherein there is no tumor in the testis, but the markers still keep elevated. So clinically stage 2 indicates the presence of regional lymph node metastasis. Here again the markers are within S0 to S1. Stage 3 represents non-regional lymph nodes and or visceral metastasis. Here the tumor markers are significantly elevated. So coming to the International Germ Cell Cancer Collaborative Group risk stratification for advanced disease. When I say advanced disease, it includes 2C and 3. So here we need to pay attention that seminoma has only 2 groups, that is the good risk and the intermediate risk, and there are no patients classified as poor risk. Whereas in the non-seminoma, patients are categorized into good, intermediate and poor risk based on the serum marker levels, and also the non-lung metastases are classified as poor risk. So a word on high inguinal archetectomy, it is both diagnostic and therapeutic in early cancer. It involves removal of testis and cord structures till the inguinal ring. Transscrotal archetectomy is contraindicated as it breaches the scrotal lymphatics. Avoid delay of more than a week from diagnosis, and testis sparing surgery is highly controversial. It is done only in special situations. So when I say principles of management, here we always aim for cure most of the times. So young age and good performance status permits aggressive treatment, possibility of cure even in metastatic disease, chemotherapy to be administered regardless of leukopenia, thrombocytopenia and moderate renal insufficiency, aggressive surgical approach to resect all residual masses after chemotherapy. So coming to management of Gcnis. Gcnis is diagnosed usually on testicular biopsy done for infertility or contralateral biopsy during testis preserving surgeries. So rationale for treating this is 50% risk of invasive GCT at 5 years. High inguinal archetectomy is definitive treatment. 20 gray of RT though has similar efficacy but at the cost of hampering opposite testis, and chemotherapy is less effective. So when I come to the stage 1 seminoma, so here the occult mets are present in 10 to 15% of the patients. So that is the need for the further treatment in these patients. So the treatment options are surveillance, adjuvant radiation, adjuvant chemotherapy and risk adapted approach based on the tumor size and rated testis invasion. So the surveillance rationale is only 10 to 15% of these patients have occult mets, and so the recurrence-free survival is 85% at 10 years. So with no high-risk features, recurrence drops to 6%, and the cancer-specific survival is 99%. And surveillance protocol includes physical examination and contrast CT at 3 months, followed by 6 monthly till 3 years, and annually. Tumor markers are optional, and chest X-ray and chest CT in symptomatic patients. So by surveillance, we can avoid the toxicity of chemo and radiation, while the disadvantage is the continuous radiation exposure in the follow-up and the strict compliance which is lacking in our patients. So chemotherapy for clinical stage 1 seminoma, here the single agent carboplatin therapy, 1 cycle is commonly administered, area under curve 7, 5-year disease-free survival of 96%, follow-up after chemotherapy is with annual contrast CT, abdomen and pelvis. So radiation for clinical stage 1 seminoma included previously the dog-leg configuration, that is the retroperitoneum and ipsilateral pelvis, which is now changed to only the retroperitoneum. So previously dose of 20 to 24 gray over 10 fractions was administered, long-term recurrence-free survival of 97% and cancer-specific survival of 100%. So the toxicity of radiotherapy includes acute toxicity in 5 to 15% and late toxicity seen in 5%, persistent oligospermia in 8%, and second malignant neoplasms which develop over a period of 10 to 15 years in 15% of the patients. So EAU guidelines 2021 summarizes offer surveillance as preferred management if facilities are available and patient is compliant, area under curve 7 carboplatin therapy to be considered, do not perform adjuvant radiotherapy, and adjuvant radiotherapy should be reserved only for patients not suitable for surveillance and contraindication for chemotherapy. So stage 2A, 2B seminoma includes both chemo and radiation. So relapse rate of 8% in stage 2A and 10% in stage 2B. Acute toxicity is seen more with chemo, while the late toxicity is seen with radiation. No head-on RCTs comparing both RT and chemo. Follow-up protocols include CT scan at 3, 6, 12 months and then annually till 5 years. So stage 2 and stage 3 seminoma is good risk and intermediate risk. So the follow-up is with FDG PET. If there is a residual mass less than 3 centimeters need to be observed. More than 3 centimeters FDG non-avate can be observed. More than 3 centimeters FDG avate. Repeat PET CT after 6 weeks. Persistent FDG uptake or increase in size, salvage therapy. So this is the summary. So stage 1 non-seminomatous germ cell tumors occult met seen in 25 to 30 patients, 30% of the patients. High risk features includes LVI, embryonal carcinoma, and proliferation rate more than 70%. The treatment options are surveillance, adjuvant chemo, and RPLND. No role for radiation as they are not radiosensitive. So surveillance is to avoid overtreatment, and if relapse occurs, salvage is always possible. So the disadvantages with this is relapse rate is high with the radiation exposure and adding to the cost of repeated imaging. So adjuvant chemotherapy includes 1 cycle of BEP with relapse-free rate of 95%. 1 BEP is equivalent to 2 BEP. So RPLND, role of RPLND in clinical stage 1 non-seminomatous germ cell tumors, nerve-sparing RPLND is the standard of care. Relapse rate 10% at 5 years. Further treatment depends on histopathology. RPLND preferred if high inguinal archetectomy suggests teratoma with LVI. So the EAU 2021 states offer surveillance if LVI is not present, and discuss 1 course of BEP as adjuvant treatment alternative if patients are not willing to undergo or comply with surveillance. Stage 1S and 2A, 2B. For stage 1S, repeat tumor markers, CT scan and ultrasound to confirm there is no macroscopic disease. For confirmed stage 1S, 3 cycles of BEP or 4 EP. For stage 2A with normal tumor markers, if there is regression, keep them on surveillance. If there is stable disease, RPLND. For stage 2B with normalized tumor markers, nerve-sparing RPLND is preferred. So this is the primary RPLND treatment options. Pathologically N0, put them on surveillance. Pathologically N1, both options are equivalent. Pathologically N2, chemo is preferred. Pathologically N3, chemo is again preferred. So stage 2 and advanced NSGCT, good risk group 3 cycles of BEP, intermediate risk groups 4 cycles of BEP, poor risk group 4 cycles of BEP. Response assessment, poor response, there is dose intensification or second line chemo. If complete resolution, put them on observation. So post-residual masses, necrosis is 40%, teratoma 45%, and viable malignancy seen in 15%. FDG PET is not recommended to differentiate. RPLND is mandatory in all residual lesions more than 1 centimeter. Outcome depends on completeness of resection as they are not chemosensitive.
Amresh,
6 to 8% can develop malignant neoplasm. So last slide.
Thank you.
Post-chemo status in NSGCT, complete remission, RPLND not indicated, residual mass less than 1 centimeter, role of RPLND is uncertain, residual mass more than 1 centimeter, RPLND is mandatory. Thank you. Thank you for the patient listening.
Thank you so much, Amresh. It was a brief but comprehensive review of all these tumors. Thank you so much for finishing within the time. Thank you so much. Moving now on to the recorded talk that is from Dr. Gagan Prakash from TMC Mumbai. And he is going to enlighten us a risk-adapted approach to the testicular cancer. Anand.
Good evening, everybody. Thank you, Urological Society of India and the Youth Organization of USI for this invitation and opportunity. I will be talking about the risk-adapted approach to testicular cancer. Now, this whole concept of risk stratification is not new to us in urology. We've been using it for renal cancer, prostate, bladder, and penile cancer. And today, let's see how it makes a difference in testicular cancer. It essentially helps us create a balance between the oncological outcomes and toxicity. And this could happen at various levels. It would help us take decisions like whether to treat or not to treat, or what kind of modality of treatment to be chosen, like surgery or radiotherapy or chemotherapy, or what should be the intensity of treatment in terms of the numbers of chemotherapy cycles, or maybe in the future it would help us choose or select our patients for open surgery versus minimally invasive or nerve sparing or extraperitoneal RPLNDs. We all know about the TNM classification of testicular cancer and how it is unique in incorporating the tumor markers as the S stage, the LDH, beta HCG, and the AFP tumor markers. And essentially it has various stages. And what's different over here in the staging of testicular cancers, it's complex, and I must suggest all exam going residents to keep this particular staging in your to-do list a day before the exams. It doesn't have a stage 4 disease in testicular cancer staging. There are no grades. Instead, there are S1 to S3 levels, and also a very unique risk stratification called the IGCCCG, about which I would be talking in some time. Now let's understand that when we talk about risk-based approach, there are essentially two things, one or two concepts actually. So one is about risk factors, and the other one is about risk or prognostic grouping or stratification. So risk factors is something which is relevant to stage 1 germ cell tumors, whereas risk or prognostic groups is something which is more relevant to the advanced germ cell tumor. Now, risk factors are used in management of stage 1 germ cell tumor. In seminoma, we know that around 10 to 15% of patients with stage 1 disease have occult metastasis, and typically the options to treat this stage would be surveillance, adjuvant radiotherapy, or chemotherapy. And then comes the query about whether to treat these patients or not, surveillance versus one of these options. And this is where the risk factors like tumor size and invasion of radiotestis comes into play. Notice that the guidelines very strongly mention that the decision about treatment should be based on risk factors. Similar thing in stage 1 non-seminomatous germ cell tumors, where around 25 to 30% of patients could have occult metastasis. And again, we've got options of surveillance versus no treatment, that surveillance versus treatment, which could be either adjuvant chemotherapy or RPLND. And again, we've got risk factors, amongst which the most important is the presence or absence of lymphovascular invasion. But others like embryonal component and MIP staining has also been mentioned. Again, the same story over here. If you look at the guidelines, very, very strongly say that this whole decision has to be based on risk categorization or risk factors based on these pathological factors. The other concept about risk-based management is based on this International Germ Cell Cancer Collaborative Group risk stratification, which was essentially, many centers had a collaborative work published in 1997, where based on factors like the presence of primary site, whether it was just testis and retroperitoneum or whether it was mediastinum, and what were the sites of mets, whether it was pulmonary or non-pulmonary visceral mets, and what kind of tumor marker levels were for a patient, AFP, beta HCG, and LDH. Based on these criteria, the seminoma disease was categorized into good or intermediate prognosis, whereas the non-seminomatous was divided into good, intermediate, and poor prognosis risk groups. And if you look at the summary of metastatic germ cell tumor, you'll see that at every level, there is first an insistence about categorizing these patients into one of these risk categories, and then the treatment pathway is being chosen. Now, very recently, this whole IGCCG was actually updated in another large collaborative group with the idea or the aim to offer a more contemporary assessment, a more granular assessment of the progression-free survival and overall survival in an era which is, right now with better utilization of chemotherapy drugs. I would like to spend some time on the next two slides, which is about the update and what was found that the 5-year progression-free survival and the 5-year overall survival of both the good and the intermediate risk groups in seminoma. And by the way, this was a cohort of almost 2,451 patients of seminoma, which is like a huge number for seminomas. And it was found that both the 5-year PFS and the 5-year OS actually significantly improved in the recent cohort. Also, they could come at a particular cutoff of LDH, which could kind of prognosticate these patients. A similar trend was seen in the non-seminomatous group also, which was close to 10,000 patients. And there was a 5-year overall survival improvement seen in good and intermediate risk patients. And in poor risk patients, there was a significant improvement in both the PFS and the overall survival. You can see that the overall survival actually increased from 48, 5-year overall survival increased from 48% to 67% in the more contemporary series. This particular updated IGCCG stratification is based online, and I would suggest all of you who are treating testicular cancer to start using this risk calculator. Now, if I had to crystal gaze about what's going to happen in the future about risk stratification, it is clearly the use of microRNAs. This is essentially a biomarker which has been extensively researched and is potentially going to be used in the diagnosis, in predicting relapses, in adjuvant treatment, in prediction of post-chemotherapy residual masses, how many of them have viable or non-viable tumor, and in prognostication. And the other area where there's a lot of work and research going on is the concept of radiomics, which is essentially texture analysis. You would be aware of how the images are being extensively studied and some kind of predictions are being made out of it. Something more closer to and more relevant for the Indian kind of a scenario where non-biological factors are being tried to be integrated in the risk assessment. Factors like the socioeconomic status, the marital status, insurance status, and whether the patients are from are being treated in a private or a general hospital. Take-home messages: risk-based management balances oncological outcome and toxicity. IGCCG is a robust tool for risk assessment and has a recent validation. MicroRNA-based biomarkers are being extensively evaluated and could potentially govern the risk-based management of testicular cancer. Thank you for your attention.
Thank you so much, Gagan, for this talk on the risk-based approach for the testicular cancers. Now we have one more speaker in person, and I would be delighted to invite Dr. Kapil, and he will deliver a talk on penile preservation surgery. Are they really worth? Over to you, Kapil.
Good morning, everyone. Greetings from Hyderabad. We were small, physical, but robust, and a really nice gathering over here. It's a pleasure to be a part of the conferences again physically. So moving up from the testis to the penis, coming to the penile preservation surgeries. The topic is, are they worth it? So we all know squamous cell carcinoma of the penis is a relatively rare disease. So all that this slide implies is we see it 3 times much more commonly than the Western population. So the number of patients we get will be more, and we should be geared up for handling these kind of situations in a way they should be appropriately handled. There is no doubt about radical surgery offering excellent outcomes oncologically, but the concern has always been the over-treatment which has been given for this disease. Why the need for preservation? For the obvious reasons. The patient needs to have sexual intercourse, needs to avoid upright, and the psychological impact of losing the organ is an important consideration over here. This was an important study. It was published in 2000, and along with this, in the adjacent 2-3 years, there were a lot of publications which signified that we are definitely over-treating this cancer with the amount of margin being taken. The conventional margin of 2 centimeter was brought down to 5 mm. This was a landmark change in the EU guidelines 2005, where they believed that 5 mm was a significant amount of margin which would give adequate oncological clearance, thus paving the way for all the penile preserving procedures. This is another study. It was a systematic review. There were 128 patients included. What is important to note is that the sexual function was lacking in up to 68-70% of the patients, which is a very, very high number. 50% of the patients developed psychiatric symptoms, and of those 50%, 80% had depression, and the study followed them up. 2 patients ended up killing themselves. They attempted suicide. In fact, they died. So it's a significant psychological dysfunction which needs to be addressed. Coming on to what the guidelines say, they are quite clear. They do not have much of ambiguity about the use of penile preservation procedures. When it comes to TIS, TA, well, we are all clear, including T1A, G1, G2, that the preservation procedures are the way to go. There is no ambiguity or confusion, with the strength rating being strong. Even up to T1B, G3 lesions, it's quite clear that penile preservation procedures are the procedures of choice. It's in T2 where the conflict arises. EAU guidelines still recommend penile preserving procedures where possible for T2 disease. It's the NCCN which slightly differs. NCCN says T2 onwards, partial penectomy would be a classically partial penectomy, though considered a penile preserving. Here we would like to differentiate it. So they say T2 onwards, partial penectomy would be a procedure of choice, whereas EAU guidelines still stick to where we get a clear margin, we are still comfortable doing a penile preserving surgery. So there is an entire list of the modalities. Our focus obviously remains on the surgical. The topical therapy is dealt by the dermatologist, lasers by the dermatologists mostly. These are the penile preserving approaches, and the first three is where we focus. Partial penectomy. Glans resurfacing is the procedure where the lesion is localized to the glans. This is a procedure where the entire glans, it can be a partial glans resurfacing or a total glans resurfacing. The lesion is skinned off the glans. It's the skin with the epithelium and the subepithelial tissue which is removed. And you can use a split skin graft which is placed over it. The graft is quilted for a good uptake. So the visual impact of the first image would be, in a clinical scenario, the obvious way out, people would say, go ahead and do a partial penectomy, but these patients are the ones, this is a patient who was managed by a total glans resurfacing, and the outcome is pretty cosmetically and functionally good. The concerns about the oncological outcomes are well addressed. As far as T1A disease goes, the numbers of the patients in the first stage, there were 36 patients. There was a recurrence in 2 of the patients. If you compare this with the recurrences post-partial penectomy, in the longer studies, they're almost the same. So there is nothing that we are losing by doing these procedures. Next would be a glansectomy. This can be done for both the proximal and the distal glandular lesions. You have the option of doing it in 2 ways. One is the resection of the lesion. Once the lesion is resected, the glans distally is resected along with the lesion, and there's a circumcoronal incision with the covering, with the skin brought advanced and a neoglans formed. The other option is just excise the part of the tumor, advance the flap of the skin, and form a flap onto the glans. So this is again a sinister looking lesion. It was managed with a glansectomy. It was the distal glans which was cut. It was the proximal glans which was cut, and the outcomes were fairly good. This is a case which we had done. The patient had, this was a large ulcero-proliferative lesion of 3 months duration. So this is what it looked like after excision. This was the raw area. We had sent a margin from over here, which had come as negative. So we were oncologically sure of our clearance. And this was the tumor when it was excised. This is the post-excision negative margin. And this is the finally intraoperative picture after the skin has been advanced onto the glans. The final biopsy was T1 low grade. Again, the oncological outcomes after glansectomy are fairly good. There are a fair number of series ranging from 70 patients, 40 patients, though relatively small in number. Yes, there's a full cancer-specific survival and hardly any recurrence. So this is something which we had read in the books about Mohs micrographic surgery. The thing is, it's out. It's no more done for at least as a part of the penile preservation approach. It's no more appreciated, neither is it done. Even the dermatologists are giving up on this procedure because the layer by layer resection was so thin that you are ending up leaving tissue. At times, the microscopic pickup of the leftover tumor was not even certain on microscopy. There are enough number of studies which say Mohs micrographic surgery is to be discarded, it's no more in vogue, and it's no more in use. Partial penectomy is a procedure which needs no introduction. We've all done it, we are all aware of it, all the residents do it. So the slide is just to emphasize that when you go into larger numbers, the risk of recurrence definitely remains. Even with partial penectomy, it's not like it's a recurrence-free surgery. What is important is the person who was having a sexual dysfunction of 70%, in these studies, once you have done an organ-sparing surgery, the 70% of the patients ended up having spontaneous rigid erections, and 60% had a normal coital activity. So going from an absence of sexual activity in 60 to 70% to having it in 60 to 70%, that would be a significant achievement for these patients. Again, these are the scores of the quality of life of that the patients. These were the scores before they had the disease, and these were the scores after the disease once the penile preserving procedures were done. So, we are somewhere approaching close to the similar values, which definitely improves all the psychological aspects of the patient's life. So, penile preservation surgeries are definitely worth it. What is important is careful case selection based on the tumor and patient characteristics, and even a minimal margin of 5 mm is associated with oncological safety with good cosmetic and functional outcomes. So the right question is how much to cut. There is no question about cutting, but how much to cut, we've brought it down significantly with fair amount of good results for the patients.
Yes, Kapil, and how much to cut when it comes to somebody's penis, it is really a significant thing.
Correct, that's significantly important.
Thank you so much, and I think this balance talk will help a lot of people to maintain the balance between not violating the oncological principles and preserving a cosmetically and functionally viable organ. That
the only difficulty which we might face is the late presentation that our clinical spectrum of patients have. They wait till it becomes so big that they cannot see it, or probably they have to go on to the doctor.
Very true. Thank you so much, Kapil.
Right.
We look forward to you after this talks for the discussion. For time being, now let us move on to the next talk that is all the way from London. Let me invite Dr. Abhishek Chandna. It's going to be very early morning for him to join us. Over to Dr. Abhishek Chandna. He's going to talk about perioperative therapy in node-positive penile cancers. What are the principles and what are the current evidences?
Good morning, everyone. At the very outset, I would like to thank Urological Society of India and the Youth Organization of USI for providing me with the opportunity to speak at this esteemed platform, and I shall be speaking on perioperative therapy in node-positive penile cancer, principles and evidence. So why is there a need for perioperative therapy in penile cancer? As we all know, the extent of nodal metastasis is the most important factor for affecting survival in patients with penile cancer, and there is a particularly very poor 5-year cancer-specific survival, especially for N3 disease. I shall be discussing in brief about adjuvant chemotherapy, radiotherapy, and neoadjuvant chemotherapy, along with updates on targeted therapies and immunotherapy through the time allotted to me. Drawing inspiration from excellent results of chemotherapy in head and neck cancers, this was the first study demonstrating excellent outcomes as compared to historic 5-year survival of 39%. Thereafter, combination of taxanes and cisplatin became popular with better outcomes seen in these studies, and since then the combination is the standard of care in today's time. This retrospective study by Joshi et al. Looked at the outcomes of 1,123 node-positive penile cancers in the US National Cancer Database. They observed that there was a significantly better outcome in patients undergoing inguinal lymphadenectomy as compared to those not undergoing lymphadenectomy. Addition of chemotherapy did increase the survival slightly, but this failed to reach significance in the study. Nietzsche et al. Through their retrospective multicenter trial of 743 patients, proposed a nomogram predicting survival and introduced the concept of positive lymph node ratio as an important marker in these patients, apart from the stage and age at lymphadenectomy. And patients obviously with higher scores, according to this nomogram, did worse as compared to those with lower scores. Based on the concept of this lymph node ratio, the same group produced and validated a simple risk calculator consisting of positive lymph node ratio, nodal stage, and surgical margin positivity, making use of the same retrospective cohort of patients. And they suggest that patients with more than 19% risk of recurrence in 2 years should be considered for adjuvant chemotherapy, and which falls in the intermediate and high risk patients according to this calculator. The EAU recommends adjuvant chemotherapy for pathologically node N2 and N3 disease, and due to lack of enough data on N1 disease, the EAU does not presently recommend routine use of chemotherapy. It promotes trials for N1 disease. However, wound complications following surgery may delay the initiation of chemotherapy. Advanced age of our patients and their comorbidities often makes them ineligible for chemotherapy. Moreover, heterogeneous chemotherapy regimens followed at various centers, as well as the associated complications and toxicities associated with chemotherapy, limits the use of chemotherapy in our patients. Moving on to adjuvant radiotherapy. The premise for radiotherapy for penile cancer comes from outcomes of radiotherapy in vulvar cancer and head and neck carcinomas. Radiotherapy has also been suggested as a standalone treatment for inguinal lymph nodes, but this particular Indian study from Tata clearly demonstrated benefit of inguinal lymphadenectomy over radiotherapy for N0 and N1 disease. Conventionally, radiotherapy was also considered beneficial for patients with extranodal extension of nodal metastasis, and this retrospective study of 93 patients refuted this concept by showing poorer outcomes for patients with extranodal extension who were treated with radiotherapy as compared to those node positive patients without extranodal spread. Um, the EAU penile cancer panel conducted a systematic review of 7 studies and 1,605 patients only to conclude no role for radiotherapy in adjuvant settings, apart from palliation, which is the present guideline. Neoadjuvant chemotherapy aims at providing early systemic therapy, and it aims at downstaging the tumors to make them operable. Though a lot of studies previously on chemotherapy did have neoadjuvant patients, but this study is the first prospective trial on the same, and they did show that patients who responded to neoadjuvant chemotherapy had a better overall and progression-free survival. They demonstrated a PAT CR of 10% and an overall response rate of 50%. Another multi-central trial, though retrospective, showed a pathologically complete response rate in 17.4% with an objective response rate of 53.2%. And the present guidelines do suggest neoadjuvant chemotherapy for fixed and matted lymph nodes. This flowchart outlines the management of node-positive penile cancer based on EU guidelines. And as you can see, penile cancer still remains a surgical disease, with lymphadenectomy being essential for better outcomes. Most of the existing evidence for penile cancer comes from retrospective studies, and the impact multi-center study is presently ongoing, which is going to answer a lot of our questions which have been raised today. And they will randomize node-positive penile cancers into 3 arms, including neoadjuvant chemotherapy, adjuvant chemotherapy, neoadjuvant chemoradiotherapy patients with high-risk features on inguinal lymphadenectomy will further be randomized into the pelvic arm to receive a lymph node dissection versus adjuvant chemoradiotherapy. And they plan to accrue 400 patients. They have still now recruited 39 patients. And once we have the outcomes of these patients, we will clearly have a lot of answers. One group from Taiwan also used intraarterial chemotherapy, but their results have not been replicated, and they only had 5 patients with node-positive disease. Targeted therapy, as you can see in this diagram, there are a lot of pathways that we can target. Definitely, cetuximab, mTOR inhibitors have been tried. Dacomitinib is another TKI which needs special mention. Was tried in 28 patients, and they had good response in 9 of their patients. Though the progression-free survival and overall survival is less than that we see in chemotherapy patients, it is definitely a drug which we can try in patients who are not suitable for chemotherapy. Immunotherapy is making huge strides, and there are multiple ongoing trials, and I believe we will be seeing the use of immunotherapy for treatment of penile cancer more commonly in the near future. Thank you.
Thank you so much, Abhi. This is an era of multimodality approach, and he has given a detailed, elaborate review on the role of non-surgical modalities to offer the best treatment outcomes to our patients. And we'll come to the questions later. And let me now invite Dr. Gautam Chaudhary, all the way from Jodhpur. He is going to speak on flap necrosis, how to prevent it, and if at all it happens, how to treat that. Over to you, Dr. Chaudhary.
Good morning, everyone. Thank you for the opportunity. My topic is the flap necrosis in inguinal lymph node dissection, how to avoid and treat. I have nothing to disclose. So let me take you to the anatomy of the groin region. So groin skin is primarily supplied by the three branches of the femoral artery. One is the superficial external pudendal, second is the epigastric, superficial epigastric, and third is the superficial circumflex iliac artery. When we see our area of the dissection, so this is our line of dissection. Below to this line, that is the deep to the scarpa fascia, all fibrofatty tissue we remove. So here important to understand that the viability of the flap is totally dependent upon the anastomosis in the superficial most layer of the skin, that is the campus fascia from the adjacent skin. So how to avoid the flap necrosis in the groin dissection? Whenever feasible, we should use the small incision, like in the Catalona dissection, where when it was not necessary to do the standard inguinal lymph node dissection. Dissection in the defined surgical plane, as I mentioned earlier, that we should preserve the campus fascia, where the small anastomosis from the adjacent skin maintain the viability of the flap. And in the literature, it has been described that the blood supply in the groin region travel from the lateral to medial one. So often we should and we do that transverse skin should be preferred over the vertical skin incision. Minimum use of the electrocautery at all, if we need to use, then bipolar should be preferred. Minimum tissue trauma, we all know it may be the cause of the tissue ischemia, and good hemostasis. And duration of the surgery also matters in the term of the tissue ischemia and the necrosis. So too harshly done surgery and very prolonged surgery may be the responsible for the groin flap ischemia. And the tension-free closure, we all know that is very important. So the wound closure should be the tension-free. And at many instances where we should use the flap at the time of the closure of the wound, when we need to remove the part of the skin with the lymph node, or when the extensive lymph node dissection, that is a standard groin dissection, need to do. So that time myocutaneous flap should be used at that time only. And last one is, if the disease is allow us to deal with the minimal invasive mean like laparoscopic or the robotic mean, then video endoscopic inguinal lymph node dissection should be performed. We all know the three main complications of the open groin infection incision. These are the wound infection, seroma formation, and skin necrosis. Skin as necrosis has been described in the tune of 7.5 to 62% in the various literature, and having the various reason for that. So once the skin necrosis happened after the groin dissection, how to deal? So let me discuss one by one. If the vessels are not exposed and no infection in the wound, then the split thickness skin grafting over the full thickness skin grafting is preferred to cover that area. And in some time patient wish to have focus on the cosmesis, then the full thickness graft can be used. Second is when the wound is infected, which is often the scenario, and lot of serious discharge, then the vacuum assisted closure is very useful therapy. It helps in the enhancing the granulation, increase the vascularity, and it also continuously suck the all dead space secretions. Then with the vac we may remove the drain which we placed in the dead space after lymph node dissection. Random flap and the axial isolate flaps are rarely useful to cover this defect. Important here too is that when the defect is large, that is when the femoral vessels are exposed and the flap necrosis which lead to the large area exposed, then we should use the myocutaneous flap. And as I mentioned earlier, these better to use whenever feasible at the time of the primary closure of the wound. But if the flap necrosis happened and we need to cover that area, especially when the femoral vessels are exposed, then there are various flap. Commonly used are the tensor facial lata pedicle flap, anterolateral thigh flap, and vertical rectus abdominis myocutaneous flap, and the gracilis flap with the skin. So tensor facial lata and the anterolateral thigh flaps, they are primarily based on the branches of the femoral artery again, and they need to rotate from the adjacent skin with the muscle. And vertical rectus abdominal myocutaneous flap based on the deep inferior epigastric or the deep superior epigastric artery, also a very useful flap. Sometime we need or we don't see the myocutaneous flap from the adjacent area is not feasible or not possible, then we need to involve the plastic surgeon for the free flap, and these need to anastomosis with the deep inferior epigastric artery often. So advantages of the flap closure, we all know that they protect the femoral vessel. The flap brings well vascularized tissue from the distant area. It covers the dead space and decreases the seroma formation. It helps in the wound closure without tension. Early adjuvant therapy can be instituted, and it shortens the hospital stay too. So in take home message from this presentation is the identification of the right surgical plane, that is the below the scapa fascia, and the extent of the dissection if feasible should limit. If the lymph node disease is not bulky and surgeon is comfortable, then the video endoscoping inguinal lymph node dissection should be preferred choice. And when the disease is bulky, fungating, and post radiotherapy situation, then we need to do extensive lymph node dissection, because that is the curative one also. So, and need not to worry about the skin loss and the necrosis, and that time the primary closure should be done with the myocutaneous flap. After the primary closure, if there is flap necrosis, and then it can be dealt with the skin split skin grafting and the VAC therapy if the vessels are not exposed. So this is one of the photograph where we did the robot assisted wheel, and you can see on the right side how at 1 month interval how very nicely healed the scar and wound. Seroma was persisted for 3 weeks. So thank you once again.
Thank you, Gautam, for giving tips on how to prevent this disastrous complication, and if at all it happens, how to efficiently deal with that. Thank you so much for the talk. Now we have come to the end of the didactic talks, so it will be an interactive session. So I would welcome virtually Dr. Ravi and Dr. Raghunath to join us for the discussion, and I shall welcome Kapil and Amaresh to please join us on the dais. And this session is now open for the questions. Kapil, one question is there from the audience is Mohs micrographic surgery completely obsolete, or still you have some place for it?
I'd gone through the few of the papers. So what they were saying is the layer by layer resection, we tend to thin it out so much that at times it's a difficult procedure to do. And in the end, there were recurrences which were there. If you compare it with the glandsectomy and the other glans resurfacing, the recurrence was slightly higher. And this is not only for penile surgeries, even for dermatological cancers, Mohs has a higher rate of recurrence. So squamous cell carcinoma being a surgically curative disease, I think
so in one word we can say it is obsolete now for any organ. Forget about penis, any organ.
For penile surgery, yes, not the preferred thing.
The house is open. Any questions from the floor, Abhi? Anand, Dr. Ravi and Raghunath are there with us. Yeah, so, hi, Raghu, good morning.
Hi, good morning, good morning.
Yeah.
Very good morning to all of you. I would like to thank USI for this opportunity. Fantastic program, and all the speakers did their best. And I have some comments and shall I comment?
Yes, over to you, Raghu.
Yeah, I would request Ravi to comment later on. All 5 talks were excellent, fantastic, and Dr. Amresh said the very good introduction that lays the foundation for further talks. One thing I would like to mention here is whenever NSGCT, whenever these parameters he mentioned, LVI is there and embryonal carcinoma more than 40% is there, and even proliferative index is more than 70%. For N1 disease, probably better to go for RPLND. Of course, there are other options as well. And when you're contemplating RPLND, if you see Joel Shinfield series, 16% of the times outside the template recurrences are seen. So you should be very careful about that. Whatever the recommendation is there, whatever the templates are there, probably you should look into this. Okay, that's number one. And when I was a student, we used to say less than 3 centimeter for RPLND, and now things are changing. Less than 1 centimeter definitely may not be required, but 1 to 3 centimeter again, lot of discussions are happening. At this point of time, probably radiomics can play a major role, and as Dr. Gagan said, microRNA and radiomics probably can throw some light, even in 1 to 3 centimeter group, when to choose RPLND, when not to choose RPLND, because RPLND is not a simple procedure, particularly in younger individuals, because testicular tumors are common in young people. Nerve sparing may not be possible all the time, and even experts may not be able to preserve 100% of the time. So some morbidity is expected with this, so you can't take this lightly. So when you're contemplating RPLND, definitely you should keep all these things in mind. And when it comes to the third talk by Dr. Kapil, penile preservation surgery, as he mentioned, a lot of psychological issues are there in young individuals. Probably I would suggest all young individuals, psycho-oncologist counseling is very, very important before surgery itself. It is not just for the patient. The couple should get involved in the psycho-oncological counseling. That's very important for them. Otherwise, even suicidal tendencies are very high in this group of patients. When it comes to pathologists commenting on the margins, generally pathologists will take where they suspect, only at that particular site they take the margin and they study frozen section, because they have to give within 5 to 10 minutes. So they take only that margin. We have seen this happening. The final report comes as positive. So we should talk to them. Even if you spend a little extra time, you're not going to waste anything. Request them to give proper margin report. Otherwise, you have to revisit again and do further partial penectomy or whatever. Right? That's very important point to note. And when it comes to the fourth talk by Dr. Abhishek, perioperative therapy for N+ disease, he did a good talk, and but some contradicting points are there. EAU do not recommend radiotherapy. It is still experimental for even N3 disease or N2 disease. It is still experimental, but there is some palliative role is there. But NCCN recommends adjuvant radiotherapy. Neoadjuvant radiotherapy, he commented, probably it is not there in the guidelines. So these points you should note. And coming to the last talk, how to prevent flap necrosis, and he alluded all the points. The most important point is video endoscopic inguinal lymphadenectomy. If you do video endoscopic inguinal lymphadenectomy, virtually you don't see flap necrosis. But when to do video endoscopic inguinal lymphadenectomy, it is a simple procedure actually. If you can understand the anatomy of the femoral triangle, you can do it. You don't need a great armamentarium. The basic laparoscopic instruments are enough, and basic skill set is good enough. Understanding of the anatomy and going through the proper planes is very important. So I would recommend, I would request all youngsters or everyone to learn video endoscopic inguinal lymphadenectomy, because virtually you don't see flap necrosis. And he also enumerated a lot of other surgical principles to avoid the flap necrosis. Whatever you do with open surgery, however expert you are, how many even hundreds of surgeries you have done, flap necrosis you will see in some group of patients. So with this, I thank you once again. Thanks for this opportunity. I request Dr. Ravi to comment on the talks. Thank you.
Thank you, Dr. Raghunath. And first of all, it's congratulations to you for this wonderful session, because all these 5 speakers have done such a perfect job. I don't think even I would have done that well. So fantastic. And 3 of them actually our prodigy, and I'm very proud of them. Dr. Raghu has already covered all the expert comments. I just want you to, in testicular cancer, as since it's a youth forum and you're going to be the future of our country and the entire thing. So I would like you to look out for MIR 375 and 371. These are the 2 microRNAs in testicular cancer which are likely to make a strong stride in future. So just look out for that, and probably in eventual meetings we would have more discussions on that. Kapil gave a very good insight on how to do a penile preservation, and I think one has to, the major problem, as he also highlighted, is early detection, and probably some movement has to be done towards that. Like breast self-examination, we have to teach our male population that yes, they should also come early, and so that we can actually do penile preservation. Abhishek, congrats to you, and yes, we look forward for that impact trial, because that's going to tell us exactly, because in testicular cancer and penile cancer, largely things have not changed over last 30 years. It is more or less monotonous, except for this few ifs and buts which are coming up, and you guys have really picked it up well. Gautam, yes, I think as Dr. Raghu said, wheel should be the future. But one small message here, he said a smaller incision. I would say if you have a bigger mass, take a bigger incision, because if you do a bigger mass from a smaller incision, lymph node dissection, you would end up with more necrosis. So that is one thing. Otherwise, wheel is the only answer. And thank you once again. I hand it over to Aditya and Joshi.
Yeah, thank you, Ravi, and thank you, Raghunath, for sparing your valuable time and giving these expert comments. And I thank all the speakers for the job which they have done, and especially to Amresh and Kapil. They have been in person. And I take this opportunity to welcome few of our seniors, Dr. Shroff sir, Dr. Anil Bradu, and Dr. Ajay Kumar sir. So, sir, we would take this opportunity to welcome you. Anand, we need to have a few words of encouragement from Dr. Ajay Kumar sir. So please, let us have the opportunity to listen to him. Please. Sir, we missed out on you while inauguration was going on, so we need a few words of encouragement from you, sir, as always.
Well, I thought I have to speak after the lunch.
Yes, sir.
And tell you what should be the quality of a leader. The quality of a leader is that when their session is going on, they will sit in the corner there and gossip so much that they disturb the whole hall. Mr. President, sir, I have been requested by the chair to say a few words.
Yes, sir.
I said I have to speak in the afternoon anyway.
You can
on
still speak some
qualities
words,
of a
sir.
leader. And what is the quality of a leader? Look at those leaders sitting in the corner. And they are gossiping and disturbing the whole hall.
That is the leader.
If they have to, they should go outside and talk.
Sir,
well, this is my message. Thank you.
Yes. Thank you, sir. Your point is well taken. Thank you, Kapil.
Sir,
thank you, Mohan.
sir.
Yeah, over to Dr. Adi.
Thank you, everyone. We quickly move on to the next segment of this session, and that's a debate session, a very interesting session. We have a 24-year-old gentleman with stage 1 and non-seminomatous germ cell tumor. He has walked into the clinic. He is very apprehensive, and he does not want surveillance as an answer. He has seek consultation both from Delhi and from Mumbai. From Delhi, Dr. Jiten Jaipuria has offered him chemotherapy, while Dr. Ashwin has offered him retroperitoneal lymph node dissection. Let's listen to both of them and then decide. And the experts will be there for this session, and we'll have the comment after this. So first we have Dr. Jiten Jaipuria from Delhi.
Good evening and greetings from RGCI. Today I will deliberate on chemotherapy as a treatment option for a 24-year-old male with stage 1 NSBCT with PT2 and LVI positivity not filling for surveillance. These are my conflicts of interest. My aim today is to not score a win but explain my perspective so that we can make a more informed choice. We know that every treatment modality has its pros and cons. However, sometimes thinking objectively can help us make better decisions. So before we start, I want you to picturize the benefits of RPLND in your mind and answer this question. Overall, in terms of all possible negative outcomes, how much do you think chemotherapy is worse than surgery for CS1 and SGCT? Think of a number and hold that thought till the end of the talk. So let's dissect the evidence. Our patient is CS1, PT2, LVI plus, no comment on histology or baseline fertility, and not willing for surveillance. So the key concepts are that patients with stage 1 NSGCT often harbor micrometastatic disease and no imaging modality can reliably detect them. Micromets can be present with normal tumor markers. However, if there is teratoma in the primary specimen, then primary RPLND should be prioritized. And if tumor markers are raised 4 weeks after orchidectomy, then chemotherapy should be the preferred treatment. Hence, for academic discussion, I am assuming our patient does not have teratoma in the primary and has normal baseline tumor markers after orchidectomy. So we understand that the probability of micromets in CS1 NSGCT depends on risk factors such as LVI and embryonal histology, and there is a 41 to 77% chance that our patient harbors micrometastatic disease. Surveillance in the presence of LVI positivity actually carries a high risk of recurrence, and since our patient doesn't want it, the options are RPLND, nurse sparing, or a single cycle BEP. So as per the latest systematic review, all 3 treatment modalities have 100% cancer-specific survival. However, for CS1 and SGCT, the median recurrence rates are 3.3% for chemotherapy versus 11.1% for RPLND. When we try to reduce the morbidity of RPLND by modifying the resection template, then the risk of extra template disease actually increases and can reach 23%. We do not have level 1 evidence yet about the ideal limits of dissection. Now, importantly, if viable malignancy is found after RPLND, then we would need to give 2 to 3 cycles of chemo, and there is a 30 to 50% chance of that happening in our patient. So now let's objectively compare RPLND and chemo. Let's label the toxicity due to 1 cycle of chemo as C and that due to RPLND as R. Let's imagine that we have 2 groups of 100 patients each, similar to the case that we have. Now the overall toxicity suffered by 100 patients in the RPLND cohort, assuming 40% patients having viable malignancy needing 2 cycles of adjuvant chemo, will be 100 R plus 80 C. The overall toxicity suffered by 100 patients in the chemo cohort, assuming 3% recurrence rate needing salvage RPLND, will be 100 C plus 3 R. So for RPLND arm to prove superior, the toxicity in the chemo cohort has to be higher than toxicity in the RPLND cohort. And after a little bit of maths, you can easily see that RPLND will only prove superior if toxicity of a single cycle chemo is 385% higher than RPLND. So does this figure match your expectations? Let's look at the true toxicity of a single cycle BEP chemo. We now have long-term data of patients given 1 cycle chemo for NSGCT, and in one such study with 40 patients, the only long-term toxicity directly attributable to treatment was 3 patients reporting intermittent tinnitus. In fact, systematic review proves that secondary malignancies after treatment for early stage GCTs is similar between chemo and RPLND, and incidence of 0.9 versus 1%. Meanwhile, in reality, the feasibility and logistics of offering primary RPLND are much worse. Most residency training programs in India do not have adequate exposure to RPLND, and there are only a handful of surgeons, doing open nerve sparing primary RPLND. And even fewer are familiar with the laparoscopic approach. And though at RGCI we have the largest reported experience with post-chemotherapy robotic RPLND, but the learning curve of robotic RPLND is estimated to be 44 plus cases, and presently no single surgeon in the world has reported such a large experience. So this real world inadequacy with the delivery of quality RPLND actually got proved in a nationwide RCT comparing chemo to primary RPLND in Germany, where RPLND arm was found to have significantly lower recurrence-free survival. In fact, the percentage relapse rates following primary RPLND vary widely from 6 to 34%, highlighting the importance of institutional experience and expertise. However, primary RPLND does have a unique role in patients with teratoma having malignant transformation, where chemotherapy has lower overall survival. In summary, RPLND has many issues lowering its potential. Firstly, while quality RPLND can only be delivered by top 1% surgeons, chemotherapy can be widely administered. Secondly, chemotherapy has the lowest recurrence rates, and in a country where patients do not follow up, offering primary RPLND with higher chances of recurrence can be risky. And a nationwide RCT proves that as a general approach, chemotherapy is better. Lastly, according to recent data of toxicity, chemotherapy toxicity is definitely not 4.8 times greater than that of RPLND. So the mathematics for RPLND does not really work out. Finally, the whole confusion arises because presently we lack better ways to find out those with residual microscopic disease, and microRNAs are proving better than conventional markers to detect metastasis and can even discriminate teratoma from viable disease. So the future is definitely promising. Thank you so much. I'll be happy to take questions.
Thank you, Dr. Jitain. Now we move to Dr. Ashwin. It's a difficult task for him to defend RPLND. Over to Dr. Ashwin now.
Good morning, everyone. Thank you, USI, for this opportunity. I'm going to debate about RPLND in favor of RPLND for high-risk NHGCTs clinical stage 1. All of us know that lymphovascular invasion and EC presence are the risk factors in addition to pathological T2 stage. My disclaimer slide is that probably as per the AU guidelines, we all know that the chemotherapy is considered to be the first choice, and RPLND, the role of RPLND, which is explored in these particular patients, is very limited now, but I have certain points in favor of RPLND, which I'll be mentioning now. Pathological upstaging happens for 30% of these RPLND candidates, so they are transferred from stage 1 clinical to pathological clinical stage 2. So they are the ones who deserve more therapy, obviously. If we are empirically giving upfront 1 BEP for these patients, probably we are undertreating them because they need 2 cycles of BEP after completion of RPLND because of virtue of having positive nodes. So 1 surgery followed by 2 BEP versus 1 BEP empirically definitely an undertreatment for these 30% patients. In RPLND, in high volume centers, all of us know that retroperitoneal recurrences are very less. Majority of the Swedish, German trials have mentioned good, excellent clinical outcomes or oncological outcomes in long-term follow-up for these patients. Similarly, Italian data mentions 85% of the patients do not require anything else apart from RPLND for these patients, with late relapses being only 1.2%. So systemic relapses do happen with RPLND, we know that, but the tune is up to maximum of 10%. But they are the candidates who would need subsequent 3 cycles of BP, and they are chemo naive, and they are the ones who deserve the therapy to the best possible strategy. Systemic relapses also happen with 1 cycle of PEP. They are about 3.2%, and they are the ones who have aggressive biology. Unfortunately, these candidates would be more elected for salvage chemotherapy than standard BP regimen, because 1 or 2 cycles of BP have already been given to them as a prophylaxis. So without suitably utilizing first line to the adequate capacity, meaning BP 3 cycles or 4 cycles to the adequate capacity, and subjecting them for salvage chemotherapy probably is not a very justifiable option in my opinion. And instead, RPLND followed by 3 BEP for systemic recurrence would be a better favorable option in terms of keeping 1 valid option or 1 line of defense in reserve for these patients who actually need therapy in long run. Atypical histologies, obviously we know radio-resistant and chemo-resistance happen with teratomas. Nearly 16% concordance with having retroperitoneal pathology of with teratoma if you have a teratoma in the testicle. Peanut tumors, rhabdomyosarcomas also are similar on the similar lines, and malignant gonadal stromal tumors. They have a high possibility of nearly 37% turning out to be node positive. The only randomized trial comparing RPLND versus 1 BP, obviously, because of this trial, 1 BP came into picture and more robust role was described because of the recurrence rates. However, I would like to mention toxicities here. More than 3 grade 3 toxicities are happening to the tune of 37.4% with only 1 BP regimen. Cumulative toxicity of RPLND with possibly 2 BEPs for those who have positive nodes is about 8.7%. So massive difference. Long-term sequelae of BEP, all of us know, obviously there is a clear dose-response relationship. However, we are giving 1 or 2 cycles of BEP already to these patients to start with or to initiate these consequences. So pulmonary toxicity, fertility issues, neurotoxicity, nephrotoxicity, metabolic syndrome, and hypogonadism. Long-term risk of second malignant neoplasm, especially cardiac rhabdomyosarcomas, thyroid and kidney cancers. These are potential problems. So those patients, as per the Italian data, where we do not need anything beyond for 85% of those patients who are fine with RPLND, probably we are unnecessarily subjecting these individuals for some sequelae. Follow-up strategies, if we say probably 100 patients each in 3 arms, to understand how many chemotherapy units will be required for upfront plus for recurrences and relapses, RPLND will be possibly the least, 90 for including the relapses, or as compared to 1 BEP where there will be like 109 units of chemotherapy required, against to surveillance will be there will be like 150 based on the recurrence rates. So least possible chemotherapy units required for RPLND arm. Follow-up for NHGCT is not going to be very stringent after 2 years, because majority of these are happening, majority of the recurrences are going to happen within 2 years, and doesn't make a difference between RPLND and a BEP as such. Minimal invasive surgery, laparoscopic surgery, with enough long-term data now from 2 main centers, laparoscopic RPLND is a good option for staging these particular patients as compared to open approach with similar relapse rates and similar disease-free survivals. Antegrade ejaculations with good nerve spare, which is possible in this particular setting, is beyond 90%, which is described. However, there is no hypogonadism, no deterioration of sperm quality, which is already compromised in testicular cancer patients because of chemotherapy in these RPLND arms. Going forward, probably microscopic RNAs or MIB index, these are the molecular markers which are also coming up in a big way for testicular cancer now, and they would identify actual wolf in a sheep's cloth, and they would be the candidates for chemotherapy over RPLND in my opinion. One quick thing as a data coming from SGCTs, the seminomas in early stage 2A and 2B stage, where there is a potential of surgery, and it is already presented in ASCO, and prime test trial is recruiting after the interim analysis with a favorable results, meaning they are exploring the surgical role for early stage seminomatous disease. Then why are we running away from NSGCTs, where it was a established modality of treatment for years together, or decades together, I should say. That's my.
Thank you, Dr. Ashwin. Now we move to back to Dr. Jiten for his rebuttal. Stick to 1 minute of rebuttal, sir, please.
So thank you. So it is important to understand that surgery was always there for testicular cancer, but the sentinel event that improved survival in the 70s was actually a discovery of multi-agent chemotherapy by Einhorn and Donohue, and it still continues to improve mainly due to that. So as a standalone modalities, testicular cancer, the role of surgery is only in when you have disease limited to the testis and low volume retroperitoneum. Beyond that, chemo has to be part of the plan. In fact, surgery does not accurately stage disease. Even in best of situations, you will need to give chemo in 20% cases post RPLND, because disease will actually be failing in the lungs, provided you did a good job in the retroperitoneum. Otherwise, it will fail there also. So the long-term toxicity of single cycle BEP is minimal actually, and acute toxicity is actually 30% plus, which is mainly leukopenia needing Graphyl and vomiting needing ondansetron, which is actually parallel surgery in terms of morbidity to the patients. So the long-term risk of secondary malignant neoplasms after single cycle chemo is a myth. Please do away with it. It is the same as surgery if you look at data overall. Lastly, I am a surgeon and I wish to stand on the other side of the debate, but we must understand that, a scalpel may not be a treatment for disease pathology and patient physiology always. Thank you.
Can we have the recorded version?
Yeah, we'll have the rebuttal from Dr. Ashwin.
Last slide or the rebuttal slide, I'm just trying to put some figures and possible options in front of each other for RPLND and chemotherapy arm. RPLND gives us opportunity for accurate staging. So pathological stage is in our hand against only clinical for chemotherapy. 30% risk of upstaging to clinical stage 2 with these are the candidates who need 2 cycles of BEP. Against this chemotherapy, there is a possible undertreatment by giving only 1 BEP for these patients. 10% systemic relapses, and they are chemo naive, and hence 3 cycles of BEP would be given for cure. And they are the candidates who will be identified who deserve the treatment the most. Against this 3% systemic relapses, majority of these would be on second line chemotherapy because they will be early relapses, or they were already taken 1 or 2 cycles of BEP. One additional point here is majority of the medical oncologists in India are still practicing 2 BEP and not 1 BEP. RPLND avoids chemotherapy in at least 70, maybe up to 85%. Chemotherapy, all patients would need 1 or 2 cycles of chemotherapy, so we are over treating other individuals. Our typical histology obviously goes in favor of RPLND. With MIS, laparoscopy, and eventually, once we have the robust data from robotic surgeries, will have minimal morbidity on RPLND arm against acute systemic toxicity by chemotherapy, which is beyond grade 3 up to 37%. Again, long-term toxicity in surgical arm is minimal against this potential sustained long-term potential side effects of chemotherapy, which are going to be staying with the patient throughout, are responsible for survivorship issues. No risk of second malignant neoplasm, significant risk of second malignant neoplasm, which is a described entity now. Fertility, antegrade ejaculations, and fair rates of which are fair possibility with no spare without any compromise in the quality of spermatogenesis by virtue of a therapy against to quality of spermatogenesis going down with negative impact in addition to hypogonadism happening with chemotherapy. And last important point is probably if we are going to give chemotherapy for all these patients, we are slowly going to unlearn the art of nerve sparing RPLND, I should say. Because if you're not going to train our fellows for nerve sparing RPLND, we can't expect them to have or can't expect them to be doing post chemotherapy RPLNDs. So that has to be there as a standard of practice in teaching institutes. And I rest my case here in favor of RPLND. Thank you so much.
Thank you so much, Dr. Jiten and Dr. Ashwin, for those wonderful points. And we all have encountered patients who are perturbed with the oncology control, recurrence rates, fertility control, and retreatments. So we move on to our experts. I'll request Dr. Raghunath and Dr. Ravi to put an end to this debate and enlighten us.
Thank you. Thank you, Dr. Jiten and Dr. Ashwin. Great debate. I thoroughly enjoyed this debate. One thing, patient parameters are very important, whether he's married, whether he's completed his family or not. These things should be considered. Both the debaters did justice to their talk. In fact, ideally, we should these two debates should be there in front of the patient in the MDT, and we allow the patient to choose. I think that is the right way. That is personalized medicine. So I assume this should happen in front of the patient in the MDT. We should understand that long-term toxicity, because he's just 24, he's going to live for another 60 plus years. So long-term toxicity, as both of them said, the second malignancy, pulmonary toxicity, metabolic syndromes, infertility, all those issues should be kept in your mind. And when it comes to adverse effects of RPLND, experience of the surgeon is very important. As Dr. Ashwin said, whether you're offering nerve sparing or not. So these two parameters are very important before contemplating RPLND. So both of you did a fantastic job. I appreciate you and I congratulate you both for this. Thank you, and over to Dr. Ravi.
Thank you, Dr. Raghunath. And I'm actually confused, even being on the other side, to give a kind of verdict. But you guys did such a fantastic job. But to my mind, I think I have to lean towards Jiten, not because he did better than you in respect to talk, but it is because the evidence is in favor of him, more in favor of him at this point of time. As we all know that RPLND per se is a difficult surgery to master, and unless we are there with nerve sparing techniques that we can give equivalent results, we are right now, we have to lean towards that single cycle chemotherapy because it is not that toxic as been potentially shown for second malignancies and other stuff. Having said that, I agree with your comment that we have to train our residents also. So in a situation, as Dr. Raghunath put it very nicely, that in a situation where patient has this to decide whether he is going to or not. So that's where we should evolve towards. Thank you.
Thank you, both the speakers and the experts. And we'll move on to the next session, the video session. It's a very interesting session. So first we have robotic retroperitoneal lymph node dissection tips and tricks from Dr. Amitabh Singh, all the way from RGCI, Delhi.
Good morning, everyone. I'm thankful to organizers of USI Youth Conclave 2021 for giving me this opportunity to present tips and tricks of robotic RPLND. Robotic RPLND has many challenges like working on major abdominal vessels throughout the procedure, working in close proximity to bilateral renal hilum and bilateral ureters. But the biggest challenge is desmoplastic reaction after chemotherapy, which makes tissue plane difficult to identify and dissect. Severe desmoplastic reaction is again a major reason behind conversion to open RPLND. Another issue is low number of procedures, which make it difficult to overcome the learning curve of procedure. We have done 37 cases of robotic RP-LND over last 10 years in post-chemotherapy residual masses, which is the largest single center experience till date. Over the next few minutes, I am going to share tips and tricks of robotic RP-LND that we have learned over past 10 years. We always use transperitoneal approach as it provides larger working space and similar anatomical details as open RP-LND. Initially, I did RP-LND in flying position, but now using supine position as it gives a better access to both sides of retroperitoneum in same docking. In SI and X, I dock robot from right shoulder of the patient, whereas XI robot is docked from left side of the patient. It is always better, rather mandatory, to have experience of open RP-LND before robotic RP-LND, and always try to start with 3 to 5 centimeter of lymph nodes at 1 or 2 involved site only. This 16-year-old boy had left testicular tumor. After 3 cycles of BEP, he had residual 3 centimeter para-aortic and inter-aortocaval lymph node. Patient underwent transperitoneal robotic RP-LND with SISD robotic platform. Ports were placed in curvy linear line between umbilicus and pubic symphysis. Patient was kept in steep Trendelenburg, and a robot was docked behind right shoulder of the patient. Patient right shoulder was turned down to retract small bowel in right upper quadrant of the abdomen. After having orientation of abdomen, root of small bowel mesentery was incised from ileocecal junction to DJ flexure. Peritoneum of mesentery can be stitched to anterior abdominal wall on both sides for better retraction of small bowel and exposure of retroperitoneum. Upper boundary of retroperitoneal exposure was left renal vein. Lateral boundaries were ureters on both sides, and lower boundary of exposure was bifurcation of common iliac artery. Always start dissection where desmoplastic reaction is least, usually opposite to affected testicular site. As in this case, I started dissection on right side of the retroperitoneum. Take extra care for right ureters and a right gonadal vein during paracaval node dissection. Pre and paracaval nodal dissection was followed by inter-aortocaval node dissection. Careful attention is required at lateral side of inter-aortocaval space for lumbar vein and artery. Clipping of lymphatics before transection is necessary to prevent chylous ascites. Identification of lumbar nerve is in inter-aortocaval space is sometimes difficult due to desmoplastic reaction. At upper limit of inter-aortocaval space, careful dissection is warranted to prevent injury of right renal artery, which is mostly found beneath left renal vein. Dissection of non or least desmoplastic will expose greater vessel and facilitate further dissection. To ease the para-aortic nodal dissection, inferior mesenteric artery and inferior mesenteric vein can be ligated and cut to release mesentery in the difficult cases. All attempts should be made to identify sympathetic trunk, which runs on medial border of psoas muscle and lateral to para-aortic lymph node. But desmoplastic reaction makes sometimes difficult to identify them. Identification of left ureter and psoas muscle helps further dissection. Careful dissection is again required at upper boundary of para-aortic lymph node to prevent injury of left renal artery, junction of left renal vein to left gonadal vein, and left renal pelvis. Liberal clipping of lymphatics is needed before cutting to prevent chyloscystitis, as these are the most important culprit in most cases in chyloscystitis. Para-aortic nodes were dissected till common iliac artery with preservation of inferior mesenteric artery in this case. After finishing nodal dissection, a resection of left gonadal vein was done till deep ring. You might need to redock a robot again in same position to facilitate dissection of gonadal vein up to deep ring. At the end of procedure, complete hemostasis was again confirmed. Hemostatic agents can be handy. And procedure was finished after putting drain in retroperitoneum. Console time was 150 minutes with total blood loss of 50 ml. Patient has chylous drain output after oral diet on post-op day 2, which was managed conservatively with fat-free diet, and final histopathology was teratoma. I published experience of robotic RPLND in post-chemotherapy residual mass of 13 patients from our center in 2017. We could preserve antegrade ejaculation in 84% of the cases with no recurrence reported during 23 months of the median follow. Thanks for patience hearing.
Thank you so much, Dr. Amitabh. That was a visual treat to watch. Now we move to the last talk of this session, and it's the, let's say we saved best for the last. We have video endoscopic ilo-inguinal lymphadenectomy from Dr. Tarun Jindal from TMC Kolkata.
A very good morning to all. I'm Dr. Tarun from Tata Medical Center, Calcutta, and I'll be discussing our technique of video endoscopic inguinal lymph node dissection. The video endoscopic inguinal lymph node dissection is a common surgery which is being performed for management of diseases like carcinoma penis, vulva, lower limb melanomas, total tumors, etc. The conventional open technique is a highly morbid procedure, and it is associated with at least 30% risk of morbidity, the most common being the flap-associated morbidities. Anybody who has done or been a part of this particular surgery can vividly remember these grotesque images. These patients take n number of days to completely heal, and lots of dressings, lots of effort go, and lots of problems happen during the healing of the open wounds, which are as a result of conventional open groin dissections. So how do we do a minimally invasive video endoscopic inguinal lymph node dissection? Mind you, we do not use the conventional technique. The technique which I'm going to describe is called the lateral veil. So for that lateral veil, what we do is we position the patient like this so that the knees are flexed and the hips are abducted. We catheterize him. We put in a few surface markings. This is on the medial border of sartorius. This is the medial border of the adductor longus. And this is a tangent which represents the femoral vessels. To create the space, we use a very simple contraption, which is a 14 French endotracheal suction tube over which we use the glove finger. And this is a very simple assembly, and you can actually avoid using the costly PDB balloon. This will cost approximately 15 rupees to the patient. So for the veil, the multiple planes which are described. So some people tend to work between the lymph nodal tissue and put the lymph nodal tissue down. But what we use to, the space which we use is the space just above the fascia lata, that is the deep fascia of the thigh. And we tend to put the entire lymph node packet on the roof. So the first structures that we encounter in our dissections are the vessels. This is how we create a space. We give an incision on the site of the camera port, identify the glistening deep fascia, and inflate the balloon. With saline, you can inflate the balloon to approximately 150 to 200 cc's comfortably. There is no risk of rupture. And we tend to push the balloon to other places so that the entire space opens up for us. This is the port positioning of a conventional veil. So in a conventional veil, the camera port is in the midline and there are two working ports on the sideways. But this is the port position of a lateral veil. So what we do is drop a tangent from the anterior superior iliac spine vertically down up to the knee. And on this tangent superior, just around 2.5 centimeters or 3 centimeters from the ASIS, we put in the left arm port, which is a 5 millimeter port. On this line itself, around 5 centimeters down, we put in the camera port, which we use a 10 or a 12 millimeter port. And just off the tangent, we put in the working port, which is the right-hand port for the surgeon. If you are using a robotic platform, this is how you dock the robot for a conventional veil. But if you want to use it for the lateral veil, this is docked slightly more down. So this is how we do the laparoscopic veil. On the floor, you can see that this is the fascia covering the sartorius muscle. And we are slowly progressing to the medial aspect of the thigh, and in a while you'll see the adductor longus coming into picture. So that's the adductor longus right there. So what I've observed that if you use hook or ligashore, the smoke generation is minimal and the vision doesn't get bad. If you have air seal, nothing good better than that. But harmonic is a problematic instrument in this space because it creates the snowflake appearance inside this and makes the vision very difficult. So we proceed from the apex of the femoral triangle towards the inguinal ligament and we start seeing the vessels. Here you can see the femoral artery being dissected out completely, and just medial to the artery you'll see the femoral vein. So once we have identified both these vital structures, we tend to clean them up by using a ligashore or a hook. And in a while, you'll see this structure is the saphenofemoral junction. So we tend to clean this again, and you can use clips, you can use staplers, you can use even a ligashore, whatever you want to divide the saphenofemoral junction. Once the saphenofemoral junction is divided, we move towards the inguinal ligament again. If you want to harvest the deep nodal tissue, this is the area where you can harvest the deep nodal tissue. You can see now we are completely in the process of removing the deep fat and the lymphatic area, which is medial and anterior to the femoral vein. That's the inguinal ligament coming into picture. And once you are done with it, then the entire lymph nodal packet, which is on the roof, is brought down. So it is very important now that you identify the correct plane between the campus and the scarpa fascia. And can you see this flimsy adventitial tissue between the campus and the scarpa fascia? If you can identify this tissue, just keep on working into this tissue and you would never face any kind of flap necrosis. The entire fibrofatty lymphatic tissue is brought down by working into this space and is delivered out. This is the video of a robotic veil. The robotic veil gives a certain advantage over the laparoscopic veil because of the dexterity of the instruments. The technique remains the same. So on the floor, you see the sartorius. We are working towards the adductor longus. This is a lymphatic which is being charred by the use of bipolar. You can see the great saphenous vein coming into view now. So all the fibrofatty tissue and the lymphatic tissue surrounding the saphenous vein is completely mobilized so that you can see the entire saphenous vein. So this is the advantage of a lateral veil, that you can see the vein in its entirety. The instruments will never clash. The camera person will never have a problem assisting you. In robotic platform, again, the instruments will never clash. So all the branches of the saphenous vein are isolated. You can either use a bipolar or you can use clips on them and divide. The rest of the technique is exactly the same. So now the saphenous vein and the saphenofemoral junction is brought down. You can see the femoral artery here, the femoral vein is out there. This is how the specimen looks. And this is the post-operative picture. You can never have a better gratifying picture for this particular surgery. So our surgical experience, the lymph node yield is approximately similar to open surgery. We have 7 to 8 lymph nodes on each side if by using this lateral veil. Early discharge is possible. The average hospital stays approximately 2 days. The average operating time is 100 minutes on each side. We have never had a flap necrosis. We had performed the first ever robotic veil by the lateral approach 2 years back. The lateral veil has extreme advantages over the conventional veil, which I've already discussed. But if somebody is interested in getting into more details, we have just published an article which covers the technique of lateral veil and the advantages over the conventional technique. Thank you so much for your patient listening, and good luck for the further program.
Thank you so much, Dr. Tarun, for that wonderful presentation. Before we move to the experts, I request anybody from the floor to have any questions or quick comment. Everybody was glued to the screen during this video session, actually. Rajiv sir, any quick comment? Dr. Abhishek, yeah.
So I have a question to Dr. Amitabh. So Dr. Amitabh, what is your experience with the management of chylosositis? Do they settle down and what is the duration? And have you got any experience of using octreotide, or have your patients actually required parenteral nutrition?
Dr. Amitabh, you are muted.
Can you hear me?
Yes, please.
Yes, sir. So we tried everything actually, from the conservative management to lymphangiography, both. So initially, like suppose after operation, patient is having chylous brain output. So we just keep them on the fat-free diet. If suppose on fat-free diet it's not responding, then we'll keep the patient NPO when we have experience of giving octreotide also. So few patients responded to the octreotide and NPO and parenteral nutrition also. We have experience of giving this lymphangiography in poor patient actually. Before coming to this institution, I joined this institution in 2015 in January, I think. Before that, sir had experience of opening one patient for this chylosositis also. So I think we have almost each and every experience of doing the procedures to control the chylosositis.
So what would your advice be for somebody who's seeing chylosositis for the first time?
So initially, sir, we all just keep the patient in like on the fat-free diet. If they do not respond or chylous brain output is like very high, like more than 300, 400, 500, then we just keep them NPO for 1 or 2 days. We start total parenteral nutrition. We start octreotide also, and we keep the drain. Actually, we don't remove the drain on day 1 actually, because there are some practice the surgeons are following where they remove the drain on post-op day 1. So we keep the drain unless we start the patient on oral nutrition, just to check it out whether he is having chylous output or not. So once the patient is having chylous output, then we manage them accordingly depending on their output and whether they are responding to the conservative management or not. And if they not respond to all type of conservative management for like 10 or 15 days, then we just take consultation of our intervention radiologist. We do lymphangiography by lipidol, and they screws also with this lipidol, leaking lymphatics.
Thank you, Dr. Amitabh. Congratulations on your wonderful work.
Thank you, sir.
Thank you so much, Abhishek. I'll now invite the experts for a quick comment on both the videos. And both of you have transitioned from open to robotic or a minimally invasive. A quick comment on that also, especially for the youth who want to take up these surgeries.
Yeah,
should I start first?
Both videos were excellent. I have only 1 or 2 comments for the robotic, RPLND. Surgeon must have adequate experience in open surgery. That's very, very important. And surgeon should have done at least more than 10, 15 open RPLNDs, and you should have done at least 50 to 100 robotic, any other surgeries, robotic uro-oncological surgeries, before venturing into robotic RPLND, that too post chemotherapy. And it's not just surgeon's experience, even you should have a good assistant. That's very important, because you'll be handling around the major vessels. In case of bleed, the bleed is usually massive. So you should be able to respond to that and react to that in a swift manner. So you should have a good assistant. And I congratulate Dr. Amitabh for this best video. And when it comes to video endoscopic inguinal lymphadenectomy by Tarun Jindal, again, excellent. He described both the pros and cons of both conventional veil and lateral veil. I agree with Tarun that lateral veil, the clash will be minimal. Otherwise, clash is more with the conventional veil. That too, around the knee joint, your instruments will be clashing. Otherwise, the outcomes are same with both. I have one question to Dr. Tarun. How are you going to handle the lymphoria? How long you will be expecting lymphoria, and what are any technique to prevent or reduce the lymphoria duration?
So, I mean, the lymphoria will be exactly the same. So, I have tried using ligashore. I mean, majority of my lymphatics are charged by using ligashore. The difference of the drain output is never there. So, use bipolar, use ligashore, use clips. Lymphoria, if it's supposed to happen, it will happen. You have no way to reduce that. I do not believe in using stockings. We have tried using stockings also. We have tried using compressions. I mean, something work for one patient, in the other patient it will not work. So lymphorias will take their own time. So we counsel the patients that you might need to go back on drains. The drains will definitely come down, and that's what we do. Nothing special.
Yeah, you're absolutely. We also tried a lot of maneuvers to reduce the lymphoria. In fact, by removing the stockings early, that's one way of reducing the lymphoria.
Yes, we have stopped using stockings completely.
Yeah, once they stop developing lymphedema, that time the lymph output will come down. So thank you for excellent videos. Thank you USI for this opportunity, and thank you. And over to Dr. Ravi. Thank you once again.
Thank you, Dr. I think let's first have the comments from Amitabh about the question which Dr. Adi had put to them. Then I can speak upon it. Amitabh, please.
Sir, I can't hear you.
Ravi,
I didn't hear you, sir.
Dr. Adi had put a question about transitioning from open to robotics.
Ravi, your voice is breaking, so can you just temporarily stop your video so that the bandwidth can be used less?
Hello.
Yeah, audible.
Yes, Dr. Ravi, your voice is breaking actually, the internet.
Yeah, I think, fair enough. So my comment was, congratulations to both of you for the excellent video. I wanted you guys to comment upon Aditya's question about transiting from open to robotics.
Ravi, your voice is breaking, so I think we'll take the question in the next sessions. Yeah. So with that, we come to the end of this oncology session, and we have introduced a new thing, a new flair in this second edition of Youth Conclave. That is a star talk. So let me invite one star to welcome a superstar.
Thank you, Rohit and Aditya, for having this first session. It went on very well. I would not waste much time. And we have this out-of-the-box talks to break the monotony of urology. And we have none other than our President, Sir, Mallikarjun, Sir, to deliver this talk on corporatization of medical services, future of urology consultants. So I invite Malik, Sir, to give the talk.
Thank you, Dilip. And well, it's great till now, and fantastic videos we saw. It is very nice. But anyway, the present talk today is on corporatization of health services and the future of urologists. This is a thing which has been discussed, and we have been looking into it last 10 years, what is happening into the society, and we see that people are getting frustrated with the corporatized sector, and their frustrations are expressed in our conferences saying that we are not being taken care of by the healthcare sector. I just wanted to talk it because I'm not giving a solution for this, but I'm trying to tell for us to look into a different perspective. We have to look into a different perspective. What is the future of young urologists with this corporatization happens? Let us come to the definition of corporatization. What we think as corporatization has got no relevance. What we are talking actually is privatization. Corporatization is a government-owned institution being corporatized with a simple administrative process of their own, like NMDC, BHUL, these are all corporate sectors. Whereas when you come into other thing, it is privatization. That means there is a private hospital which make an investment of 2,000 crores, and that is a private sector which is completely there. So there's a small thing. Why it's happened? Basically because the cost of demand or need, government could not keep up the pace with that. That's the reason why the private sector has come into place. If you look at this William Bow Committee in 1943, even before independence, has evolved a fantastic system. Had it been in place today, we would have not been discussing this today. If you see, I don't want you to read anything else other than that a long-term program, what has envisaged at that point of time. The primary program, the short-term program was creating the primary health centers, which India has done it, and we restricted ourselves to that level, and the long-term program could never be launched in a bigger fashion. That long-term program had multi-specialty hospitals in a district level at every level in the next 10 years, which was supposed to be there. And you can see many of them are served, like having a uniform MBBS thing and having a central institutes, etc., have been taken care of. But that long-term program has never been launched, and that's where the private sector came into picture to take care of that. If you look at the history of corporatization, the national health policy, they realized that they could not get this long-term program into place by 1980s. Then they thought that they need to get the primary health care can be taken care of by the government, but the tertiary levels requires a lot of investment at many places. So they allowed this thing to happen. And the whole thing revolutionized at that point of time. One of the best examples was starting of a private sector on Apollo Health City and all, which initially took their beatings because of not able to be afforded, but it has become a norm now that it is everywhere, rampant everywhere. And the restrictions of FDA being lifted in 2000 led to an immediate investment coming into this picture, where they saw a big chunk of money being earned over a period of time. Well, what is correct today? I am not here to discuss whether this way or that way what is correct. Had we created all those William Bohr Committee's recommendations into place, possibly we have been looking into an NHS-like policy, what is happening in England. We could not, so we are looking at an American side of policy where we create and everybody has to buy their healthcare, and that's what is happening inside India at present moment. So what happens with corporatization, like privatization, I would so call it? They are led to a government, the growth of the corporate hospitals, and slowly there is an FDA coming into health sector, and that brings in bigger hospitals, not smaller hospitals, and the erosion of small-sized private hospitals and clinics will start. They get derailed over a period of time. But why the RS are shifting into corporate structures? Why are we not restricting ourselves how we did it in the last 20, 30 years? But it is very clear. We know our answers. In fact, we don't go to a small place and work because we have got no enthusiasm in going there. At the same time, the government pay is not, we feel that is quite inadequate. Of course, when compared to any other sector, it is quite inadequate. So we have our own reasons to shift into corporate structure. I don't think I need to emphasize on that. At the same time, why smaller hospitals are not able to exist. It's not only our context where we want to go ahead with the corporate structures, why the smaller hospitals cannot exist, because they are individual based and uncertain future. They cannot meet the regulatory requirements what is necessary. And when you become very small, your purchasing power is very less. You're bigger, you got a bigger purchasing power. But when you're small, purchasing power is very less and you cannot exist over a period of time. The advantage of corporate is always there. Purchasing power is very high, investment into technology is very high, better administrative capabilities because there are people meant for it. So there is an advantage regarding admin and purchasing is covered. At the same time, what we talk about most of the time is disadvantage of corporate. Why we feel that disadvantage? Because your abilities and training are not considered into picture, but your turnover is considered into picture. That is one thing which makes us worried, because we are trained academicians all these days, claimed academicians, I would say, all these days. Whether you are or not, you disagree, but you claim yourself that an academics, so an academician has to be respected. There is a disparity of a payment. The senior guy is paid less and a junior guy is paid less. So your academic credentials, your age comes into picture, which hurts us in many aspects. That's the reason why we are hating the corporate culture, we call it, we, inverted commas, we came it as culture. But it is the truth anywhere in the world. You take any sector, you take software sector, it doesn't pay you by seniority. It's abilities which are being paid, and what makes that to earn more money is the thing what is paying you. So why not in this sector? Why we come into the question of humanness into it when we get our payments, but at the same time, we talk about when somebody calls up, you have to be human when treating the patients. We say we are also individuals living in the society. So we have our disparity in our minds regarding our profession, at the same time, our way of existing in the society. Well, there are some certain things, performance targets, unethical practices. This is common. I don't think that is true everywhere. It is possibly common in 10% of the places, 90% of the places it doesn't exist. So we ultimately realized that at one point of time, is a subtle loss of our autonomy, which was existing once upon a time. So we started behaving as if we don't like this sector the way we are being treated. But you should understand that is the way it is going to be. Because it's controlled by a big investment, insurance company, pharmaceuticals, purchasing power, all these things play in you. You are a small, minuscule role into the whole project. So in which case, we cannot be dictating the thing. In no way it can happen. So we need to be this reprofessionalization and re-stratification of this thing is going to be a norm for future. Let us say disclosure. I was a roaming urologist. I was a consultant urologist in a corporate. I became an entrepreneur urologist. I don't know what next decade is for me, but I got all these experiences. So my experiences are being shared with you, not my opinions. I would say my opinion. There are three ways of learning the whole scenarios. You see, in my own urological practice, I learned how to learn urology from Vaidyanathan. I learned how to practice urology from Dr. Desai. And I learned how to think beyond urology by Dr. D.N. Reddy, my mentor and gastroenterologist. This is one thing we need to understand. Life goes on like this. Wish we were taught when we were doing our medicine that why I am doing it, what results it meant, will I be successful. We never found an answers for this before we came into practice. But we better find an answers. If you have an answers, you will be a better man because you read the society and find an answers. Without reading the society, we are coming into the society. That's the reason why we are facing this crunch of corporatizations. Before we understand that, come to the healthcare economics. Okay, healthcare in a short fashion. First thing we should understand, there is no consistent relationship between cost and quality of care. This is a statement. This Atul Gawande's textbook, one of the books which says healthcare spice conundrum. There is no relation. So if increasing the cost doesn't improve the quality. We were calculating about the value of healthcare once upon a time. What is that value? Quality by cost. What is that quality? Once upon a time it was patient outcomes which were defined by the surgeon. But now it is patient outcomes plus surgical outcomes or treatment outcomes plus patient experience comes into picture. So once you create that patient experience into it, the whole value changes. If the patient experience is not good, irrespective of the surgical outcome, your value of healthcare doesn't exist. So till now, we have been talking about surgical outcomes, treatment outcomes. I made this better. I did this surgery which was very difficult. But patient experience are not met with, expectations are not met with. Of course, your value is not. This is what is going to dictate in near future. For an example, I've done a fantastic surgery and a robotic ureterope vasectomy for a huge pelvic lipomatosis case, and that guy roamed around with a stent for the last 2 years. Now he doesn't have a stent. It's exceptional result for my reason. I noted, I prepared, trying to present it into this. But ultimately, he was not having a good experience because sister offered him coconut water because knowing that his creatinine is 2.2. Which he knows that he should not take coconut water. So that's gone. His experience is zero. So your value of healthcare, what you are given, irrespective of your outcomes, is come down to a lower level than what it was. So the touch points which he goes through into a hospital is not only you part of probably 10 to 15%. The 30 to 30, 40 touch points which he touches into the hospital, and every experience there matters. It is the total experience which he counts, not your surgical outcome, which he counts as a surgical experience. So what influences the customer now? Perfect treatment is assured. Don't boast yourself. I have done a great radical prostatectomy. Damn it. He knows that you'll do a great radical prostatectomy. That's the reason why he's there with you. Don't ever say that. You're supposed to do that, and that's why he's there with you. He expects anything more than that what you assured. Are you providing anything else other than what you promised? Promise is already made. You're not just keeping a promise, is not your greatness. It's your duty. It's your duty to keep up your promise. So what else you are trying to do? So never even boast that I have done a great surgery, because that is what he expects you to do, and you have promised him that you'll do it. So it is more a care coordination business which has become. So why I'm giving this preamble today for you is to understand what you need to manage, how you're going to manage in a corporate health sector tomorrow. So ultimately what happens in a value-based healthcare is you're going to reward these healthcare providers who are achieving this positive patient outcomes, not by surgery or treatment, but the patient experience-wise. So tomorrow I am telling you, this next 10 years, this will be the thing happens. You have to listen to this Michael Potter guy, value-based healthcare, and that is going to be a norm. You are assuring your service, that is assured. Your capabilities are assured because you have a degree and you have already said that I am going to do. What else this patient felt according to your treatment, that is what matters, and that's where you're going to get a plus point on this. So this is a changing landscape which happens, and that is going to be there in the next 10 years very, very fast. Where you are now, we are here at this moment. The moment in the next 5 years, the whole thing changes. This is a changing landscape wherein it is not volume-based, it's a value-based healthcare tomorrow. The payments are not volume-based, it's going to be the value-based. So this is going to be the future of corporate sector. So if they don't care about your volume, it is a question about the value. Have you created a value-based healthcare, cost-effective with the good patient outcomes? This is going to be their investment for future. What they pay you as for the volume is minuscule in the corporate expenditure. Doctor salaries pay in any corporate hospital doesn't cross 15% of the turnover. So even though they pay a 1% extra to you, it's a minuscule in their expenditure. So don't think about it. They look at the value base, which is going to be fetching them much higher revenues in near future. There is a big challenges in value-based. We are going through a transition, as I said. It takes another 5 to 10 years before we understand this. So what else at present in Indian healthcare? We are still not clear where we are. We are looking at a value-based healthcare at one point. Again, we are giving a bundled payment there to give a fantastic treatment with a very low cost. So very low cost and high quality care they are getting assured by Indian healthcare, all those schemes. So we're in a transition zone. But one thing will happen. These transitions are only populistic policies, will not survive for long unless otherwise a good quality care comes into picture. So how it takes in the near future, we don't know. We are all looking, actually we look for a universal health care. No, we are looking at a universal health coverage by paying the private hospital from the government to give the service in a bundled out payment packages. So this is going to be a transition which I don't know how it will take in for the next point, but 20% of the healthcare is still going to be corporatized, and corporate healthcare is going to exist because Indian government cannot take over every part of healthcare. They can give health coverage but not healthcare. I'll take 2 more minutes. And Indian healthcare now is utilizing the private sector for treating the tertiary care part. So what is the most important thing is adaptation. You need to adapt. Are we trained for a modern healthcare? No. You are trained as an academician, you are pushed outside. You are fetching your food, you are struggling to exist on your own depending upon your capabilities. You are not trained anything else. If you look into anything, you need to train them when they are young into a different state of individuals, wherein they start telling a story, they're creating a good patient experience, they start working as a team, work together and create a good result. No, we are all trained academicians with some part of the ego, and we are indispensable. We are the people who are trying to get the result. This is what our expectations when we come out into the society, which is not true for future. You are part of the team. You are part of the team, and you have to be trained as a team here afterwards. The future of training urologists means you should be an emotionally intelligent doctors. You should be emotionally intelligent. You need to understand the self-awareness, empathy, motivation, self-regulation, and social skills, and teach entrepreneurship right from younger days. And this is what is necessary for you to understand and exist in this corporate structure. Well, I don't talk much about entrepreneurship on this, but what entrepreneurship you should understand is never start a business to make money. Make business to make a difference. Start business to make a difference. Unfortunately, majority of this, we term the businesses as money-making ventures. Money is a byproduct of any business. There is no question of business without an ambition or making a difference. So you need to have those objectives, and financial return and wealth creation is a byproduct of the business. And defining the success is individualized. You can define the way you want. The success is what is there in your mind, and it's never an end. You have another side coin for entrepreneurship, but at the same time, what is there in future? If the golden age of physician is over, with a golden age of entrepreneurship which is going to come in, it is a chance. You be a part of the corporate care. You be part of the private care if you're talking about it. And that is the golden age here afterwards. Anyway, that is the future is going to be prepared for this. This is the last minute of my slides, which is the most important. There will be 100 companies who will dictate the patient where to go. You are not going to be the pulling point over a period of time. Be prepared for it. There are 100 things which influence the decision making on the patient's mind. You are only a part of it. The artificial intelligence, either in form of telemedicine, Internet of Medical Things, cloud computing, healthcare, everything, AVR, everything will influence the patient decision making. Your words make a part of them. The fellow comes with a lot of knowledge. What will happen? You have been doing a protective medicine. You are treating a disease till now. Tomorrow it is not so. You have gone to a precision medicine now. Now a lab will tell what will be the best chemotherapeutic agent for him. A predictive medicine, the genomic analyst will tell what will be the possible diseases he will get and what sort of a disease it can be. A preventive medicine, epidemiologist will tell what sort of a diseases he can be having. And now you will be in a participatory medicine, wherein these fellows will dictate what you are going to execute on him. So you are a part of the team tomorrow. You are a part of the team tomorrow. Your abilities are restricted to a limited level as the time passes by, and that is not far. It is only 10 years by now. It will be a participatory medicine. Patient will come with all the genomic analysis, predictions, etc., etc., etc. So that is what we should be prepared. And where there is so much of data, your surfing Google will tell you. Tomorrow corporate style, I was just talking about corporate culture, how the hospital will see your Google profile, your surfing culture, your etc., 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 and decide whether you are a good candidate to be employed in their organization or not. Your Google will ask you, can I share your data to the corporatization? If you are willing, I'll share. You will say yes, because that is what it decides whether you want a job or not, whether you can be given a job or not. And that is not far. We are trapped into it, and we are into it already. For a job you have to serve, you will be able to say where all you are there, and that is evident for it. So realize monopoly doesn't exist. You are one as a urologist in the society. Number two, adapt to the reality today. It is a participatory medicine for future. And value-based healthcare is going to be the future. You are a part of that value creation. Entrepreneurship is one way to go, but exist is by teams, because you have a better power to buy or bargain, either of the two. Thank you very much for this opportunity.
Thank you, Malik sir. It was a really out-of-the-box talk, as we say, because these aspects only Mallikarjun sir can tell us how to go about it. So coming on to the other aspect, which is one more important aspect for us or urologists, that is earning money. And this is another out-of-the-box talk for which we have invited none other than Dr. Anish Gupta, who is one of us. He is a urologist practicing in Jaipur Golden Hospital in Delhi. And we will have his talk on Eurofinance, on unventured aspects of finances by most young doctors, and 2 simple investment ideas for everyone. Dr. Anish Gupta.
Yeah, that's fine. Good morning, everybody.
thank you for giving me an opportunity. I would like to thank the USI, the EU Council, Dr. Dilip Mishra, and Guruji Sabnis sir for starting the Eurofinance group from where we have branched on to this. I've been pushing financial management as an agenda vigorously over the last 1 year to all urologists, and I'm thankful for the many opportunities I've been given to present my views on that. I try to present something different every time so that we do not just talk about ways to earn money, but we also talk about how we should be managing money. That is why I named the topic Unventured Financial Aspects. You see, Dr. Mallikarjun, President Sir, just said we must adapt and there is no monopoly. So whatever we are earning, we must grow that so that we have an opportunity in life in case we aren't able to earn for any circumstance, we still have something to fall back on. So there are 5 tenets I'm going to base my talk on. An introduction, you see, as I just said, every individual's life is different. Our experiences, social network, personality, beliefs, reactions make up the sum total of who we are. But no matter how different we are, we all need to undertake financial planning. It's not just about saving wisely, spending wisely and saving prudently. We must go a step forward. The first aspect of financial management is risk profiling. Ideally, the risk profiling should be step 1. Before you start investing in any financial product, or for that matter, starting any business, it should ideally be done by a qualified financial advisor. It is a process of evaluating the individual's willingness and ability to take risks. This would then help to determine a suitable asset allocation, say how much into equities, which is considered riskier, and how much into fixed income products. All investments contain an element of risk. These include risks from general market conditions, fluctuation in currency exchange rates, interest rates, possibilities of companies going bust or defaulting. The next is cash flow management. You see the input and, this is simply estimating and recording all your outflows, like say rent, EMI, electricity bills, medical expenses, children's school fees and insurance, and your inflow, such as salary, rental income or any other receipts, over a regular time period, say monthly. If you've done goal planning, you would have an idea about the amount you need to save every month and meet those goals. Is the net amount of receipts versus expenditure enough for that? Do you need to increase your receipts or do you need to decrease your expenditure? Often putting down this in a sheet every month helps out figure out the exact method. The emergency cash is something, I've not put up anything there because it's more talk. So there's no point me putting down pointers. It's more important for people to understand. They're fairly intuitive. Everyone knows about it. Most understand it, but hardly anyone follows it. From time to time, we may have sudden unanticipated expenses due to events like medical emergencies, loss of job, something like COVID in which a lot of corporates were downsized or the minimum guarantee was removed, or a family member who needs help. So a certain basic sum should be kept aside in a very safe and easily liquidable asset, like say a liquid or overnight fund or short-term FD. Generally, as a thumb rule, 6 months of living expenses should be kept aside for this purpose. The next part is very important, and we must diversify. You see, asset allocation is very important, and all money should not be put into one venture. Before investing in specific investment products, it is important to be clear of the split in allocation you wish to have into different classes. Broadly in India, the most investment products can be classified into three main types: equity, debt, and gold. Real estate, I know there are people who are pioneers and advocate real estate, but for the younger generation to whom I'm talking to right now, it is not as popular because the amount of capital needed initially is very high and hence has become less attractive. So if you decide to split 50-50 between equity and debt, the schemes and products have to be chosen accordingly. A simple rule of thumb is 100 minus age. If your age is 35, 65% of that should go into equity and 35% of that should go into debt. Now this next slide is very interesting. I do have a pointer. Okay. So you see, this is a asset allocation quilt, as you call it. This goes from 2011 to 2020, and it gives us 10 categories of assets, and it tells us how they have performed over the last 10 years. Now, if you would just see gold for that matter, it was the top performing asset in 2011, went down to 8th in 2012, stayed down, giving minus returns for the next 3 years, went back up, came down, went back up, stayed up. And look at the equities. They were very much lower down in 2011 and had been cycling up and down to end up 2020 with this very high growth in the small caps. And real estate was very poorly growing now, though it had been growing very fast earlier. This is the basic principle of personal finance management, which should hold good even in the face of disruption. This includes building a safety net and an asset allocation aligned to our goals. When investments are based on the bedrock principle of diversification across asset classes and rebalancing is done on the time horizon available for goals, then investors feel far more comfortable of weathering interim shocks. You see, maximizing returns is not the primary goal of a financial plan. It is to bring an element of certainty to finances. That statement must be taken home, irrespective of external events. Most of the people who regularly save and invest, you'd be surprised to know, would be able to meet most of their goals with just a return of 9%. The last thing in the unwanted financial aspect is something which people do not pay that much heed to and is very important, which is succession planning. When we die, it is important that our financial assets are passed on to our heirs smoothly without them having to run from pillar to post. For this, it's important to plan while we live. This involves keeping a consolidated account of all our assets and liabilities and ensuring nominations are in place for our bank accounts and investments. Preparing a will is also essential and would help avoid disputes as well as release of investments by banks and other financial services providers to the rightful heirs and nominees. So I'll go on to the next part of my talk, which is giving two simple financial instruments as advisors, which people can start off with if they're planning to go into equity. I am not a registered financial advisor, and this is something I'm just doing in a closed group. The first is exchange traded funds. Index funds that are listed and traded on exchange like stocks. They enable the investors to gain broad exposure to entire stock market in different countries and specific sectors with relative ease, and on a real-time basis at a lower cost of management than many other forms of investing. An ETF is a basket of stocks that reflect the composition of an index. It may be Nifty, it may be Bank Nifty, it may be infrastructure index, it may be the pharma or the healthcare index. We also have exposure to international indices, like we have an ETF for the Hang Seng index. We have ETF for real estate, REIT ETFs we have. So we have many other ETFs. the ETF trading value is based on the asset value of the underlying stock, and think of it as a mutual fund. You can buy and sell at a real time throughout the day without having to put money aside in one go. I'll just take one more minute. The next is equity SIP. Invest in 5 or 7 good blue chip companies from each sector, pick up one, put aside a few fixed amount for putting it into those every month. Grow slowly and gradually your corpus will grow, and the blue chip companies, when you invest in, they are not going to go anywhere. Even if you buy, let's say 10 units of Reliance over the next 6 months, and you keep on doing it over the next 20 years, you will have at least 120 units which would have doubled, bonus would have been given, dividend would have been given, and the money would have tremendously grown. It does demand some amount of observation and monitoring from the investors, but gives the advantage of cost averaging tool. Even if the market is high, yesterday we were I was being asked, should we invest now if the market is very high? You should invest. Some of these stocks are not as going as high, some of them are going very high. But you can average your cost by doing it over a regular period of time. This is my last slide. I normally try to end my talk with a quote from Bhagavad Gita. Nacha mam tani karmani nibadnati dhananjaye udasin vad asinam asaktam teshu karmasu. O conqueror of wealth, none of these actions bind me. I remain like a neutral observer, ever detached from these actions. This talk I gave is like a pair of tongs in the kitchen. They are lifeless by themselves, but in the hands of a chef like you, they will come to life and do wonderful things, such as lifting heavy, red, hot bowls of life. Thank you for a patient hearing.
Thank you, Anish. That was wonderful. We had a really nice out-of-the-box session with 2 great talks. Now we would move back to urology. This is the most wanted session of urology, which is endourology, upper tract. And we have decided to base this session on RIRS and ESWL. Dr. Deepak Raguri will be moderating this session along with Dr. Brojan Burman. I would invite Deepak to take over this session now.
Thank you. Starting the endourology, upper tract, the theme will be stones and RIRS. Our experts for the sessions are Dr. Kandar Parikh, Chairman of Sham Urological Hospital, Ahmedabad. He has been conducting regular endourological training program and conferences for young urologists, the most notable being Advancement in Endourology, live operative workshops. Our second expert is Dr. Chandra Mohan, Chairman and Managing Director of the Preeti Group of Urology and Kidney Hospitals, Hyderabad. He has been conducting regularly the endourology training program for young urologists like us. He is also the host for urology teaching platform in the Facebook, the Pure Urology. So with this brief introductions of our experts, we move on to the 5 presentation. They are of 8 minutes each. The first talk will be given by Dr. Saurabh Gaur. He'll talk on ESWL, resurgence or dead. Dr. Saurabh.
Good morning, everyone. Lithotripsy was first introduced in 1980. Later on, Dornier's human model 3 became so successful that it became first-line option for most of the stones. Even after 30 years, it's the only non-invasive modality and can be readily performed on outpatient basis. SWL is currently recommended preferentially over other modalities in absence of unfavorable factors of stone composition and anatomical patient factors. Anatomical factors which can impair successful stone treatment are steep infundibulopelvic angle of more than 45 degrees, narrow infundibulum of less than 5 mm, very long calyx of more than 3 centimeters, and long skin to stone distance of more than 10 centimeters, and shockwave resistant stones like monohydrate, brucite, or cystine. As a general rule, if the stone problem is simple, renal anatomy is normal, and stone is around 2 centimeter or smaller, SWL should be the primary treatment modality. Recently, there has been a significant trend away from the ESWL, even though it's least invasive and has least complication rate. There are many reasons. Ureteric stones usually comes with symptoms like pain or urosepsis and may require emergency degestenting or emergency procedures, but emergency ESWL is usually not possible due to various reasons. Then issue comes of secondary ESWL treatment, which can go up to 60% in case of lower pole stones. Issue of residual fragments, even if it's clinically insignificant, does not go down well with the patient. So urologist and patients both want treatment of the stone in the single sitting, either by complete dusting or by removal through endoscopy. Physician preference is the main aspect in choice of treatment modality. There has been a dramatic advancement in the endoscopic technology in the past decade, and young urologists are exposed to this state-of-art endoscopic techniques during their training. So hence, naturally, they are more inclined to use these technology than SWL. Also, in the same time frame, there has been very limited progress in the SWL technology. Other factors are migration of many common urological procedures from hospital to private surgical centers. Increase in physician ownership of these centers and financial incentives play a role in preferential selection of certain procedures. Hospital setups might even affect the indication of surgical intervention. For example, a patient with small asymptomatic 1 centimeter soft upper pole stone that can be easily treated with ESWL have high success rate, is more likely to be treated by PCNL in small centers and RIRS in corporate hospitals when either the lithotripsy facility is not available or insurance packages are not available. Treatment protocols for SWL differ, but local practice often deviates what is recognized as best practice. This can be understood by shock wave rate. Slow shock wave rate is beneficial, but it also increases the time. So it is not feasible option in high volume centers. Urologists and technicians are mandated to follow a set protocol defined by the institution. This also takes away critical aspect of treatment out of the hand of the urologist. In addition, inadequate knowledge regarding concept and advances in the field could also be a factor. Practical steps to improve success rate are proper preoperative imaging to know the detailed anatomy, pain control during the procedure, lowering the shock wave frequency, and delivery of the shock waves should start at a lower energy setting, and then there should be stepwise power ramping. This achieves vasoconstriction during treatment and prevents renal injury. There is no consensus on the maximum number of shock waves delivered and the intervals between the sessions. Though in renal SWL, the interval should be around 7 to 10 days, and in ureteral cases, it can be given on the very next day. Acoustic coupling should be done properly, as defects or air pockets can deflect up to 99% of the shock waves. Abdominal compression belt can be used to decrease the stone movement during respiration, and it can also reduce skin to stone distance in obese patients. Procedural control of imaging during the procedure is very important to refocus if the patient moves. As the clinician gains experience, he can read the subtle signs of stone breakage like softening of margins, loss of density, and movement of particles. This is very important to determine adequate number of shock waves delivered. Medical expulsive therapies after ESWL increases stone free rate and reduce analgesic requirements. Post-treatment mechanical percussion, diuresis, and inversion therapy helps in dislodgement of stones, and this is particularly helpful in lower pole stones, and stone clearance rates are also increased. Technical innovations like optical and acoustic tracking system facilitate stone targeting and reduce X-ray exposures. Modern lithotripsers have both fluoroscopy and USG to track movements. Respiratory motion can move stone in and out of the focal zone up to 5 centimeters, and due to which up to 50% of the shots may miss the target. These advancements trigger the lithotripter only when the stone is on target, so it shortens the treatment time and reduces exposure to the shock waves. Dornier lithotripter's built-in camera system provides excellent control of coupling quality. It has been shown that low pressure and wide focus has same disintegrative efficiency, but homogeneous fragmentation than the high pressure and small focus. In new shock waves introduction like burst wave and high frequency could be a game changer, as these enables very fine disintegration without any significant side effects. Even hard stone can be pulverized in less than 2 minutes. Other modifications like dual head lithotripter and tandem pulse shockwave generator are not in widespread clinical use. So apart from change of indications, the main obstacle is higher rate of secondary procedure. This might be improved by use of optical navigation, video control of coupling, and reduction of respiratory movements. It is up to the manufacturers to bring these promising changes and others like burst and high wave frequency in the market for the rise of ESWL. Now sharing a few results. This is a 74-year-old male with right proximal ureteric calculus and left lower pole calculus. A bilateral DJ stenting was done under local anesthesia, and 2 sessions were given on both sides to achieve complete clearance. This 35-year-old male with lower pole partial staghorn was counseled for ESWL. Stenting was done under LA. After 3 sessions, DJ stent was removed, and after 1 month follow-up, gave 100% stone clearance. This 50-year-old male had a 1.5 centimeter pelvic stone. He developed stent stress after first session, for which stenting was done, and complete clearance was achieved after second session. This 25-year-old male had a 1.6 centimeter pelvic calculi and 8 mm proximal ureteric calculi. DJ stenting was done, and complete clearance was achieved in 3 sessions. This patient with horseshoe kidney had a right PUJ calculus of 15 mm with 1500 Hounsfield per unit and left PUJ 17 mm with 1600 Hounsfield per unit. Both the side DJ stenting was done under local anesthesia, and 2 sessions were given on both sides to achieve complete clearance. SWL is the only non-invasive method with least complications and give very good result if best practice guidelines are followed. Currently, it's recommended over other modalities in favorable cases, and if recent technological improvements are made like burst ESWL, it could be a game changer. Thank you.
Thank you, Saurabh. Our next speaker is Dr. Giridhar Venkatesh from Bangalore. He will speak on which flexiscope to prefer for beginners, either is disposable or reusable. Dr. Giridhar.
Good morning, respected teachers, seniors, and colleagues. This topic is more for a debate. Which flexible ureteroscope is good for the beginner, whether it's a disposable or reusable scope? I'll put forth my views based on some available evidence. So how do we compare? So there are several parameters. One is the stone-free rates, complication rates, operative time, the cost, difference with respect to surgeon experience, scope longevity, and clearance of lower calcial stones. There's an excellent review article that was published in the International Brazilian Journal of Urology in 2019. And this has answered several of these questions. It's a good article to go through. When we compare the reusable scopes, the fiber optic scope is more delicate, comes although with a lower cost, the maintenance costs are higher and the image quality decreases with time. Whereas the digital scope comes with a larger diameter, but it gives excellent vision and lasts longer than the fiber optic scope and also provides greater maneuverability. The sterilization costs are similar for both scopes. When you consider the disposable scopes, all are digital scopes, hence it's an advantage, and it comes only with the cost of purchase. There are no repair costs and the sterilization costs are minimal. Generally, these are larger scopes, but of late, smaller scopes have been introduced, which can be used with smaller access sheets. So comparison of outcomes were done in many studies. They compared the stone-free rates, complication rates, and operative time. The stone-free rates were comparable, whereas the complication rates were significantly lower with disposable scopes. And several studies have shown shorter operative times with disposable scopes. This may be due to the fact that they are digital scopes. There are several hurdles for acquiring a reusable scope. One is the higher initial cost. So the hospital managements may be reluctant to buy a new scope or replace a damaged one. And of course, there can be surgeon reluctance to use this scope really, especially for lower calcium stones. And there are maintenance issues. Trained manpower will be required for sterilization and handling. When we compare the image quality, the fiber optic scope image quality deteriorates with time, whereas the digital scopes maintain their image quality till the end of its life. That's an advantage. Considering scope longevity, there are several factors. Surgical factors are use of access sheets, miniaturized baskets, and smaller laser fibers. They improve the life of the scope. whereas some patient factors like lower calyceal stone location and larger stone burden, they reduce the longevity of the scope. In general, digital scopes last 25 to 30% longer than fiber optic scopes. Fracture et al. Studied the longevity of scopes and specifically two aspects of it. They compared 50 flexible ureteroscopies and for loss of maximal deflection and irrigation. And they found over 50 procedures, there was a 25% loss of ventral deflection and 50% loss of dorsal deflection. And there was a loss of irrigation as well. So this may actually translate to lower SFR, higher operative time and higher complication rates for fiber optic scopes. And stone location is another important factor which determines scope longevity. Especially there is a 96% scope failure due to in situ fragmentation of lower calyceal stones. So most scope failures are due to lower calyceal stone management. And of course, in addition, in situ fragmentation of lower pole calculi is not possible in nearly 30% of cases. So there's a direct correlation between the technical difficulty of the procedure and incidence of ureteroscope malfunction. So the surgeon may be reluctant to use a reusable scope in these situations. And considering the impact of sterilization, it has been seen that scope breakdown or damage occurs in nearly 15% of cases during sterilization. The disposable scopes have a clear advantage of not requiring extensive sterilization processes and hence less damage. The single-use scopes don't require any sterilization, which is a big plus point. Coming specifically to the question, are infections related to reusable scopes? The answer is yes. Several studies have shown a significant difference in post-op infection rates between reusable and disposable scopes. Two studies I have cited here. In one study showed MDR pseudomonas associated to two colonized flexible ureteroscopes, and another study showed contaminated ureteroscope being responsible for E. cloacae infection. So there's another study which showed all other parameters were comparable, like procedure time, the SFR, and mean cost, but overall infective complications were much higher with reusable scopes as against the disposable scopes. So they concluded that disposable scopes have lower post-op infection rates. Surgeon experience is another factor to be considered. It has been shown that reusable scopes are favored only if more than 60 cases per scope can be performed. So only high volume institutions might find it more cost effective. Surgeon experience becomes very important here. When we compare the initial costs, the fiber optic cost is slightly lower than the digital scope cost, but the repair and sterilization costs are comparable. In the Indian scenario, there are no studies available to compare the costs, but I've gathered data after discussing with several experts. The cost per scope is rupees 70,000 to 1 lakh, and the initial cost includes an additional 3 to 4 lakh for the monitor purchase. An average scope usage is about 4 cases per scope, which makes the cost per procedure about rupees 25,000. Of course, lithoview is more expensive, but the advantages are no repair costs are involved and the sterilization cost is low. And moreover, companies may offer the monitor free with bulk purchase of scopes. The only disadvantage is incompatible or exclusive monitors, which means monitor of one company cannot be used with the scope of another company, making the urology unit stick to one manufacturer. So the factors associated with the beginner are inexperience. So digital scopes are definitely preferable, disposable ones, because the risk of scope damage is higher and higher chance of relancing for the beginner. So disposable scopes are preferred. The scope related factors are superior image quality and no effect of surgeon experience, much lower infective complication rates, and they can be used boldly in anatomically difficult locations. Hence, they are preferred. So to conclude, disposable flexiscopes score over reusable scopes in several aspects and probably are the best flexiscope for the beginners. And in future, if universal monitors become available, the cost can be reduced further, making it very attractive option. Thank you.
Thank you, Dr. Giridhar, for comprehensively covering the entire topic on reusable and disposable scopes. So with this, we move on to the third presentation. It's by Dr. Suraj Suchak from Mumbai. He'll speak on lasers in RIRS. What is important, man or the man behind the machine? Dr. Suraj.
Thank you, sir. Good morning to all. Thank you for the opportunity to allow me to give this talk. So today we'll talk about what is important, the machine or the man behind the machine. First, we'll start with the surgeon. So RIRS can be used to treat intrarenal stones smaller than 3 centimeters depending on the expertise level of the surgeon, with a lower risk of kidney injury and hemorrhage in comparison to PCNL. The surgeon skill is very important. When we start out, we think we know a lot, and there is a lot left to learn actually. We don't know that much. As we do more and more cases, we realize the lacunae in our knowledge, and we tend to realize there's a lot we don't know. There's a Dunning-Kruger effect, which shows that within a few number of cases, we feel supremely confident, we reach Mount Stupid, and then few complications, they break our confidence, we go down, and slowly build it up. And that is when we have true learning coming in. There was a study done by Bernardinelli et al. Who showed that the surgeon experience was an important outcome for our RIRS. Another study done by De Cruz et al., where they did a qualitative analysis, concluded that you need at least 60 cases of RIRS where all your variables are then comparable. So the learning curve they said was around 60 cases. Komori et al. Evaluated, they found that the learning curve is around 100 cases. So it is safe to say that the learning curve for this procedure is 60 to 100 cases. However, for complex stones and complex situations, I think the number would be significantly higher. So coming to laser. Laser stands for light amplification by stimulated emission of radiation. It is monochromatic, coherent, and collimated rays that we use. The lasers that we use are of pulsed type for stone lithotripsy. We can control the pulse duration, the energy, and the frequency. The power is equal to the energy in joules multiplied by the hertz. We can have the things that we control are pulse, duration, and frequency, like I said. So pulse can be short pulse or long pulse. Short pulse is usually used for fragmentation. In this, the energy delivered is a pulse of high energy for a short duration of time. So it has a high peak power. In long pulse, the same energy is given over a longer period of time. So it has a low peak power and it is better for dusting. So long pulse is extremely good for dusting. Short pulse is for fragmentation. Holmium-YAG laser has been the gold standard laser for stone surgery over the past 2 decades. It still faces some limitations. The limitations are in the form of, it is slow and it is time consuming. Here we can see the design of the Holmium-YAG laser. The limitations, like I said, it is slow, time consuming, it has an inefficient design, a large size, requires a cooling mechanism, high power requirement, it is quite fragile, and a single cavity can generate only 30 hertz of frequency, so we need multiple cavities if we are going for higher power. So we need a new laser. This new laser should have ideally a smaller fiber, a lower energy, and a higher frequency. This has been offered to us by thulium fiber laser, where we can see the fiber size goes down from maybe 273 to 150 microns. It decreases the diameter by 1.8 times. The surface area decreases by 3.3 times because of this change in diameter. Because of the decrease in the surface area, the density of energy increases. So we must decrease our energy also by 3.5 times for the same amount of power. The thulium fiber laser consists of a thin, long silica fiber, 10 to 30 meters long, and it is doped with thulium ions of 10 to 20 microns. It is pumped by a diode laser. The Olympus and the Quanta systems have been CE marked, as well as they have got FDA approval. On comparison, the holmium-YAG and thulium, the wavelength is of holmium 2120, thulium is 1940. The pulse energy range here, you can see 0.2 for holmium, much lower for thulium. It goes down to 0.025. The duration range is 1 millisecond for holmium, it is 12 milliseconds, significantly longer for thulium. We can see that the pulse shape, it is dictated, it is a very regular pulse shape which we get for thulium fiber laser. The fiber that we use is significantly smaller in thulium. Here it is mentioned 150 because 150 is used in clinical practice. However, experimentally they have tried up to 50 micron fibers. The cooling system is required for holmium, not so much for thulium. Now we can see here the maximum absorption coefficient of thulium is higher than that of holmium, supposedly increasing its safety profile. The thulium is up to 6 times lighter, it is more energy efficient. You need a special 42 ampere collection for holmium. A simple 5 milliampere suffices for thulium. A much bulkier machine for holmium compared to a small portable machine for thulium. The thulium fiber has a high reliability and a low maintenance cost. It is a fully solid state design and it has no water cooling system. It has fans inside. On a technical parameters, on a technical comparison, the thulium fiber scores over the holmium yak laser. It has better water absorption, it has more parameters, more stable pulse, it has a lower peak pressure, smaller laser beam profile, higher reliability, lower maintenance cost, simple wall plug is sufficient, a better wall plug efficiency, 12 times more efficient for thulium fiber than holmium. It has low weight, smaller laser fiber and a simple cooling system. The only problem is the cost. It is more expensive than that of holmium. On comparison of clinical outcomes, because this is what we should be really looking at. We should be looking at what difference does it make to the patient. The thulium fiber still scores over the holmium because of faster fragmentation, better stone ablation, more dust is produced, there's less retropulsion, less burn back, less fiber breakage, so increased fiber life. It has equivalent temperature change and equivalent safety profile. The peak power of thulium is low, so it's not very, very good for fragmentation. The sparks, it can sometimes cause sparks on stones if we are too close to the stone, and there is a low visibility over 60 Hz frequency. The take-home message would be that experience is extremely important. You need to do more number of cases to get better at this, and nothing can replace that. And thulium fiber laser is likely to be the future of lasers in RIRS. Thank you.
Thank you, Suraj, for a very comprehensive review of holmium and thulium laser. With this, we move on to the fourth presentation. It's by Dr. Vijay Madhuri from Jodhpur. He'll be speaking on flexible ureteroscopy in anomalous kidney. Is it any different from a normal kidney? Dr. Vijay.
Good morning to everybody. Great to be in Hyderabad. And my topic is flexible ureteroscopy in anomalous kidneys. So the question is it any different? Well, the answer is both a yes and a no. So it is like playing a game of Mario and you're on level 4 and you go to level 10. So the game is the same, but it's not exactly the same. So what are the anomalies you can encounter? These are the anomalies. I'll be going through them briefly. The most common is the horseshoe kidney, and you can see here one of the IVP, and this looks like kind of a nightmare, the collecting system, how to go, where to approach. So what are the issues you can face? The kidneys are usually positioned lower than normal. So the ureteric access sheath may not be inserted fully, and some part may be left outside the urethra, especially in the female. Then usually there is a ureteric kink at the PUJ, where the ureter crosses anteriorly over the isthmus, joining both the kidneys. And that can create a sharp bend and lead to difficulty in maneuvering once the scope crosses and goes into the PCS. Then obviously there is the abnormal orientation of calyces. Many times the calyces face medially rather than laterally and anteriorly as well. So that needs advanced maneuvering skills, and sometimes it's actually unreachable even after trying. So, and the next is malrotated kidneys. So you can see this malrotated kidney here. The pelvis is facing anteriorly rather than laterally. Okay. So again, what difficulty you encounter? The usual scope movement will not make you reach the desired calyx. You have to maneuver your scope such that now the bend is facing downwards. So pelvis may face both anteriorly or posteriorly. and the abnormal orientation of calyces is there. And next is the ectopic kidneys. So the most common anomaly is the pelvic ectopic kidney, and as you can see here, the anomalies you can face in the pelvic kidneys while doing RIRS is that the ureteric course is usually tortuous, and there may be sharp bends while negotiating your scope inside. And once bends are encountered proximally, the deflection further on when you reach the PCS is decreased, and this may be difficulty. And of course, there is another issue of supernumerary kidneys, and here in this case there may be 2 or 3 ureteric orifices on the same side. So identifying the correct moiety is also an issue. Then there is the duplicated collecting system. As you can see here, sometimes both moieties or even a single moiety can be duplicated. So here a preoperative roadmap is very essential. So you need to be very clear exactly in which moiety you will be going. And the level till which the duplication extends is also important. Sometimes you have a full duplication where both the PCS and the ureter are totally duplicated, or sometimes the ureter may join each other at some level. So that has to be known clearly. The location of the ectopic ureteric orifice should also be determined. Sometimes it opens laterally, sometimes it may be distal or even in the prostatic urethra. And one strategy to identify the ureters differently may be to place different colored urethric catheters, or to place a catheter in one in which you don't want to go. Last is the diverticulum, anomalies in which the calyceal diverticulum communicates to the PCS through a very narrow hole. And the identifying the location of this calyx is very important, and in relation to the PCS, because the orifice, as I said, is very narrow, and it may be lost while you are doing the initial ureteroscopy, and there may be a difficult angle of entry into the infundibulum as well. So this has to be known beforehand so that you exactly know when you enter the pelvis where you expect the calyceal opening to be. Again, the 3D orientation is important. Sometimes the calyceal opening may be anterior or posterior, so you need to be good with your bearings so that you know how to move your hand and also deflect the scope. 3D orientation is also important if you decide to incise the bladder neck, because there are vessels running near the neck of the opening. So these are the anomalies which you encounter, and as you can see, a slightly different maneuvering and skill set is required as compared to the regular ureteroscopy and RIRS. And the summary of changes, I'll just briefly outline what you need to do. So first of all, we need to have a very good roadmap. Preoperatively, we need to be very clear what we are dealing with. And for this, CT urography is preferable always. Pre-stenting helps. Sometimes these ureters may be narrow, and even if not narrow, because of the abnormal angles, it may be difficult to negotiate. So a dilated ureter will be more accommodating for your maneuvering. Keeping a safety guide wire is always a good idea, because these ureters may be prone to injury during maneuvering because of their abnormal orientation. Then ureteric access length and location has to be tailored. So as you can see, especially in pelvic kidneys, the access sheet lies quite a bit outside the body, and this may be difficult to maneuver. Pressurized irrigation is very helpful, and there are many methods to be used. We at our institute use a continuous pressurized irrigation system, which is more means hassle-free, but many people use an assistant pushing the irrigation under pressure. It depends, but the field has to be clear. Watch for the bubble. So now, as you know, when the patient is in supine position, the bubble will always face anteriorly away from the ground. So this helps in keeping a proper orientation. It will guide you how and where to maneuver the scope. Then keep injecting contrast through the irrigation port whenever it's needed. If you are lost or if you don't find the desired calyx or the stone, This will help you where to guide your scope. Was the ergonomics? RIRS has some ergonomic issues even in the routine instance, and here the case is more difficult. So you have to watch it well. The patient height and the screen height all have to be correct. Scope type and dimensions matter. The digital scope is a slightly larger scope, and pre-stenting may be needed more often for that. Thinner laser fibers are helpful because the angulations may be difficult and the deflection may be limited. Then lastly, if everything fails, please think of staging on mini-perc. Keep the safety of the patient uppermost, safety of PCS and ureter uppermost. Take-home message from my side is Flexi-URS has the same principles but more difficult in anomalous kidneys, and so experience matters. This is all from my side. Thank you very much.
So operating on the anomalous kidney doing RRS is a challenge for both the machine and the man behind the machine. Thank you, Vijay, for an excellent talk. For the fifth talk, I invite Dr. Ravi Jain from Ahmedabad. He'll be speaking on management of residual fragments post-RIRS.
Hello, Dr. Brajan. This is a small flip in the program. Dr. Desai has already logged in. So we'll just take the start talk first, and then we'll get back to you to finish with the last talk. We have Dr. Mahesh Desai himself here to give a start talk on what I see as the future of stone management in RIRS. Who better than Sir himself? He's been there, he has done it, and he's seen it all. Sir, welcome. Over to you.
Thank you, Dilip, and I thank the Keshavamurthy Mallikarjun and the organizer for inviting me in this youth conclave. I already feel young. That's the effect, and I'm really impressed with all the talk which I've been listening for last a couple of hours. Has been very good, and I really enjoyed the talk. Can you hear me?
Yes, sir. Very well, sir. We can hear you.
All right. Now I will log into my screen and one minute. Well, what I see as the future of the stone management in RIRS, I think RIRS has been developing very well. As I said, the first speaker, Dr. Saurabh, he talked about ESWL. And I see when the ESWL started going down, the flexible ureteroscopy started coming up because of improvement in the instrument and the technique and the result. And then the PCNL has been studied there. I think all three energy are the complementary, and then there are the places because the stone are variable and kidneys are variable, and what can be very, very useful. So now what is I've seen in last 30,000 cases in 42 years, the stone management has been different because the stone size has decreased. Almost 76% of the stone are small, less than 3 centimeter. And we've been doing mini perc and a micro perc for this small stone. But when the stones are larger, we are doing a multi perc. But on the other hand, there are so many people like Kandarp and Chandra Mohan, they are doing flexible ureteroscopy for the 3 centimeter stone, and for a larger stone, they do the ECI-RS, the combination of therapy. So thing is that now we have a very many options, and then what we have to see is what is the future, and the future definitely depends upon two things. One is the instrument, the quality of instrument, and the limitation which has been there so far has been overcome, and the experience of the surgeon. So RIRS future, I believe, is in image, as already the speaker has spoke about the digital one, the design, especially the deflection of the tip, then the RIRS in a difficult access, like people have talked about ectopic kidney and horseshoe kidney, RIRS in combination with PCNL, RIRS for renal access, RIRS is cost effective, and RIRS, robotic RIRS, and then a new instrument, and of course the training. So, spurred by the advances in a miniaturization, digital camera, and illumination technologies, new digital endoscopes are engineered to improve the image quality and reduce bulk by dispensing the fiber optic and improving the light delivery. This scope utilizes CMOS chips digital camera at the distal tip of the scope and a light emitting diode light source that is housed within the proximal scope. Now, I'm not going to speak too much about the development. Already the speaker has spoke about it. But what I see RIRS in my practice, especially in a difficult access. Now, this is a calyceal diverticulum, one person says, and if you have a diverticulum and if you have a good cortex above and it is in upper calyx, so I think, that is where the RIRS I feel is extremely useful. And here putting the scope into the upper calyx, and then you looking at the infundibulum, and then the small opening of the diverticulum, and then you can inject a methane blue into the system and then wash it out, and then you will be able to see the opening, and then you dilate make the opening bigger, and you see the stone. And the stone, look at the vision. The vision is so beautiful, and that when you are doing with laser, there is hardly any bleeding. And here you will see that the stone is breaking up, and the stone is fragmented, and you can clear the stone. It is the most dependent area, and you will find the results very, very, very good. So let me go forward, and here is a total complete clearance of that thing. Now this is another patient which is again challenge. He has underwent a right transureterostomy and right ureteric reimplantation. So access to the ureter is difficult, and the left renal calculi on the evaluation for the left flank pen, left poorly functioning small kidney, the supracostal no comorbidity. The kidney is very, very small and scarred, and there is a lots of bowel adhesions, and it was very difficult to do it. Now look at this kidney, and there is a stone there, and here is a reimplanted ureter, and it's going to be difficult to do it. So what I did was I punctured the kidney on the right side and passed a guide wire, and the guide wire went down the ureter into the bladder, and this is in supine position. And then I did a scopy and picked up the guide wire and pulled it out. And once I pulled it out, I dilated the lower ureter, and then a double lumen catheter, 10 French, and then I passed another guide wire just after the dye study, which is again going into across the other ureter into the left kidney. And here again, you can see that the guide wire is gone there, and the tract dilated, and then over that tract, we passed a flexible ureteroscope, which is gone to the other side, and we slowly, you will see that it is going very, very smoothly, and this was a poorly kidney. Other kidney is a very good function. So creatinine, everything was normal. We passed a sheath, and then through the sheath, we passed a flexible ureteroscope, that the stone was there, and here is a system. Look at the image, beautiful image, and here once you see a nice image, you can do a better job. And here with the laser, you disintegrated the stone. There was some infective element was there, which was already been covered with the antibiotic, and then in the end, the procedure, you passed a DJ, and then and here you see a parenchymal calcification, because when we did a dye study, this was in the parenchyma. And then, so here is the position where PCNL is not possible, ESW is not possible. Flexible ureteroscopy offers an excellent approach to this kidney and then do it. Sometimes you have a stone which is in a very awkward stone with the awkward pelvic collecting system. It is in the lower calyx and there's a large cyst. And here we could pass a flexible ureteroscope. You can see that because of the new deflection, you can go into the lower calyx, you can see the stone, and then you could basket it and take it out to the pelvis and push it into the upper calyx, and then you can disintegrate. Or nowadays, the flexible, the scope is so nicely curved that you can break the stone there and there. Now, this is a kidney, which is a stone, large stone. It had a partial nephrectomy. And you can see the drooping flower appearance. And it's a stone there. And it's not a normal collecting system. So it was a very difficult, we did a flexible ureteroscopy, but the stone is very, very big. And to break the stone, I'm sure with the drooping flower, it is not going to clear completely. So naturally, I thought that I should do a PCN under the fluoroscopy, under the ultrasound, and I did ultrasound, and at the same time I was observing from the flexible ureteroscope. Here you can see that, so here is a case, a difficult case, and here with the flexible ureteroscope, you could, under observation, you can pass the guide wire. Guide wire is seen here, and the track is dilated, and at the same time, the flexible ureteroscopy will also help to monitor your position, and then it is balloon dilated, and then you can pass a nephroscope, and then you can break that large scope and do it. Here you can see that under vision you can have a perfect puncture, and then you can do it. I just push it further, and here is the dilatation, and then the stone will be broken up and then cleared up. So this is the access, and then this is access can be complete clearance, you can get it. And sometimes you have a multiple stone like this where impossible to clear all the stone by PCNL. And here we have used in supine position the puncture of the kidney. And then your colleague here is Abhishek Singh, who is doing the flexible ureteroscopy. I am doing the PCN, and with both of us approaching the kidney from below as in upward. You can see here I punctured the kidney under the ultrasound, and he has been dilating the ureter. Once we both are there, there are multiple stones which needs to be coming out. And this is a PCN site. This has got a suction as well, so it will keep the break the stone as well, or it will suck it out. And larger one you can pick it up, but you can use once you are clear the stone from that axis, then you can ask your colleague to Abhishek to pass the flexible ureteroscope. Here is the flexible ureteroscope, which has been the stone was brought near to the PCN, and then it was with a laser, it was disintegrated. Again, you can see that it's multiple stone, and here again each stone is brought down. Either they are broken and it will be sucked out, or it can be brought down and it can be removed with the PCNL. So this is the combination of therapy, and it works very well. And I think if the stone is impacted, you break the stone with a flexible ureteroscopic, like in this case, and fragmentation followed by suction. And I'm just going a little faster to make sure that I cover everything. And here is a complete clearance. I left the PCN because there's a multiple stone, and here is the stone fragments. And here, if you can see that left complete clearance of the stone from the other side. This is only possible with PCNL and ureter. Only one puncture, and rest of these all flexible ureteroscopy. Now we have a robotic URS, and this is a few years back. Me brought this robot to Nadiad for a trial, and now it is in the finishing stage. Maybe we will be getting it slowly, but here you can pass the scope into the kidney, and it is easy to maneuver into the kidney, and you don't have to use different hand movement. It is done by automatically by the equipment. Now this is a different machine, not a turkey machine, and this is likely to be available in short time. So that will also helpful. Robot is coming, technology is improving everywhere. So this is another stone, and sometimes this stone I thought would be excellent for the PCNL, except when I looked at the IVP, it's a mal rotated, and there is no way I can puncture this kidney. And the stone is also here, and it is a very, very difficult stone, even for me.
I rotate like in the right kidney. It's a left kidney, sir.
Left kidney, left kidney. Yeah, it is in left kidney. All right, and it is a mal rotated kidney, and the pelvis is facing out, and here is the flexible ureteroscope. You can see the vision very nicely, and we are trying to negotiate so that we can go to the stone. Now we can see the stone, and once we are stone, the stone was disintegrated completely. And let me confess, this stone we kept it for a Oliver texture, and then when he had come for the workshop, and then he beautifully did it. This is done by the Oliver texture, and this was done, and complete stone was completely disintegrated, and then you can see that the picture. The end picture was that there was a complete clearance of the stone. So sometimes people are doing sandwich therapy, RIRS with microperk, and but you know, it is the same as I showed you earlier, but due to the time, I think I will go further. And now I would like to talk about the recent development at the disposable scope. And along with the disposable scope, as something which is interesting, it comes suction, a urethral access sheet with suction. And here you can do the ureteroscopy, dilate it, and then you use a ureteric sheet with suction, which will come up to the pelvis. After dilatation, you put it, and you go up to the pelviureteric junction, and then you pass a flexible ureteroscope, and then apply the suction here. So two advantage. One thing is when you do this, there is no intra-renal pressure increases, and you can suck it out. At the same time, the dust will all sucked out, and you can fragment the stone to the minute thing, and majority of the small particle will be sucked out from this thing. So it is a very simple device, but two advantage. As I said, the decrease in intrarenal pressure and the small dust will be taken out. But then we thought that sometimes dust is there in the lower calyx or different calyx, and if you keep a suction tube at the perioperative junction, it is sometimes difficult. So this suction tube you can maneuver in each of the calyx. Once you visualize by putting a dye, or you can just visualize by there is no telescope in this suction. So once you have done it, you got to see on fluoroscopy and maneuver the thing. So here is a patient with a stone, and this is the dilated. This is a CAVAC, which is malleable, and here is the irrigation, and the other end you can manage to turn the tip accordingly, and there is a suction there. And here we have passed the routine sheath, and then we visualize the stone. Stone was disintegrated by the flexible ureteroscopy, and you can see into a small particles. And once it has been done, you are passing the suction tube, KVAC, in, and then you're going into each calyx, and then trying to suck out. And you can see the suction. Once you're finished, you can again do the flexible ureteroscopy to check whether any stone is left behind or not. If there's a large fragment, you again break it and then make it a small fragment, and then you can suck it out again. So similarly, this is a very device. Still, it is not in the market, but we did a few cases. about 12 to 14 cases, and we found that it has got an excellent. Only thing, our suggestion was that even if you have a small telescope, then we can see where to go and which fragment to suck it out. And so this is the one. Now, at the end of the thing, you can see that the very small passable fragments are left behind. So, and there is another one. This is the stone here, and here you have you puncture the kidney, which is with the tip is little malleable, where you suck the stone, and then through the flexible ureteroscopy, you push the stone on the tip of that Piscian sheath, and you break the stone. And this is a suction, active suction going on. So the stones are sucked out, and with the flexible ureteroscopy and a small malleable Piscian tube, you can clear the stone completely. So I think what has happened with the presence of a complete clearance was achieved with the presence of high power laser and the miniaturization of the equipment in PCN as well as in ureteroscopy. I think the development of suction is very, very important. And lastly, I feel that whatever you do, training is very important. Now the speaker previously was talking about you have to do a 30 cases or a 50 cases or 100 cases. Why do that on a patient? This is a simulator which we have, and here you have different things you can do, how to pass into the ureter. I can visualize, and then there's a grading system which is given. So, here is a stone, and then you can do the dye study, and then you can start to localize the thing. This is all animation where you can see how it is done. Then once you're done, we can do the clearance. For example, I have one training module and another is the live, and I'm comparing the both. Here is a diverticulum with a stone, and here is also a diverticulum with a stone. This is a live on my right side, and on the left side is the animation. This is on the machine, and this is and here. So here it is past, and here is a live, and both are almost going up similarly. So if you do a practice like this, so there is you get expertise, and then once you are there, you should know how to enter the infundibulum. So you need to do a dye study. Now here you already reached there, and here you can see that the use of methylene blue and the dye, where you can see the small opening, and here you have reached up to the pelvic-ureteric junction, and then you can do the dye study. Just a minute, and see, here is the dye study. You are in a different calyx, so you go to the proper calyx and then do it. And here is a stone, and here again you are going into it. Again, you should do a dye study to see where the calyx is, and then once you go there, and you will be able to see the hole, and with the laser you divide that, and then stone will be seen. And similarly here also on a model you can do the same thing, and then you can do. So training is possible with a simulator where you can do flexible ureteroscopic training, and this is very, very important. I think future is not doing the training at the expense of the patient. It is training in the lab, and then you go into the to do it on the patient as an expert, because whatever training you have achieved will help us in doing it. I will just go forward as so here the results, the level of operator anxiety is nil when you are doing on the mentor. Endpoint operator training. Endpoint is important. You have to identify the infundibulum, you have to break the stone, and the option of repeating the procedure for improving the skill possible. While when you're doing that directly, level of surgeon's anxiety is very high. end point is stone clearance and options are not possible. So is it worth doing the practice? Well, enhanced multidimensional learning experience, skill acquisition, skill development, skill maintenance, skill validation is very important. Even if you are doing ureteroscopy, at time you should do the practice, so that important in skill maintenance is there. And that improves the patient care, increase the competency, and decreases the cost, because in one sitting you can completely clear. So that is what my thoughts are, that flexible ureteroscopy with the new ureteroscope is very, very useful, and one can keep it in our armamentarium. You can use it, you do the selective of the cases, and you can combine both judicially. But before getting practice, go to the lab and then do the practice, so that you are already expert when you are doing into the teaching. That's what I see as a future. And of course, the suction with laser is, I think, has really changed the scenario. We are at the moment getting a complete clearance of the stone. Thank you very much for kind listening and the opportunity to talk.
Thank you, sir.
Thank you.
Thank you. That was a wonderful talk. And there was a round of applause to sir. And you have very wonderfully summarized starting from training up to the robotics in flexible ureteroscopy. Thank you, sir. Thank you, and we're honored to have you. And I'll quickly pass the mic on. 1 second, sir. There's a comment from the expert here.
Mahesh Desai, sir, excellent talk, sir. Especially post partial nephrectomy case, ultrasound, the guided puncture, and then flexible scopy. Most updated things. The only question I wanted to ask is this KVAC. Is it optically guided or it is CM guided?
No, it is ultrasound guided.
No, sir. From the flexible ureteroscopy suction which you have shown, is it the scope which has suction or it will be fluoroscopy guided?
Fluoroscopy. But we are planning that the suction tube should have a small fiber optic light source.
Yes, sir. Yes.
So that we can see it. At the moment, it is fluoroscopy.
Great, sir. Thank you very much. Excellent talk, sir.
Thank you.
Thank you, sir. Thank you.
So, Kandarp, you include this in your instrument. The training model should be there in your book.
Yes, sir. I think it's a very valid suggestion, and I really enjoyed your talk. And many new things I think many people have heard for the first time. For the KVAC, I just have only one simple resistance at this moment. As you correctly said, that it is to be ultrasound, the ICM guided the manipulation in the kidney. Now, during RIRS also, in the initial part, some people are using a lot of fluoro. And you are adding on the fluoro. Now, if you are doing RIRS on a regular scale, I think your radiation exposure will be too much to your, as well as the patient's radiation exposure will be too much. And secondly, when you are sucking the system, I think sometimes it can produce, because it is an unguided, non-visually guided suction. So we don't know where we are sucking, and it might cause some kind of a petechial hemorrhage to the submucosal vessels. So maybe the fluid will be turbid. These are only two reservations at this moment. But as you said, that if you incorporate some kind of a telescope into it, I think life will be very easy for the RIRS surgeon.
That is the first answer to your question. There should be a telescope with the light. For the second one, what we do is we do the irrigation. The irrigation has to be there before you suck. So that reduces any type of small bleeding will be there. I mean, I cannot do that. When the fragment with the fluid, it flushes out and sucks out. So that would be, we have seen it, and it is very, very impressive to do that. And most important is there is intravesical pressure doesn't increase. So patient doesn't feel any post-operative pain. So that is a very, very benefit. And I really enjoyed all the talk in the session. Everybody has done wonderful presentation, and they have covered the topic very well. It was enjoyable, and it was also a good few of the things I learned from that. So thank you very much.
Thank you, sir. Thank you once again. I pass on the mic to Brajan to complete the session with Dr. Ravi Jain's talk.
Thank you, Deepak. Mahesh Desai sir has shown us that the only limitation that we place before us is the limit of our imagination. So coming back to the presentation, the final presentation is by Dr. Ravi Jain from Ahmedabad. He'll be speaking on management of residual fragments post-RIRS. Dr. Ravi.
Good morning, everybody. Thank you, Urological Society of India, Young Urological Society of India, for giving me this opportunity to present on management of residual fragments post-RIRS. Every urologist is very happy when he's able to offer his patient the most advanced and minimally invasive form of stone management, RIRS. But when the patient comes to us back with residual stones, definitely the surgeon is not that very happy. And if the urologist keeps having residual stones after the most of the procedures, he definitely feels at crossroads. So, residual stone, are all residual stones similar? There is a term known as clinically insignificant residual fragment, and it goes by the definition of stone size less than 4 millimeter on the NCCP KUB. But is size the only factor? No, it would be like looking at a glass either half full or half empty. But then that is a two-dimensional vision, because also other than the size, a fragment which is asymptomatic, non-obstructing, and non-infectious care after the end of the procedure is a clinically insignificant residual fragment. So we all know, friends, that PCL is a modality of choice for stone size more than 2 centimeter, and RIRS better serves for stones up to 2 centimeter. Hence, according to the RIRS scoring system, we know that there are chances of residual stones with lower calaceal stones, especially with acute infundibulous pelvic angle and stone size more than 2 centimeter. So, assessment of residual fragment, what is really important? It is how to assess the residual fragment, when to assess the residual fragment, and assess really what is significant. How to assess? So, NCCT KUB is the modality of choice because it has got the highest sensitivity. It can detect up to less than 2 millimeter of fragment, but it has got radiation hazards, cost, and availability are the issues. Endoscopic evaluation by the surgeon at the end of the procedure has good sensitivity, can detect stone size more than 2 millimeter fragments. Friends, here, guide wire is the thing to be compared for comparing a residual fragment, and not the laser fiber, because nowadays the fiber diameters are variable. USG KUB again has got a good sensitivity for fragments more than 2 millimeter, no radiation hazard, available and cheap. X-ray KUB falls nowhere in the guidelines. So, second question is when to assess? Should it be immediate post-op? Nah, because the patient would not have a clearance by that time. 3 months post-operative period is suggested by a few authors, but that would be, I guess, too long. So, the most practical and the commonly followed thing is 1 month post-operative period when we plan to remove the DJ. So, residual stone, is it significant? Yes, it is significant because it can cause stone reformation, stone regrowth, UTI, ureteric obstruction, and residual stones with metabolic diseases and infectious stones such as carbonate hepatite and stromal stones can form a nidus again. But again, how much is significant? Because more than 50% of the patients with residual fragment on NCCT will not experience a stone-related event. So how do we manage the residual fragment? Modalities of medical management, ESWL, RIRS, PCNL, or observation. Hence, let's go into the details of each of these. Medical management mainly revolves around the cited therapy, especially useful for the uric acid stones. Metabolic workup is ideal. It definitely decreases the stone recurrence and inhibits new stone formation. ESWL, excellent modality, good stone free rate, minimal invasive, less complications, but we have to explain cost to the patient. PCNL, invasive procedure, higher chances of complications, and usually suggested for residual fragments. And again, cost is the definite thing. I would like to discuss some special situations. She is a 56-year-old female with horseshoe kidney with bilateral obstructive uropathy. Patient was operated for left PCNL, but it was attempted and was not successful. And the patient was referred to our center. And looking at this complex PCS, I did a staged RIRS, two-stage RIRS, and I could successfully clear more than 95% fragments on the left side. Now for the small, non-obstructing ischemic cal, do you really think should we treat this residual fragment? Maybe. Second case of a malrotated kidney, patient with a blocked calyx, the scope is not able to go inside. So this patient will also be reported as a residual fragment. But question again here is, should we treat such a residual fragment? A third case, a patient with a 13 lower calaceal stone with a long infundibulum, the scope reaching with an acute angle. Now, if this patient has got a 5 lower calaceal non-obstructing fragment, should we treat? And if yes, then re-RIR is very difficult. Mini PCNL for a 5 stone, how many will raise their hands? And ESW with low clearance rates for a lower calaceal stone, really we need to think upon. The fourth case of a malrotated kidney patient is a recurrent stone former, stone burden more than 3 centimeters in all the calyces, did a staged RIRS, and successfully cleared more than 95%. Now this patient has got a 4 lower calaceal non-obstructive stone. Should we really treat this residual fragment? Hence, what I mean to convey is, like any stone surgery has to be safe, effective, and available, and it has to be decided on the basis of evidence, experience, and expertise. Similarly, all residual fragments are not similar. Even all these residual fragments need to be understood and need to be dealt as case to case. Our own data of 225 patients where we had a clearance of more than 80% and we had a clearance of more than 95% after staged RIRS. Only among the modalities for the stone management, residual management, re-RIRS was the main modality of management and could successfully offer to these patients. So what I need to convey more strongly is the residual fragments is known after RIRS, but we need to counsel the patient properly for that. The patient may have a chance of developing residual fragments, and we need to have a proper informed consent so that the patient is ready and he has to understand that he or she has to bear the cost of whatever ancillary procedure is supposed to be undertaken. Otherwise, I'm sure we all would like to avoid this horrible experience. Better stone-free rate in RIRS, uretic access sheet use may or may not improve stone-free rate. Dusting versus basketing has always been a matter of debate. Newer laser TFL may have better dusting, so maybe the residual rate might be less. But the most important thing is the training and expertise of the surgeon will definitely improve the stone-free rate in RIRS. Hence, what I at last need to convey, residual stones, not all stones are clinically significant. We need to really understand which significant stone needs treatment. So we have to understand for that. Staged RIRS definitely has a good stone-free rate. The most important thing in any residual stones is counseling and consent of the patient so that at the end of the procedure, we are not like unhappy Sushant Singh. We are like MS Dhoni hitting a 6 at the end of the procedure. Thank you very much.
So managing the residual fragment post RIRS also involves managing the expectations of the patient in a significant way. Thank you, Ravi, for a very good presentation. I invite our experts, Dr. Kandar Parikh sir and Dr. Ravi Mohan sir, Dr. Chandra Mohan sir, for their observations and comments on these 5 presentations. Kandar sir.
So you're mute, sir. Please unmute yourself.
So for the first presentation regarding ESWL, I think ESWL is still a preference method for the stone up to 1 centimeter in size in upper pole, especially in the upper and the middle calyx of the kidney. Unfortunately, because of the many reasons, the preference for the ESWL is going down. The reasons are already mentioned by our speaker, but I would like to add that maybe because of the poor selection of the case, secondly, the poor quality of the ESWL machine and the financial dynamics, I think they are also playing a significant role in selecting the modality for the kidney stone management. And I tell you one thing, that if a urologist has a stone up to 1 centimeter in size, I think most of the urologists will prefer ESWL. Though RIRS and mini PCNL both are doing fantastic job, but they are slightly invasive. So for the stone less than 1 centimeter size stone, I think if you have got a good machine and personal involvement of a urologist probably will make a difference in the result of a ESWL. I think Chandramohan, the next comment for you.
Sir, due to time constraints, first session, all the comments you please give, sir. Other sessions I will give. Whatever you said, I agree. Even if it is less than 1 centimeter, we are slightly going for the RIRS than ESWL because it's unpredictable result. In fact, ideal case for RIRS is 1 to 1.2 centimeter. Very ideal case, even for a beginner. So, sir, continue this session, expert comments, sir. Next session I will do because time restriction. Thank you, sir.
Okay. So regarding the thulium fiber laser talk, I think I agree that thulium fiber laser is going to be the future, but still we are waiting for the data because it's a good dusting device. It's not a very good fragmentation device. So its use in the PCNL, I think probably will not be, it's not very good idea to completely dust the stone and producing a result like what we do with the RIRS, because we still need to clear the dust. So, and secondly, important thing is impacted ureteric stone. I think I'll be very hesitant using a thulium fiber laser over a holmium laser. So otherwise, thulium fiber laser, I think many companies are coming, many modifications will come. The third important thing is that the initial purchase cost of the thulium fiber laser is slightly higher, and we have no, though it is said that there is a less maintenance involved, but when I discussed with the company people, they said that there is no much idea about the maintenance because it's the diode that is pumping the energy in thulium fiber laser, and many diodes are connected. And the circuit within the box is so complicated that you cannot change one diode. So you might have to change the entire assembly if the machine fails. So in that case, it's going to be very, very expensive. So I have no idea about it. Maybe in future, we'll get answer to this question. I think the third talk, the selection of the flexible scope, which one should use. I believe that reusable flexible scope, that is FlexX2S or P7 from Olympus, I think it was a preference by many people because digital costs, digital flexible scopes are very expensive to begin with, though they are wonderful. And now there is a miniaturization in digital scope also. But with the introduction of this limited use disposable scopes, either from Pusen or a BioRad or some other companies, I think for a the person who is starting the RIRS program, I think they are better off buying this kind of a scope where you can use this scope for at least 10, 15 times. And so the working cost goes down. And even if you break the scope, the initial loss is less. So with this advent of this new limited use disposable ureteroscope, probably in future, this will be the first choice of majority of the urologists who are starting. And also you can reserve it for the complex anatomy where the breakage is more. The fourth, I think Dr. Ravi Jain's talk regarding residual stones. Initially, it was thought that clinically significant residual stones are up to 4 mm. Now it has come down to, if you review the literature, it has come down to 2 mm. And now, according to Dr. Olivier Traxler, whatever dust you make, the dust size has to be 250 micron in size. Otherwise, you will leave a lot of stones in the kidney. So our aim has to produce this golden dust. And I think probably that is the reason the thulium fiber is gaining a popularity, because there is a possibility that you can produce a very good dust. But with the holmium also, I am very, very happy. Residual fragments, I evaluate the patient after 3 weeks. And with the I do a post-op CT scan. I don't rely on X-ray or sonography for the follow-up because it is sometimes misleading. CT scan gives you a fair idea whether you left behind the stones or not. So these are the some of the comments for this talk. I don't know whether I am forgetting any other talk or not.
Thank you, Kandarp sir. I will comment in the next session. I congratulate the speakers. They have really focused on the talk. Time also focused and unbiased facts they have given. Let it be disposable scope or thulium fiber laser or the relook of the stones. I congratulate all of them. Very well done. Thank you.
Thank you, our experts. Because of paucity of time, we will be straightway moving to the next part of our session. Dr. Deepak, you may take over from now.
Thank you, Dr. Bhajan. I guess that was a wonderful session of 5 talks. They've given a good start to the session, and we're running a bit late. So we'll get going with the next session. That would be videos. So Dr. Tanuj Paul Bhatia from Faridabad will be giving a talk on step-by-step RIRS for lower pole stones. Dr. Tanuj?
At the outset, I would like to thank you for this opportunity. I will be talking about step-by-step RIRS for lower pole stones. So the first step to a good RIRS, be it any polar stone, is a good preoperative workup, which includes a good imaging in form of a CT urography or a IVP. If you are doing a NCC TKUB, better to do a RGP before you proceed intraoperatively to know the anatomy, and a sterile urine culture. Why it is important? Because we need to know the infundibular length, infundibular width, and the infundibulopelvic angle, because that dictates the success of our lower pole RIRS. So the second step is intraoperatively we do the road mapping. For this we can do a simple ureteroscopy or we can do a RGP. I prefer to do a ureteroscopy in most of the cases. Then you can pass your guide wire, and if you want, another safety guide wire. And then you have to pass the access sheath. This has to be very gentle under fluoroscopy guidance. If you face any resistance, better to come in another day, put in a stent and come out, or you can go without the access sheath. But this has to be very gentle under fluoroscopy guidance. As a fourth step, when you enter the PCS, always inspect all the calyces first, rather than going directly to your target calyx, because with flexible ureteroscopy, one of the advantages is that you will see many of these small plaques or very small tiny stones inside the calyces, and if you manage these stones then and there, then you are rendering the patient stone free for a longer time, because they will not develop into larger stones. And after that, you can go to your target lower pole stone. You can see how the infundibulum is, how is the width and the length of the infundibulum again, and how big is your stone. Just enter all the calyces and inspect. As a fifth step, it is always recommended to transfer the lower pole stone into a favorable calyx. Why? Because it offers a higher stone free rate and a longer scope life, although it does increase your operative time. So now when we have to transfer the stone, there are certain ways by which we can do it. I prefer to do it using a 200 micron laser fiber. I just drill into the stone and take out the stone from there and put it into a favorable superior or a middle calyx. Of course, you have to again see the infundibular length and width before trying to do so. Other ways to do it is by using baskets. We can do it using a 4-wire basket like an N-circle, or using a N-gauge or other baskets, but I prefer to use an N-circle basket because it's very easy to release the stone if it gets stuck. You just have to open the basket, push it against the mucosa, and it would generally release. Of course, you need a good assistant who is, who knows how to use the baskets. Also, when you are trying to transfer a stone with a basket, most of your field of vision is occupied with the stone. So you better to follow the guide wire if you have to enter the superior calyx, or you can do it under fluoroscopy guidance. So there are certain tricky situations where transfer is difficult. One such tricky situation is when there is a large and a hard stone, which you may not be able to transfer very easily. So you can just break it into large fragments, then you can transfer each of these large fragments into a superior calyx and then break them into dust there. Also, sometimes there can be long and narrow infundibulum and you are not able to transfer even the larger fragments. Then you can just break the stone in situ then and there. And you have to start with dusting and end by popcorn, and towards the end you can pick up those larger fragments and render the patient stone free. Of course, you would like to use either a disposable scope or one of your scopes which already has a couple of dots, because you don't want to damage your new scope in such cases. Also, there can be diverticular stones which seem like one stone on the CT, but actually they are generally multiple stones. One can do a blue dye test to identify the opening if it is not seen. Generally, we see these multiple stones covered by a layer of thin mucosa. So you can just fire over the summit and open it up. And then you can just use your saline irrigation and the stones would just pop out. And then you can increase the opening further and you can pick them up with the basket if required. So many times there are these difficult to approach minor calyces where you will be just seeing the stone, but you will not be able to really reach it to fragment it. So what we do is we decrease the pulse to short pulse. That makes the stone to jump out of the calyx, and then you can do some popcorning or basketing and manage those stones. Another way to manage it is by using a ball tip or a fiber cut flush with the sheath through a bent scope. That's how you can reach those stones. So the last step to management of stones is the lithotripsy. Whether you are fragmenting after transferring it or in situ in the lower calyx, we always start with dusting so that most of the stone we create into dust. And we end inadvertently, there would be some larger fragments which are created. So we finish by popcorning, and in the end, we can pick out the larger fragments, send them for stone analysis, and also show it to the patient. Thank you.
Thank you, Dr. Tanuj. That was a crisp talk, and I guess the youngsters watching should realize that the more seamless RIRS looks on screen, that means to say the surgeon has got his basic steps perfectly on. So thanks, Dr. Tanuj, and we'll get back to you on any comments. So now we'll ask Dr. Karthik from Trichy to give his talk on ECIRS, position, ergonomics, and procedure. Dr. Karthik.
Good afternoon, everybody. I'm going to take you through a video demonstration on ECIRS, and I'm Karthikeyan Naganathan. Endoscopy combined intrarenal surgery combines supine PCNL with RIRS for the management of complex upper tract stones. It has the advantage of high stone-free rates without the need for any additional puncture. Thanks to these three gentlemen who had contributed immensely to the evolution of ECIRS. It was Professor Cesare Scoffon who coined the term endoscopy combined intrarenal surgery, and it was him who actually popularized this procedure. ECIRS is indicated for complex upper tract stones involving pelvis and multiple calyxes. Combined ureteric and renal stones can also be treated with ECIRS. Proper positioning of the patient is paramount for a successful ECIRS. After induction of anesthesia, the patient is kept in the lithotomy position, is brought to the edge of the table, and two bolsters are kept under the patient, one at the level of upper chest and another at the level of pelvis. We don't need too many OT personnel to actually position the patient for ECIRS. The flank is kept free to allow easy manipulation of the scope. If needed, the opposite flank can also be supported to avoid sagging of the patient to the opposite side. Positioning a obese patient is a challenge for any procedure. In case, if needed, we can even strap the abdominal pannus to the opposite side to keep it away from the surgical area of interest. Here, we are seeing two lines both starting from the posterior axial line. Marking of the posterior axial line is very important for a successful supine puncture. The cranial line is marked after rotating the torso to the opposite side, while the caudal line is marked before rotating. If the cranial line is taken as a landmark, it may lead to a difficult puncture and even chronic injury. So, it is always better to mark the posterior axial line without rotating the torso. Having two teams of urologists with a complete endourology armamentarium is a basic prerequisite for an ECIRS. Having an ultrasound machine within the OT is not mandatory, but definitely helps when you have an enlarged liver or spleen, especially when you have a suspicion of retrorenal colon. This is a schematic diagram representing the OT setup and the position of monitors for an ECIRS. Proper placement of monitors and the energy sources is very important for an ergonomic setup for the operating surgeons. Both surgeons should have their corresponding monitors in straight line, preferably at the level of their eyes. The fluoroscopy monitor is positioned in such a way so that both the surgeons should have an uninterrupted vision. The supine PCNL surgeon can actually sit and complete the procedure comfortably. We routinely do ECIRS under regional anesthesia. After placement of retrograde catheter, we first do the supine PCNL followed by the RIRS. Here, the supine PCNL is done through the lower calyx. The lower calyxal component and the pelvic component are cleared with the supine PCNL. The flexible scope image is shown on the left. The flexible ureteroscopy is advanced to the upper calyx. Stone in the upper calyx is fragmented and basketed with an engaged basket and moved to a common location. from where, using a grasper, the fragments can be collected and cleared through the nephroscopy tract. With this, the fragment clearance can be rapidly achieved while doing a ECIRS. This patient had a complex upper tract stone with a main stone bulk in all the three major calyxes and a large stone in the upper ureter. While the upper ureteric stone is getting fragmented with the RARS, we did a supine mini perk to the superior calyx. Because of the large stone bulk, the entire calyx was filled with stone and there was not enough space to park the MAP access sheet. We kept the nephroscope just at the outside of calyx and the stone fragmentation was started with laser. After clearing the stone, we got enough space and the amperage sheet was advanced to the calyx. The entire upper calyxal stone was cleared with this maneuver, and after clearing the upper calyxal stone, the flexible ureteroscopy was advanced and the stone in the middle and lower calyxes was basketed and cleared through the nephroscopy tract. Antegrade access can be precisely achieved with the help of endovision technique. This patient had two parallel calyx and the stone was located in the medianmost calyx. Precise puncture was possible with the help of an ureteroscopy assisted puncture. Lithotripsy during supine PCNL can be achieved with either lithoclast or laser. During ECRS, there is no need to dust the stone while doing RARS. Care must be taken to avoid damage to the endoscope. It is preferable to park the flexible ureteroscopy in the upper ureter while the nephroscopy stone fragmentation is under progress. Because of the continuous irrigation from below and the horizontal position of the tract, passive stone clearance is an advantage during ECRS. The overall operative time is shorter because of one of the reasons for a overall shorter operating time is because of the passive stone clearance during ECRS. Avoidance of multiple tracts and the resultant less nephron loss and bleeding chance is the greatest advantage of ECIRS. Anesthesia related advantage cannot be overemphasized. Cardiovascular and respiratory parameters are definitely better with this position. The overall operative time is shorter and the procedure can be completed under regional anesthesia. Look at the beauty of ECIRS. This patient had a large upper ureteric calculus and stones in all the major calyxes. Supine PCNL was done through the lower calyx and the lower calyxal component and the upper ureteric component were cleared using supine PCNL. Flexible ureteroscopy was introduced. Stone in the upper calyx and the lower calyx was basketed and handed over to the nephroscopy and cleared through the percutaneous tract. By this, we could avoid multiple tracts with the ECIRS. To conclude, we need two surgical teams with complete armamentarium for a successful ECIRS. The procedure can be completed under spinal anesthesia. Proper case selection is very important to achieve maximum stone clearance with minimal nephron loss. I thank one and all for your patient listening. I will be happy to take any queries at the end of this session. Thank you for your
Thank you, Dr.
patient
Karthik. That was a very crisp and well compiled talk. I will pass on the mic to Dr. Chandramohan for his expert opinion and comments.
I appreciate Dr. Tanuj Pal Bhatia and Dr. Karthikeyan for good, nice presentation. Both I have one question and then we will conclude. When will you say after going inside that I will not do RIRS? On your clinical experience, a large stone, when will you say that no, it is not at all good case in the first go only?
Sir, first of all, more than 2 centimeter stone in a lower calyx, I would not go in for RIRS. Secondly, I mentioned there are sometimes those very difficult to approach minor calyces which are very difficult to approach with your scopes.
Okay.
And if it is not amenable, it is not amenable. Then we go ahead and do preferably a PCNL, mini perk or ESWL. So those are the two conditions. Sometimes I have encountered verticulums which are just not
reached.
you can just not see the opening, and if it's too much far away from the calyx, you don't want to make a false track or something there. So we can just leave the stone as it is.
I also add to that a stone which has very broad base and cannot be seen all around with the iceberg on the top. Usually it gives trouble. After doing half, we realize that we are not able to do it, wasting time. In that, it's a very good case for PCNL because it's a very broad base towards calyx. Excellent video, Tanu sir.
Thank you, sir.
Karthikeyan, are you there?
Yes, sir, I'm here, sir. Can you hear me?
Nice presentation. I want to ask you one question. If you have all these stones kept in the pelvis, in supine PCNL, which calyx you prefer, lower or middle? Upper, I am not asking. Lower or middle, if given choice, both can be approached to the stone. Which one you prefer?
Lower calyx, sir.
Lower calyx.
Lower calyx.
Because sometimes we feel that we have to go to the thigh to enter the lower calyx in supine PCNL. You have to start marking below the iliac crest. Do you think it's a problem or it's okay?
Yes, sir. It depends upon the patient's habitus.
Yeah.
Bulky fat at that area, then it may be better to go to the middle calyx. Otherwise, most of the time we prefer the lower calyx.
You prefer lower calyx. Thank you. We will go to the next session.
Thank you.
Thank you.
Thank you, Dr. Tanuj and Dr. Karthik. And we'll move on to the more intense phase of the session, the last part of this session 2, the debate. And I'll read out the clinical scenario that we have given to the speakers. 1.9 centimeter lower pole renal stone, a Hounsfield density of 900 Hounsfield units, 50-year-old naval officer, wants an early clearance, and is afraid of a digestion being placed inside. He's got no symptoms though. He would go with whatever the doctor suggests. And now we have two masters in this. The first one would be taken up by Dr. Siddhalinga Swami from Hyderabad. He's talking for RIRS. Dr. Swami, yours.
Thank you, sir. Thank you, USI and you for giving me this opportunity. So today I will be debating for a 1.9 centimeter lower pole stone pro for RIRS. So the case details as described by the sir. I want you to focus on the CT film and the details of the stone here. It's a lower calyx compound stone with 19 mm in diameter, good functioning kidney, and with a wide infundibulum over the calyx and infundibular pelvic angle to be obtuse. It is 92 degrees. And I would definitely say RIRS is the best option for this patient. Why not PCNL? I need not explain. The pictures themselves will speak for you. No need to go into the details there. Why only RIRS? Yes, there is definitely early return to work, no bed rest, no restriction of physical activity, minimal pain, no puncture, no risk of bleeding, no loss of renal function or morbidity, and the fastest recovery. The pictures on the right sides are nothing but a happy kidney. So let us go a brief about the literature. What does it say? So this is a meta-analysis published in 2017, mini PCNL versus upper ureteric stone RIRS, which has clearly mentioned the hospital stay in favor of RIRS with an odds ratio of more than 3 and a hemoglobin drop in favor of RIRS. So most common what we are studying today is a lower pole stone of 10 to 20 mm calyx stone, lower calyx stone. Mini-PERC versus RIRS meta-analysis has definitely shown hospital stay in favor of RIRS, where the naval officer wants to go back to his normal activity as fast as possible, and definitely the overall complications are definitely low. So I would like to brief on this 2015 paper, which has clearly mentioned RIRS versus PCNL, not mini PCNL, it's a PCNL for a stones more than 2 centimeter with final stone free rate of 100% in both the scenarios. And I would like to highlight that the initial stone free rate is not 100% for even PCNL also. So lower pole stone 1.5 to 2.5 centimeter study, multiple studies are done. I would like to highlight this study because the stone free rates are almost similar to the mini PCNL here with the least possible complications compared to the mini PCNL. So size of the stone and the location, lower pole, are the two most commonly debated for the RIRS. So size, now we have many articles which support RIRS even for more than 20 mm. Stone free rate is almost comparable to the mini PCNL. A simple relook will definitely improve the stone free rate on par with the standard PCNL and not the mini PCNL I'm talking. And definitely less hospital stay, no blood transfusion, angioembolization, no injury to the surrounding structures. So things we need to consider, as Tanush Pal sir has made my talk much easier: infundibulable angle, width, and whether the scope will reach the stone or not. So multiple studies have given LBC has been commonly practiced for more than 70 degree of wide angle, length of less than 3 mm, and width of more than 5 mm. But I would like to highlight this study done by Bhaskar Soman and et al., which has clearly mentioned only the infundibulopelvic angle is the one which predicts the clearance of the lower pole stone in RIRS, and definitely our case has an obtuse angle, which is favoring the RIRS. So there are multiple studies which have mentioned about the infundibulopelvic angle, not yet standardized. Clinically, we can't decide whether this angle is going to obstruct ours or not. Here, the clinical scenario, you can see a live case where lower calyx, deep inferior calyxal angle, it's an acute angle, but still we were able to go into the calyx, see the stone, fragment it, do into multiple pieces, basket them out, and complete clearance of the stone was possible in situ without any trouble. Patient went home the next day. So angle, does it clearly matters for this? Really, I doubt about that. So why not RIRS? No harm in going with a flexible scope and have a look of the stone. We can always fragment the stone and relocate to the accessible calyx. We do have fiber optic soap with better lower calyxal approach, and we do have special laser fiber designed to work better in a lower pole. So we have two armamentum which has added to our advantage in RIRS is a disposable scope and a thulium fiber laser. Disposable, probably it's an ideal indication in this case, especially for a large volume and a lower calyx stone. We can do more daring and boldly in these stones without the risk of scope damage. I would like to say the image quality is on par with the digital scope. With a better image, gives a better clearance of the stone. Thulium fiber laser is definitely a greater advantage. 4 times faster you will be able to break the stone. Duration of surgery is less than half of that, what we are practically doing in our setup. So types of fragmentation and basketing, everything Tanuj Pal sir has explained, the same things. So whenever we have a stone in the lower calyx, I would like to do a partial lasing, fragment into multiple palaces, and pick up these fragments and put into another calyx and completely clear the stone on spot. So one more calyx, in situ lower calyxal stones. If you are able to see the anatomy with the RGP, you'll be surprised to know such an infundibulum, deep infundibulum with the bifid system. But when we reach it, the flexible scope, it's a easily accessible stone. If you are able to see the stone completely like this clearly, then on that day the surgery is done. Basket one of the stone which is accessible, and in situ lasering of the other stones which is in the lower pole and give the clearance. And many times it has been talked about the clearance. So I would like to show this video where we have done the lower calyxal stone complete powdering. And after the powder has been done, we are using a long access sheath to completely wash out the powder on spot. Complete clearance of the stone. Powder can be done in situ without any require of a special suction or device or any other devices. This definitely reduces the patient relook, definitely reduces the patient acceptance here. So given a chance, whenever possible, better to avoid this on any kidney. So RIRS is the treatment of choice. Thank you, sir.
Thank you, Dr. Swami. That was very well summarized. You made your point on RIRS. That's a quite strong debate there. Now we'll pass on the buck to Dr. Sudhir Devana from PGH Chandigarh. He'll be talking for mini PCNL for the same case scenario. Dr. Sudhir?
Let me start my rebuttal with the highest level of evidence that we have,
I think
particularly
we
in the
need to
form of
change.
meta-analysis. Of course, there is some old literature which included only 2 randomized control trials in the meta-analysis.
If it's a recorded one,
which
can we
has
stop
suggested
this?
that.
Yeah.
Respected chairpersons and dear delegates, a very good afternoon to all of you. First of all, I want to thank the Youth Organization of USA for giving me an opportunity to be a part of this academic event. I will be debating in favor of mini PCNL for a 1.9 centimeter lower poral renal stone in a naval officer. So obviously we all know that he is in a high risk profession, and our goal should be complete stone clearance in him. He is also afraid of double gestant as well. So considering all these issues, I think everyone in the audience would agree that obviously mini PCNL is a better option for him rather than RIRS. There is no debate in it actually. So if let us consider the preoperative counseling in this given case. So if mini PCNL is the option, obviously we will counsel him that there is no need for degestenting. You will achieve immediate on-table stone clearance. And of course, there is a risk of bleeding with this procedure. However, with the miniaturization of the scopes that we are having now, the risk of bleeding is negligible, I can say. But on the contrary, RIRS, obviously majority of the surgeons would prefer to place a degestant before taking him for surgery because the stone bulk is high. And even after surgery also, they will consider the risk of bleeding is negligible, I can say. But on the contrary, RIRS, obviously majority of the surgeons would prefer to place a degestant before taking him for surgery because the stone bulk is high. And even after surgery also, they will consider putting a degestant at the end of the procedure. So that is going to take some part of time. And then you can't guarantee immediate stone clearance on table after doing RIRS. Obviously, the gravel or the dust which is there in the system, it has to clear by itself. And so that is not under our control. So it will take some more time, like 3 to 4 weeks to achieve stone clearance. And definitely there is a risk of even adjuvant procedures also, like doing an RIRS again or an ESW. So obviously, undoubtedly, for in this given case, if you counsel this patient with the RIRS in your back of mind, obviously you can't be confident there will, because there are a lot of ifs and buts in treating with an RIRS. Everything is not under your control. But however, on the contrary, if you go for a mini PCNL, obviously you can do the job better and you're more confident in it. Let us see the operative issues. Yes, in mini PCNL, puncturing this kidney would not be a big deal. Like in the image which I have shown on the right side on the top, where there are narrow infundibulum. Obviously, if you puncture a kidney in that case, yes, there is a risk of bleeding. But however, in this case, it is an easy case. You have a wide infundibulum and it is some amount of hydronephrosis already there. Even to prevent the negligible risk of bleeding, we can even use the Doppler guidance to puncture this kidney also. And coming to the procedure per se, with mini PCNL, you are going to reach the stone with the shortest and the straightest path. You have more freedom of movement. You can use a larger sheath, which is significantly higher when compared to the access sheath, which is used in RIRS. So that will reflect in having better irrigation. You can have clear vision. Continuously, you can ablate the stone. You can use additional adjuncts like vacuum cleaner effect and even the purging effect for clearing the stone. And another advantage is the use of larger fiber laser fibers that you can't do with in RIRS. So obviously with a larger fiber, you have more energy, more modulations. You can ablate the stone faster and achieve stone clearance very fast. And the main advantage of mini PCM is that this procedure, the outcome is actually independent of the renal anatomy. Neither the narrow infundibulum nor the infundibular angles will prevent you in achieving a good stone clearance. But however, in RIRS, you are dependent on a lot of other things. So on-table stone clearance is guaranteed with mini PCNL. Of course, for reducing the morbidity, we have nowadays even people does tubeless PCNL. Even totally tubeless PCNL also has shown in the literature to decrease the hospital stay and decrease the need for post-operative analytic requirements. And of course, even this is an article published just now in 2021, where the mini PCNL has been propagated as can be done as a daycare procedure as well. Let's come to RIRS. Obviously, if my colleague wants to operate him without the need for putting a degestant in him because he's afraid of degestant, but the problem is without degestant, you can have problems like sometimes when you pass the ureteric axis, it will not go because the ureter will not allow to accept the axis. So these difficulties are there. However, even the ureteric injuries can occur if you forcibly dilate the ureteric orifice. So it has been shown in the literature as well that preoperative degestenting definitely prevents high-grade ureteral injuries, and stenting should be considered whenever you do operate in such a larger stone. And when suppose if you gone inside by doing RIRS, obviously the stone is in the inferior calyx, so there are difficulties for ablating it because there are less freedom of movement. After some time, you might have wrist and thumb fatigue also. Even the scopes do get damaged if you do an in situ ablation in the inferior calyx stone. However, if the irrigation, you can't compare with the mini PCNL. Obviously, the irrigation would be lesser, and then the vision would obviously be less, and then all these things will lead to an increase in over time. And the most important thing is Particularly when you are treating a larger stones, the amount of dust and the gravel that is created at the end of the procedure is so much. It can't be cleared so fast with RIRS when you compare with mini PCNL. So definitely there is a risk of missing some of the stones, and obviously that's going to cause depression to the patient because he has still had a stone in that at the end of 3 to 4 weeks. And then the other issue is the intrapelvic pressure. Definitely with RIRS, the intrapelvic pressures are significantly higher when compared to mini PCNL or standard PCNL, and that will reflect in the patients developing a large perinephric hematomas, even severe pyelonephritis. This happened in few of my patients, and definitely there is a theoretical risk of ureteric injury as well. So even the stone size, it has been shown that if you go beyond 15 mm, in particular with RIRS, the chance of complications increase, and even the hospital stay and the chance of incomplete surgery is also increased. And coming to the highest level of evidence, that is the meta-analysis, even the latest published meta-analysis, all for the 10 to 20 mm lower polar stone, says that mini PCNL is significantly superior in effectiveness with higher success rate when compared to RIRS. So in the given case, with the availability of miniaturization of the nephroscope and the associated minimal morbidity with it, achieving an immediate and complete stone clearance, which our patient himself wants, without putting a DJ stent, I think mini PCNL is the best option, undoubtedly, when compared to RIRS. Thank you.
Thank you, Dr. Sudhir. I guess now it's time for Dr. Swami to give his rebuttal.
So Sudhir sir, that was a nice presentation, but I would like to mention 2 points there. So one, if you are using still the laser fiber to fragment the stone in your mini PCNL, so there are definitely residual fragments in your cases also. And all the injuries what you have shown are on the flexible scope, we agree with that. And the injuries what I have shown on the PCNL are on the patients, which is more worrisome. So regarding the stent, not a compulsion. More than 95% of the RIRS what we routinely do does not require a preoperative stenting. And post-operatively also, if we are doing a flush out of all the powder like we have shown in the video, hardly we require a stent. We can put a ureteric catheter for 6 to 8 hours and then take it out and send the patient home back. Cost, yes. Nowhere RIRS can be done. We are doing on par with the URSL charges, which is not practical with the PCNL. PCNL, more miniaturization causes more cost. Cost effective analysis, which has recently published, which has clearly mentioned the cost is almost half compared to the mini PCNL there. So sepsis, as mentioned, hardly seen, 0.7%. Not all postoperative fever or sepsis, and aggressive medical management is enough. Taking necessary precaution can prevent this, still no damage to the renal function. And this is a study of 10,000 cases of many PCNLs, which has clearly mentioned there is still embolization, still sepsis is there. So finally, it's a daycare procedure versus 2 to 3 days of stay, no pain or pain for 4 days, and no restriction activity, or we want a bed rest for 1 month. So RIRS is the treatment of choice for this patient. Thank you, sir.
Thank you, Dr. Swami. Dr. Sudhir, you have one last chance to make your stand now.
Let me start my rebuttal with the highest level of evidence that we have, particularly in the form of meta-analysis. Of course, there is some old literature which included only 2 randomized controlled trials in the meta-analysis, which has suggested that RIRS could be considered as one of the therapy for treating less than 2 centimeter renal stones. But the problem is, if you see the latest new updated evidence, which included 13 randomized controlled trials, undoubtedly PCNL is considered to be the best modality for achieving highest stone-free rates. If my colleague wants to just highlight the bleeding associated with PCNL, I would say that also we should not forget that even with RIRS, you can have significant amount of bleeding at the end of the procedure. And the most important thing is the dreaded complications related to the ureteral access sheath-induced ureteric injury. This is more devastating than a minimal amount of bleeding actually, because the patient will need adjuvant major surgeries for treating ureteral stricture. So I want my patient to decide whether he wants complete stone clearance immediately on table, or he wants complete stone ablation and just to wait for the time to clear the rest of the dust and the small fragments. So with mini PCNL, you are more relaxed and stone clearance is under your control. On table, you can achieve complete stone clearance. Whereas with RIRS, however best RIRS surgeon you are, you have to wait for the time to tell you whether you achieved complete clearance or not. So it's you to decide whether you want to stay relaxed with mini PCNL or with RIRS. If your patient comes after 4 weeks with the CT scan showing a small residual fragment, whether you want to run away from him or not. Thank you.
Thank you, Dr. Sudhir. I think both of you have put your points wonderfully well. Now I'll leave it to the experts to comment on this and give their final words about this.
I congratulate both of them for giving excellent evidence-based medicine, Sudhir and Swami. Both are very interested in their corresponding topic, and they have given good quotations of the recent articles. My opinion is, if in future stone size will not be there and stone volume will be there. So in a large volume is more important, and RGP at the time of the surgery is important. So because we are in the era of the CT, 2 into 1 into 1 centimeter I will go for RIRS, 2 into 2 into 2 centimeter with a large base, given same naval officer. I have not been given the volume. Getting volume is very easy in any CT scan. Otherwise, they have defended very well, and I congratulate them. It is not the question of who won and how many will raise the hand. It is all individual patient and experience. If somebody is doing daily RIRS, he will definitely attempt go inside C. If somebody is doing daily PCNL and less experience in RIRS, he will directly put a rotary catheter and do it. It is all surgeon, and second thing is RGP and stone volume. This. If given choice, what I say is that gentle go inside and see if it is favorable, do, or else don't hesitate to do PCNL. That's why take consents for both. Don't postpone the case. Patient will be unhappy. Kandarp sir, you want to closing comments, please.
So thank you, both the speakers did fantastic job. It's very surprising to see that both the experts who are doing more RIRS are moderating this session. For the first time I'm seeing this. And even a moderator, Dr. Deepak, is also a good RIRS surgeon who is moderating this debate. So I 100% agree with what Dr. Chandramohan said, that you have to look at the anatomy, you have to look at the stone burden or the volume rather than the stone size, and intraoperative RGP. These three factors will be very, very crucial determining. And if you are good at RIRS, you go do RIRS. If you are really good at mini PCNL, go for this case. So, but in my practice, I mean, if you ask my opinion, I will, looking at the scenario, I will do RIRS in this patient because I'm more comfortable doing RIRS and I can produce equally good result as my friend will produce with PCNL or mini PCNL. So I think it's not a question of winning or losing a battle, and both the RIRS and mini PCNL are complementary to each other rather than they are competing with each other. Thank you so much.
Thank you, Dr. Chandramohan, and thank you, Kandarp sir, for taking through this session. Now I call upon Dr. Jishan to take the session forward with this out-of-the-box talks. Thank you, everybody.
Thank you, Dr. Deepak and Dr. Brajen Burman, all the faculty and the experts, Dr. Kandarp sir and Dr. Chandramohan sir, for such a good session. Now we move on to two interesting talks, which are out-of-the-box talks. May I now request Dr. Ajay Kumar, Senior Urologist. He is the past President of Urology Society of India and the Director at Paras Hospital, Patna, to deliver a star talk on qualities of a leader.
Good afternoon, friends. Well, when Keshav rang me up the other day to say something in the Young Urologist Conclave, and the topic he said I should speak on is the qualities of a leader. Well, I was very enthusiastic. Number one, to see the young faces of urology and the future leaders of our of next generation after such a long time. 1.5 years, we have been confined to our houses and our cities, and today, looking at such young, bright faces, I'm really hopeful of the future of urology in India. So let's start with the, first slide. When I was thinking how I should explain about the leader, what a leader should be like, and the only one deity who came in my mind is Lord Ganesha, the ultimate leader. And when I go along to talk about every part of Lord Ganesha depicts the quality of a leader. So first I bow my head to Lord Ganesha, and Ganesh Chaturthi is not very far away. It's coming very soon. And then I will explain to you why I say the ultimate leader. And ultimate leader is the one who is remembered before any good event, anything. Lord Ganesha is remembered, he is, worshipped before you start any activity anywhere. That is in Hindu mythology. Well, number one, I have kept this slide as respect for mentors. I find in the young generation gradually, whether it is my house or the society or wherever it is, the respect of mentors is going down very fast. Leader must have the respect for his mentors, whether it is their parents or their mentors who have brought them to this level. Lord Ganesha, his father, chopped his head off, and still every morning he sort of bows to his father and prays to him, his parents. When he was asked, these two brothers, his elder brother Kartikeya and him, were asked to do the parikrama of the Vish parikrama 3 times. Kartikeya just shot off on his peacock, but Lord Ganesha went round his parents 3 times. He said, "They are my world. Where should I go? And I have done my work." So that is what Lord Ganesha is. Well, Lord Ganesha has a large head. What does that mean? A leader must have the wisdom, understanding, and discriminating intellect. That is very important. There is these eyes of Gajakarna. What do they signify? Half-open eyes symbolize high concentration power and ignoring non-essential sides. During disputes and conflicts, the vision of the leader should understand the problems of their team rather than imposing his own wish blindly. A leader without observation is like Dhritarashtra and his blindfolded wife Draupadi, who could not observe their 100 children growing, which led to jungle law and ultimately Mahabharata. The large ears of Lambakarna. Large ears signify a perfect person who possesses the great capacity to listen to others. He needs to listen everything very carefully and with a calm mind, indicating that detailed attention is paid to what he is told. One tusk of Ekdanta is very significant. You might have been thinking, why Lord Ganesh has got only one dant and where is the other? Why? The two tusks denote the two aspects of human personality, wisdom and emotion. The right tusk represents wisdom and left tusk represents the emotion. The broken left tusk conveys the idea the leader must conquer emotions with wisdom, which are good for the society. And there is a very interesting story also. The leader should be ready to sacrifice whatever he can for the good of the society. It is supposed that Lord Ganesha used to take dictations faster than the computer. And Muni Vedavyas called him one day. He said, look, I want to get this epic of Mahabharata written down, and my thoughts will start coming and you have to write. And he agreed. For the good of the society, epic of Mahabharata had to be written. But suddenly Muni Vyas says, my thoughts have started coming, start writing. Lord Ganesha couldn't find anything to write with, broke his left tooth and started writing. Trunk of Vakratunda. The elephant's trunk is able to sense the size, shape and temperature of their surrounding, and they also wave their trunks up in air and from side to side to perceive, this is like an antenna, to perceive the surrounding atmosphere. In similar manner, leaders should be highly adaptable to their surroundings and should possess contextual intelligence to respond to their surroundings. The trunk symbolizes the radar or the antenna of today. The large belly of Lambodara. Lord Ganesha's big belly indicates that the leader should be able to digest all good and bad phases of his decision. He also needs to digest information shared to him by the management and his peers, as it will show his capacity to maintain trust and confidentiality. The mouse at Ahuratha's feet. That's very interesting. Ahuratha means the Lord who has mouse as his charioteer. This is because the mouse is logic and knowledge of self. And over it sits the symbol of supreme knowledge, the Ganesha. It indicates that Ganesh sitting over mouse has control over the logic, the rules, regulations, policies, etc. drawn by the leader should be applied logically with caution and without limits. And there is an interesting mythological story about this Mushak. Still we find in Argentina on all large rodents, 50 kg and more. They roam around and spoil things. People came to Lord Ganesh and said, sir, he is creating a lot of problems for us. So do something. So he called the Mushak and said, Punar Mushikayo Bhava. The fellow, became small in size, but then he thought this fellow is intelligent, he has the logic and the knowledge. He must keep himself, with him, so that he is employed also. At the same time, his logic and knowledge of self is used by Lord Ganesha. This is what leaders should be. You should not just say, hey, niklo bahar, tum bahut badmaash hai. But us badmaash maybe there is a quality. You must judge that one and use that quality for the good of the society. Small mouth of Gajavaktra. Ganesha's small mouth means talk less. A leader should listen more and talk less while handling people and their problems. They also need to have a clear communication with their peers so as to avoid miscommunication. Well, Lord Ganesha has 4 hands. One has axe, the other lotus, one is blessing, and other has the modak. Let me explain to you all 4. An axe in Ganesha's hand represents discontinuation from bonds and attachments. Ganesha also uses his axe to strike and repel the obstacles. A leader must axe evils inside and outside the society to protect his people. Lotus, the Padma, it is symbol of enlightenment and purity of the heart. It symbolizes divine perfection. As I quote Bhagavad Gita, one who performs his duty without attachment, surrendering the results into the Supreme Lord, is unaffected by sinful action, as the lotus is untouched by water. The blessing hands of Lord Ganesha. The third hand turned towards the devotee is in a pose of blessing which offers protection. A leader should also show the same trust to the society that they are safe and sound and would also succeed in their life by getting opportunity to grow. The modak in his hand. Modak in the hand of Lord Ganesha is the symbol of sweetness in the behavior of the leader. The modak in the hand of the Lord is inexhaustible, which indicates that his love for people is unending. Lord Ganesha is never shown eating the modak. The leader never partakes of the rewards of the deeds. Humne kiya, humne kiya, humne kiya. No. You should be sharing everything. A leader should keep on updating his knowledge. That is very, very important. If you don't update your knowledge, I'm sitting since morning. I'm not saying I'm a leader, but I'm sitting here at the age of 70, since 73 rather, since morning, listening to all young urologists and trying to understand what is new. That is very, very important for a leader. And the leader should be entertaining in nature. If you are not entertaining in nature, by evening, if you are not singing and dancing and entertaining your people, you are not a good leader. Lord Ganesha has all forms. You know, he's playing flute, he's sort of playing drum, he's dancing and everything. So leader should be like that. And any form of the leader should be perceived and enjoyed by the society fearlessly. मैं जैसा चाहूंगा वैसा अपने नेता को देखना चाहता हूं. अब look at this. Musak is reading his own, what you call tablet, and Lord Ganesha his tablet. This is how I like to see him. Somebody is seeing him as police constable. Somebody is seeing him corona time with his Musak, treating people. Somebody is seeing him playing guitar and the dholak and all. So whole mass which he is controlling should, feel free to, depict his leader the way they want. Well, I think this is the last one. In pursuit of dharma, that is stability, order, and righteousness, different approach may be taken by leader at different times. Lord Ram in Treta Yuga sacrificed everything to uphold the law. But Lord Krishna in Dwapar Yuga kept breaking the law for the same purpose. Friends, thank you very much for your patient hearing. I hope I have been able to encapsulate an ideal leader in last 14 minutes of my talk. Thank you very much.
Thank you, Ajay Kumar sir, for a wonderful spiritual leadership talk. We were very much impressed by your talk. Now, may I now request the next speaker, Dr. Kamaljeet Singh, who is a senior urologist from Amritsar, to speak on black pearls, learning from mistakes.
Good afternoon, everybody. This is Dr. Kamaljeet from Amritsar. Thank you, USI, for giving me an opportunity to talk on common financial mistakes young professionals make. Young professionals or the investors have an advantage of starting with less amount of money. They have a time advantage on their side. They are able to take risky moves. They are more tech savvy. They can form healthy financial habits very early in their life, and they have less expenses. A normal fixed deposit, which we make in a bank, gives us a return of around about 5.5%, which is taxed at 30%, and the post-tax nominal return, what we get is 3.85%. Add on to that is the inflation of this country is on an annual basis is around 7%. So the net return is minus 3.15% for all of us. So take this thing, we do not get more money if we put our money in a fixed deposit. The money does not grow in a fixed deposit. The most detrimental mistake most of the young investor makes is not to make asset allocation proper, trying to time the market, having too much money in one investment, holding to an investment too long, and buying overvalued investments. The disclaimer for this presentation is, this is a totally for an educational purpose. I'm not a SEBI registered advisor. Please educate yourself or take help of a financial advisor for your investments. I don't intend to change anyone's investment styles, and I have no conflict of interest. Be careful not to choke on your aspirations, especially the financial. The first mistake we all make is the time to start investment. We will be discussing few. We all have 168 hours. Making this excuse that I don't have time is not appropriate. For a healthy lifestyle, we need 8 hours of sleep, which gives only 112 hours remaining for us. If we deduct nearly 50 working hours a week, we are left with 62 hours. And we take out 7 to 10 hours more. So we are left with approximately 50 hours per week to achieve, to understand, to learn how to make our money grow. The young investor is always disturbed by few thoughts. I don't earn a lot. I don't understand the markets. I'm too young to invest. Market keeps going up and down, and I may risk my hard-earned money. This diagram clearly depicts that if a SIP is made of 5,000 rupees and it gives an annual compounded interest of 12%, after 30 years, it will be 1.77 CR. If you start 3 years late, you will get 56 lakhs less. If it is 5 years, then 82.1 lakhs is less. And at 10 years, you will only get 49.9 lakhs, which is less by 1.27 crores. So it's up to you when to start. The earlier you start, the better is the return. You can be late. There is nothing known as early age of investment. There is no correct parameter to start investment. Start gradually. Do not put all your money in one go. The asset allocation to start with is always wanting, and I may call it a poor asset allocation. Actually, there are 4 types of asset allocation: stocks, bonds or mutual funds, real estate, and cash. None of us know how much money is to be put in each of these assets. The next slide, I would like you all to take a screenshot, which tells that at specific age, how much money should be in a very low risk group, medium, and the high risk group. Please, this is almost a standardized form of investing. If I say at age of 45, it should be 10% cash, 10% in bonds and mutual funds. Real estate should constitute around 25%, alternative 15%, and stocks 40%. We all are taken back by uncontrolled expenses early in the part of our professional career. Never spend your money before you have earned it. Moment we come into the practice or we start a job post MCH, we have a lot of money, so we end up spending too much. And most of them are little unwanted expenditures. Most of these money go in buying unwanted stuff or in shopping, in a supermarket or in a mall. At the end of the month, we get a beautiful credit card bill statement, which is long like a tail. And we practically realize at that time that we have already spent the next month earning in paying the credit card bill. This is where the difference between the rich and the poor professional comes. A poor personal who is not rich at end of a specific time he will earn the same amount of money. He will end up spending more than what he has earned in forms of, he may add some credit spending over his monthly earnings. While a person who is little rich or have more money has the same amount of money, saves 1/3, invests 1/3, and spends 1/3. So he has controlled his wasteful expenses and put that in saving his money and in investments. Show respect for your money, then your money will think and care about you in return. Over-reliance of loans is a very common problem in the early part of our professional careers. This is basically for buying the instruments, buying house, buying cars, and overspending on credit card is considered as a loan. If your monthly EMI crosses beyond 25%, you are going out of the comfort zone. Caution is when it's between 25 to 40%, and it is stressful when it crosses 40%. So whatever loan you are taking, try to keep your EMI between 25 to 35%. Don't let it cross 40%. So this is the most important thing which all young professionals must understand while taking loans. We all love to buy fancy cars, all in the premium segment. We take big loans to buy these cars. And what happens when after 5 years, we see the outstanding amount? Our car is worth like a pug in size form, while what we owe to the bank is as big as a Dalmatian. We get this feeling that practically we are selling our car free of cost. Car is a depreciating asset, and to take a loan, big loan on it, is not an advisable thing. Next is rumor and emotional basis for investment. Lack of knowledge, because we are never taught, we have never learned, so we don't know how to invest, how to make a good asset allocation. We also fail to acquire the knowledge before we are making it. We have an emotional attachment, buying gold, buying land, stocks, some specific stocks we like to buy, mutual funds, a lot of SIPs, PPF, NPS. We have all these old habits which have come from our ancestors to us. Investing on basis of what is shown in the TV and the print media, please don't do it. It is a totally discounted news. Investing into the penny stocks. If something is very cheap, there is a reason why it is so cheap. If it's expensive, then there is a reason why it's expensive. You don't get a BMW 3 Series for 5 lakhs. You will get it for 40 lakhs at least. So same way, a blue chip stocks and a penny stocks is differentiated. Too much investment into a single sector, like it is just like putting all your eggs in single basket. Taking credits to make assets, which crosses your comfort zone in paying the EMIs, as shown in the previous slides. Now, how to proceed and correct our mistakes is the most important thing. You cannot achieve a financial independence or freedom if you don't follow the stepwise pattern. Determine your current financial situation. Determine your financial goals, what you want. Convert your financial goals into a plan, how you're going to execute it. Evaluate other alternatives which can be there to make your money grow. Create and implement it. And the most important step is go back and revisit. How could you have made these plans better? Is the most important step. That is where the real growth comes from. Study the logic and the maths behind the investment and how the money grows. Once you have mastered them, then you don't need any book for it, or you don't need to fear any book. Let's be honest, I have made mistakes. Everybody makes mistakes. Don't take mistakes as a reason for failure. Don't accept failure. Mistakes are stepping stones to learning. Anybody with a positive attitude will rephrase fail as the first attempt in learning. Attempt to improve from your mistakes. That is the most important thing. Value the time. Understand it. Starting early is very good. So start early. The money you earn is taxed very heavily. The money your money earns is taxed slightly. Find the ways to have your money work for you instead of you working for your money. Time is your greatest asset. That is why it is so important to get your money to make money for you, so you can eventually stop selling your time to make money. Money is infinite. Your time is limited. This is the basic thing we must all understand. Get money, buy assets, and own your time. I all want you all to be financially freedom. Financially freedom is the most important thing which we all need. Under leadership of Professor Subnis, we have been able to form 4 groups in which the financial knowledge is being shared by experts. I would like you all to be part of it. Understanding assets and liabilities is the first step. Converting liabilities to assets is the second step. Time and the skill management is the real source of income. Increase your income, not your expenses. Get out of your comfort zone, learn everything, and make yourself financially independent. Thank you, everybody.
Thank you, Dr. Kamaljit Singh, sir, for enlightening us on financial management. Lunch is being served at Hyder Mahal Hall, so I request all the delegates to quickly have your lunch. Meanwhile, we move on to our next session, which is an interesting session on reconstructive urology. The theme is on ureter and urethra. May I now request my friends, Dr. Abhishek Singh from Nadiad and Dr. Syed Zaid Raza to begin the proceedings.
Good afternoon, everyone. Without any further delay, let's start with session 3, which is reconstructive urology. I welcome my co-moderator, Dr. Abhishek Singh. I also would like to welcome our experts, Dr. Anurag Yadav sir from Agra and Dr. D. Ramesh sir from Bangalore. The first talk is pan-urethral strictures, options and hand, and how to decide by Dr. Kalpesh from Chandigarh.
Good afternoon to one and all. I'm Dr. Kalpesh Parmar from PJMER, Chandigarh. At the outset, I thank the organizers of Youth for giving me this opportunity. I'll be speaking about the pan-urethral strictures, option at hand, and how to decide. I disclose no conflict of interest. Urethral stricture is a surgical disease. The management depends upon the length, the etiology, and location of the stricture. Pan-urethral stricture is defined as a stricture which extends from meatus to proximal bulbar urethra. The incidence is increasing. It's a complex and a challenging issue. Not only it is important to restore the voiding function, but also the sexual function. For long segment strictures, urethroplasty is a treatment of choice. Amongst the etiology, lichen sclerosis is the most common cause of pan-urethral strictures in developing countries. The other common cause is the iatrogenic injury, commonly due to instrumentation and catheterization. Amongst the investigation, retrograde and micturating cystourethrogram is commonly performed to assess the location and the length of the stricture. In management, single-stage urethroplasty using graft or flaps is most commonly preferred. Stage urethroplasty may be performed in completely obliterated strictures. The other options are Monsieur's urethroplasty and perineal urethrostomy. To begin with, stage urethroplasty is commonly performed in patients with strictures associated with chronic inflammation, radiation, urethral strictures, abscess, and stone formation. As we can appreciate from the retrograde urethrogram, there is significant periurethral extravasation as well as abscess formation, which warrants reconstruction in a staged manner. The further images show the pan-urethral stricture, which was a redo case, and there is a multiple urethrokinous fistula formation as well, which warrants the reconstruction in a staged manner. The other indications are patients having failed previous repair, patients with complicated hypospadias repair, the surgeon is inexperienced, and there is a lack of local skin or grafts. Johansson's technique is the most commonly performed procedure in a staged manner, wherein you lay open the urethra and the skin margins are sutured to the urethral plate. The proximal urethral meatus is cannulated with 16-pinch Foley's catheter, and the plate is allowed to heal for about 3 months' time. The tubularization is performed in 3-layered manner over a 16-pinch Foley's catheter. The results are good and shows a success of about 70 to 85%. Schreiter reported mesh graft urethroplasty in 1989 for complicated strictures and for failures due to the hair growth leading to infection and stone formation in Johansson's technique. In this, a mesh tissue is used which increases the wound drainage and donor tissue area. Herein, the urethra is laid open and proximal urethrostomy is performed. The meshed graft tissue is placed on the either side of the urethral plate, which is allowed to heal over a due course of time. At about 3 months, again, retubulization is performed in a 3-layered manner over a Foley's catheter. Single-stage urethroplasty, as we all know, can be done with the help of graft or flaps. Amongst the graft, buccal mucosa is the most favored. Single-stage urethroplasty is performed in cases where the urethral lumen is more than 6 French. The plate is healthy. There is no evidence of infection or any other complicating factors. Amongst which buccal mucosa, as we all know, has a rich submucosal plexus. It is hairless, has a wet epithelium, resilient to infection. It is easy to harvest, is relatively thick, stiff, and elastic. We commonly perform the penile invagination technique for panurethral strictures using buccal mucosa graft, where the urethra is exposed on the dorsolateral aspect and laid open. The graft is placed on the side of the urethral plate and sutured over a 16 French Foley's catheter. Excellent results have been reported by Kulkarni et al. With a success of about 80 to 85%, and multiple authors have reported using the technique with a good success. The advantages of dorsolateral placement of the graft are that the unilateral vascular supply to the urethra is maintained, the corporal bodies provide good vascular bed, and there is a less risk of pseudodiverticular formation. Coming on to the flaps, it is very important for a reconstructive urologist to know the penile vascular anatomy when raising the flaps for urethral reconstruction. What are the advantages of the flaps? They are the mobile, well-vascularized pedicle units, which has an elastic skin island, and it is versatile, mainly used in patients who have unavailable donor site area, or in one we want to prevent the complications of the graft. However, the limitations of the flaps are that it is technically demanding, there is a risk of penile skin loss, possibly risk of disturbed penile sensation, and it is not useful in patients with lichen sclerosis. Amongst the flaps, mechanical urethroplasty is a commonly performed procedure where the flap is raised between the skin and the buccal fascia over a dartos-based pedicle. It is a well-vascularized pedicle which is hairless, flexible, cosmetic. The sexual functions are preserved and also feasible in patients who are circumcised. Mechanics first reported single-stage reconstruction of complex anteurethral stricture disease back in 1998, which was further revalidated by authors over the time. The quadriflap urethroplasty is a modification of the mechanical urethroplasty where there is an additional midline vertical extension of the flap. It is performed in a single-stage manner in a long segment strictures with a good success. It was first reported by Quarty et al. Back in 1985 and subsequently revalidated by More et al. In 2001. Another option is a Gill-Werner urethroplasty, which is nothing but a biaxial epilated scrotal flap urethroplasty for long segment strictures. A scrotal-based flap is raised and the two ends of the urethra are bridged over 16 French Foley's catheter. Monzier urethroplasty is a new procedure which was reported by Monzier et al. In 1969 for long segment urethral strictures, which was revalidated by Sharma et al. In 2013. It's an easy procedure with a short learning curve. There is no graft morbidity. It takes less time and less resources. The procedure is nothing but the mobilization of the urethra and laying open the urethra on its dorsal aspect. The two ends of the urethra are further sutured over the corpora cavernosa bed over a 16 French Foley's catheter with the presumption that the epithelialization will occur in due course of time. The success is about 70 to 75%. Perineal ureterostomy is a last resort for complex and recurrent urethral strictures with multiple failed urethroplasties. Patients old age who don't have voiding problem in a sitting position and the one who desires and wants to prevent the complications of urethral reconstruction. One should be aware of the complications of various techniques, amongst which the faciocutaneous flap has the highest complication rate with a tune of 30 to 40% in the form of fistula formation or penile skin necrosis. Buccal mucosa graft are known to show complications in the form of bleeding, submucosal fibrosis, and numbness. The two-stage urethroplasties are also known to cause fistula formation in the tune of about 30 to 35%. A multi-institutional evaluation of the management and the outcomes of long segment urethral strictures was reported by Warner et al. Using various procedures, and it showed the buccal mucosa graft in a single-stage manner showed the highest success of about 80 to 85% as compared to two-stage urethroplasties or a flap urethroplasty. Even a combination of the graft and flap can be used in such cases. In conclusion, panurethral strictures are difficult to treat. There is no one technique which is superior over the other. One-stage reconstruction using buccal mucosa offers excellent results. However, two-stage urethroplasties may have to be performed in near obliterated strictures. Flaps has also shown good success, but it is associated with high risk of complications. I thank you all for patient hearing.
Thank you, Dr. Kalpesh, for a very comprehensive talk about management of panurethral strictures. Next, I would like to invite Dr. Santosh from Bangalore, who's going to be speaking about management of post-DORP strictures bar incontinence.
Good afternoon, everybody. I thank the organizers and Urological Society of India for providing me this opportunity. Today, I am going to talk briefly about management of post-DORP strictures and incontinence. With the introduction of lasers in urology, there has been tremendous advancement in management of benign prostatic hypertrophy, but still the TURP remains the gold standard. Irrespective of the techniques and irrespective of the energy sources, urethral stricture and incontinence of urine still remains well-known complications after these endoscopic procedures. The incidence of urethral stricture after transurethral resection of prostate, it varies between 2.2% to 9.8%. It remains same after the laser procedures also. The incidence of urge incontinence occurs in up to 30 to 40% of patients. However, the iatrogenic stress incontinence after TURP is still rare. The incidence of stress incontinence after the laser enucleation like OLAP or TOLAP, the incidence is higher compared to the transurethral resection of prostate. The review of literature for risk factors for post-TURP urethral stricture, we found a few of the common things. The most important being mechanical injury to urethral mucosa. Use of larger resectoscopes are one of the risk factors. The resection time, catheter type, duration of catheterization after the surgery, the size of the catheter we use, the final histopathology report, and urinary tract infection after the procedure. So most of the strictures, they present within first 6 months after the TURP. So how do they present? The most common the way they present is decreased flow of urine. Some of these patients, they present as urinary tract infection and very rarely acute retention of urine. Kulkarni et al., they found the meatus to be the most common site of stricture, followed by penobulbar junction, which is the main because of the angling of the urethra due to the instrumentation through the anatomical bend in the urinary passage. Other sites being fossa navicularis, pendulous urethral strictures, and bulbar strictures. Many of the historically the membranous urethral strictures are later found to be the proximal bulbar urethral strictures. These strictures are diagnosed on uroflowmetry. The Qmax value of less than 10 ml per second is considered as diagnostic according to many studies. We use retrograde ureterogram and micturating cystourethrogram to define the site and length of strictures. Office cystourothroscopy is sometimes used for diagnosis, but most often we use it as a part of the procedure. Visual internal erythrotomy and urethral dilatation are the most common procedures performed for stricture urethra in a clinical practice. Meatotomy and meatoplasty are used for meatal stenosis as well as submeatal strictures. For long segment strictures, the conventional buccal mucosal graft augmented urethroplasty is used. Few technical points. Avoid anastomotic urethroplasties as these strictures are theoretically ischemic injuries. Both dorsal onlay and ventral onlay has similar success rate of 81% and 84% respectively. The strictures of membranous urethra, which now classified as proximal bulbar urethral strictures, prefer onlay in these strictures to avoid incontinence of urine. Can anything be done to prevent these strictures? Jong et al., they are shown using smaller resectoscopes prevents formation of these strictures. Regular preoperative urethral dilatation up to a 28 French, otis urethrotomy up to 28 French are regularly done to prevent these strictures. At our center, we use regular preoperative urethral dilatation. Next, I'll briefly talk about post-TURP incontinence. It's mostly urge incontinence, which is in the range of 30 to 40%. Irrespective of energy source or monopolar or bipolar technique, the stress incontinence incidence remains low at 0.5%. We treat these urge incontinence by an escalating dose of anticholinergic drugs initially. Very rarely, we may have to use intravesical Botox injections for refractory urge incontinence, especially those incontinence which are with a coexistent neurogenic bladder. The incidence of stress incontinence after TURP is rare. However, with volume laser enucleation of prostate, it has significantly higher incidence of stress incontinence. The pelvic floor exercise is the initial mode of management of these stress incontinence. We advocate both pre and post operative Kegels exercises. There is statistically significant difference in the continence rate at 3 months following surgery in men who have performed Kegels exercises against men who did not, though the continence rates at 12 months were not significantly different between the two groups. There is a lack of literature on surgical management for stress incontinence after TURP. Most of these management I have extrapolated from the data from management of incontinence after radical prostatectomy. The adjustable and non-adjustable male slings, they are good for mild to moderate stress incontinence. Usually the male slings, they provide compression only on the ventral side, which reduces erosion, retention rates and urethral atrophy. However, the artificial urinary sphincter is reserved for total incontinence. Adjustable transobturator male system or ATOMS is safe and effective in short term, even in patients with severe stress urinary incontinence. The rate of dry patients is in excess of 80%. Artificial urinary sphincter implants are recommended as the gold standard treatment for severe persistent urinary incontinence after prostatectomy. The observed high rates of device malfunction and grade 3 surgical complications are a matter of concern, warranting further assessment on the safety and efficacy of these devices. To conclude, management of post-TURP strictures and incontinence is stressful for both patient and the surgeon. Most of these complications are attributed to iatrogenic injury. Patience and stepwise treatment are the keys in managing these complications.
Thank you, Dr. Santosh, for a wonderful lecture. I have a question for you. While doing the endoscopic management of post-TUR, posterior urethral strictures, something like a bladder neck contracture or posterior urethral stenosis, what energy do you prefer and where do you cut in your practice? And do you have any tips on that?
Okay, so conventionally we are using volume laser for BNI or what we call as posterior urethral strictures. See, if it is only a short segment, then we do laser cut at the 5 o'clock and 7 o'clock position. But if it is entire post-urethra is involved, I don't think we can use any of these energy sources to cut these things. It has to be a one-point stricture, preferably a bladder neck stenosis. Again, if it is very closer to the sphincter or membranous urethra, we prefer not to cut. We try to dilate, serially dilate as minimally as possible, probably up to 20 French. But in case of a bladder neck, we use both bipolar resectoscope to do a cut at 5 o'clock and 7 o'clock position, or volume is equally good.
Thank you very much.
Thank you, Dr. Santosh. Next, we have ureteric avulsion, counseling and management by Dr. Bhushan Patil from Mumbai.
Good afternoon all. I would like to thank organizer for giving me the opportunity. My topic is ureteric avulsion, counseling and management. Ureteroscopy is one of the commonest procedures performed by the urologist, and fortunately the incidence of the ureteric avulsion is only 0.1 to 0.5%. The most important and probably the most difficult part in management of these types of injuries is the counseling. Because most of the time the patient and the relatives are under impression that ureteroscopy is a minor surgery. There won't be any cut, scar. Patient will get discharged in a day or two, and patient can resume the duties in 2 to 3 days. So it becomes really difficult for them to accept the complication. All ureteroscopy consent must include ureteric avulsion as a possible complication. Once we diagnose the ureteric avulsion, we need to explain it to the patient if he is under spinal anesthesia or to his relative. We need to explain in detail about the incidence of the complication, the different modalities available, and we should give them sufficient time to decide. If they opted for the immediate repair and if the expertise is available, we should take a proper consent and proceed for the repair. If expertise is not available or the patient and the relatives are not ready for the immediate repair, then put a nephrostomy tube and send patient to the tertiary care hospital. This is a part of the consent for the ureteroscopy at our institute, which clearly mention ureteric avulsion as a complication. Distal ureteric avulsion can be managed with simple ureteroneocystostomy. If the defect is significant, then it can be managed with sausage and the body flap. The proximal ureteric avulsion require the major surgery. We can manage proximal ureteric avulsion in immediate fashion or the delayed fashion. There are many factors that decide whether we should proceed for the immediate repair or a delayed repair. But the most important factor is availability of the expertise. In delayed reconstruction, we put a nephrostomy tube at the time of ureteric avulsion injury, and we plan the definitive reconstructive surgery after 4 to 6 weeks. The advantage of these types of repair is patient and the relative, they are in a better position to understand the procedure and its consequences. At the same time, they are out of their denial and now they accepted the complication. Again, you have a good radiological imaging, so you can plan your management. It is mandatory to have a renal scan in these types of injury. And if the differential function is less than 20%, then definitely the option of nephrectomy should be considered. The advantage of the immediate reconstruction is that the patient will not require the second surgery. Ileal substitution and the auto transplantation, these are the two common surgeries performed in a patient with proximal ileal ureteric avulsion. These are the standard steps for the ileal ureter substitution. I don't think there is any need to discuss whether one should go for the void preparation or not. It is now well established fact that there is no added advantage with the void preparation. Most of the textbook describe the midline incision as a standard practice, but we find this modified Gibson incision extended cranially in a paramedian fashion very helpful. It gives optimum exposure of the kidney and entire length of the ureter and the bladder. It also gives exposure to the peritoneum in a controlled fashion. We can open the peritoneum, isolate the segment of the ileum, and bring the segment in the retroperitoneum through the window created in the colonic mesentery and close the peritoneum so that there won't be any bowel during the surgery in the surgical field. It is very important to have good imaging before the delayed reconstruction, so you can decide whether to anastomose the ileal segment to the renal pelvis or to the inferior calyx. As a standard practice, the desired length of the ileal segment should be isolated from 15 cm proximal to the IC junction. Tapering is not mandatory. Nephrostomy should always be kept in all patients with these types of complex reconstruction, and DJ stent should always be put in these types of reconstruction. No sufficient clinical data exists to establish the superiority of the tapered segment, a non-refluxing anastomosis, or a shorter or segmental replacement or a standard ileal substitution. It is good practice to start sodium bicarbonate washes from the postoperative 1 or 2. It prevents the mucus plug formation. You can remove the DJ stent at end of 4 weeks after doing a nephrostogram. If there is no leakage, you can remove the stent. After a week, you can remove the nephrostomy if there is no obstruction on the nephrostogram and there is complete drainage of the contrast. Urinary leak is the commonest complication in these types of surgery secondary to mucus plug formation. Ischemic necrosis of the ileum is a serious complication and it requires re-exploration. Metabolic abnormalities are not seen in a patient or rarely seen in a patient with normal serum creatinine level. The incidence of malignancy is extremely rare and only 4 cases reported in the literature. We normally ask patients to follow up every 3 monthly with the sonography for the first year and the renal scan at the end of the 1 year. Autotransplantation is the second modality and is commonly indicated when the bowel is not available, like in a Crohn's disease and radiation enteritis, if the serum creatinine is more than 2 and if there is a bladder dysfunction or bladder outlet obstruction. These are standard steps for the autotransplantation, that is laparoscopic nephrectomy, bench dissection and perfusion, and then transplantation. The take-home message is do not be panicked. Always discuss in detail about the condition, its management and complication with the patient and relatives. Include ureteral avulsion as a complication in a consent for ureteroscopy. Delayed ileal substitution is a good option. Good counseling, proper documentation, and the expertise are keys to handle these complications. Thank you.
Thank you, Dr. Bhushan. Before we invite Dr. Anurag Yadav sir for his expert comments, there are 2 questions. One to Dr. Kalpesh. Dr. Kalpesh, the pathophysiology of panurethral strictures is mostly because of spongiofibrosis. Is there any role of an sonourethrogram or a sonoelastogram?
Thank you for the question. I don't think so. There is a role of this sonourethropy for panurethral strictures. I mean, it's a long segment stricture. We all know it's basically because of that inflammatory changes which occur, and there is an obstruction at one level, and that subsequently leads to the inflammatory changes in the proximal segment of the urethra. I mean, you can do an ultrasound and just find out maybe for short segment strictures. If it's a very dense stricture and a very small segment, you can go for an end-to-end. But long segment strictures, I don't think so there's any role.
Thank you, Dr. Kalpesh. And Dr. Bhushan, ureteric avulsions on table, when you want to put a nephrostomy, sometimes the system might not be very well dilated and it is a difficult situation. Can you throw some light on the situation?
Yes, definitely. You ask a very right question. Actually, we have one patient was referred immediately. We take a patient. It is really difficult to take a puncture in this patient because the avulsion is at a proximal site. And the kidney, most of the time, these are the patients with upper ureteric calculus with minimal dilatation. So hydronephrosis is most of the time is not there. So we tried sonography, we failed. Then we injected an intravenous contrast. And then we take a puncture through the C-arm and we put a scope. If it is failed, then it is advisable to open the patient and put an open nephrostomy.
Thank you, Dr. Bhushan. And now I'd like to invite Dr. Anurag Yadav sir for his expert comments.
Thank you very much. At the outset, let me thank the organizers, especially Dr. Dilip Mishra, for inviting me here. And I'm so delighted to see all the young faces here. Without wasting any time, I will start my comments. First of all, I would like to say something about that sonourethropy that you mentioned. And sonourethropy is, I think, important if one is considering urethroplasty against optical. And if the patient is wishing for optical, and you want to convince him that this is not a good option. At that time, you must show sonourethropy that a lot of spongiosum is involved, and it's not only the urethra, but the whole of the spongiosum is involved. So you must go for some kind of substitution. Now, I would like to reiterate the definition of pan-urethral stricture. It must include the bulbar, the meatus. If the meatus is spared, I would not personally like to call it pan-urethral. And I understand there are literature reports which say any long penile and bulbar stricture as a pan-urethral stricture. But always we must consider that meatus is involved, then it is pan-urethral. And by the same go, a meatus is involved, then any optical technique is not, it's out of question. It has to be a urethroplasty. And I think everybody knows that for BXO is common in India. And for BXO, no kind of skin should be used, not only genital skin, but other skins also should not be used. Another thing that I would like to say about strictures is the follow-up and results. Most of the patients and the doctors, the surgeons are happy if the patient is voiding in good stream. But if you really ask the patient, his expectations are more than a good stream. We objectively follow the patient with maybe RGU or uroflowmetry or cystoscopy or calibration and say that the lumen is okay. The lumen okay is not the end of it. The patient is also interested about his sexual function, especially ejaculatory function and cosmesis. So that also should be discussed with the patient. And buccal mucosa is very good. People are using buccal mucosa left and right. But I personally use labial mucosa also of the inferior, the lower lip. And if you take it correctly, there's no post-operative deformity. Then posterior auricular skin is also one of my favorites in our patients who are tobacco chewers, especially North Indian patients. And the buccal mucosa is very bad. You must refrain from using buccal mucosa in these patients. And post-auricular skin is good. Coming to TURP problems, strictures, I think it's not very common, but strictures do happen. And it's not common, why I say, because the symptomatic strictures are not common. If you go in for something later on, do cystoscopy or the patient needs catheterization when he's sick with something, he has CVA or something is being catheterized, we find a lot of patients have strictures in the bulb. So that is common that way, but not symptomatic. And I think submetal is more common than metal. And even pan-urethral strictures happen after TUR. And this is because of the large sheath for long duration and in a native small urethra. Many patients in Indians are having small urethra, especially the proximal penile and penobulbar area. You introduce your instrument and you know that it is tight. So go for Otis always. And about the incontinence part, the speaker said it is rare. I don't think it is rare. Yeah, it is rare after a week or so, but in the beginning, many patients do complain of incontinence, and you have to tell them about Kigeling. But if you expect a patient to suffer from incontinence in future, and you can, think patients with large glands, with obesity, with problems, or before TUR, they have some kind of incontinence, maybe overflow even, or urge incontinence. They should be taught pelvic floor exercises before operation. Because after operation, the patient is not in a position to understand. He has some pain locally, he has some sensory issues, and his muscles are not working. So please, if the patient is a suspect for a post-operative incontinence, you must teach him Kegels exercises beforehand. And about HOLEP, I know Dr. Anil Vashne, a good friend of mine in Delhi, who said once, 100% of patients do develop incontinence after HOLEP. It is just a matter of time when they recover, and most of them recover in few weeks. But he says, I explain to patients, 100% of them, that you will have incontinence after HOLEP. So treatment of this incontinence should not be, no big thing should be done before 1 year. They do improve in 1 year. In a few weeks, most of them improve, but you must give them at least 1 year before going for a sphincter or something. For strictures post-TUR, first thing that you have to ask the patient whether he was continent also after operation or not. There are some patients who became incontinent. There was sphincter injury and they became incontinent and they remained incontinent for a month or so. After that, they gradually gained continence and they became happy. And they come to you after 1 year or a few months with retention. So these are the patients whose membranous urethra and the sphincter region is damaged. They are incontinent and they become gradually continent because they develop stricture. So in these patients, if you do any heroic dilatation or internal hysterotomy, they'll become incontinent again. So you have to find out these patients who were totally incontinent post-TUR. About urethral avulsion, the speaker said and showed the consent form in which they have written urethral avulsion. I am not very sure, and I at least do not write in my consent. And there are so many complications of so many operations which are less than 1%. And I do not know whether we should write about that in the consent form. Explaining to the patient on table after the complication is really very difficult. If the patient is awake, even then, if you explain to him that this has happened, I don't know what will happen to his heart rate. But of course, you have to explain to the attendants who are sitting outside, and you have to explain to them very honestly. Do not hush up things. Do not close the case and refer. You have to deal with the patient, and at least you have the, if you are doing ureteroscopy, at least you have the expertise to do PCN that you can do. But if you can do a definitive surgery on table, that will be the best. And I remember in one of my patients, it was only the lower end avulsion in a lower ureteric stone. And I just told the patient and attendants that the stone is not coming out. I have to do an open surgery. And they said, okay, go ahead. Somehow in our part of the world, people are more in favor of open surgery. They think if you do endoscopy, the things recur more. So they said, okay, go ahead with open surgery. So I just did a standard reimplant. Nothing big was required. But of course, this is a very, very serious complication, and you have to be honest with the patient. Counseling is very important. About the ileal conduit, I think ileal replacement, it is a very big surgery, but the classical technique should be a little bit changed. Like Young Bonte's, I think every newcomer should learn Young Bonte's technique, in which a smaller bowel segment is needed and the antiperistalsis is done well. So I think all topics have been covered well, and my good wishes to all the speakers and for the next few sessions or tomorrow's speakers. And thank you very much for calling me here. Thank you.
Thank you very much, Anurag sir. Going ahead, now we have two videos. So I call upon Dr. Vijay Radhakrishnan from Kottayam. He is a young urologist who's extremely interested in advanced laparoscopical surgical procedures, and he will be demonstrating Bovari's flap laparoscopically.
Everyone. At the outset, I would like to thank USI and the U Council for giving me this opportunity to talk on Bovary flap ureteric reimplantation. Also, I would like to thank Dr. George P. Abraham and Dr. Mallikarjun sir, whose videos I'm showing today. The incidence of ureteric stricture has been rising continuously due to multiple factors, and sometimes a straightforward ureteric reimplantation or a swasage may not suffice, and there is a need to take a Bovary flap to do a ureteric reimplantation. It has gone constant improvement from the initial procedure described by Bovary, and then laparoscopic procedure as was described, and then of late there has been reports of robotic Bovary flap procedure. The anatomy is basically bladder is well vascularized, but the main vascular pedicles are posterior lateral. So a flap taken from the anterior wall with adequate blood supply maintained from the base can be safely taken. For long segment strictures, sometimes we may need Bovary flap. Preoperatively, we keep the patient overnight fasting with a peg-leg bowel preparation and a single-dose antibiotic prophylaxis. We need to discuss with the patient the various surgical options because not always we go ahead with the plan of Bovary flap. We may start with a straightforward ureteric reimplantation. Intraoperatively, we may find the length is inadequate, and then we may have to take a Bovary flap. In the theater, general anesthesia, 3 or 4 ports, and a deep Trendelenburg position so that the bowel goes away from the working field. Port placement, 10 mm camera port, 2 5 mm ports for the surgeon to work on, and additional 5 mm for the assistant closer to the anterior superior iliac spine. So this is a young lady with the endometriotic ureteric stricture, long segment. She was stented elsewhere. Laparoscopic approach, bowel is mobilized. The left-sided colon, here you can see grossly dilated ureter, which is dissected all around. The stent is there in place, and then as we go down, there is encasement of the ureter in tight fibrosis, and then the ureter is opened up, and the stent is removed, and the ureter is divided. Then the unhealthy segment is excised so that we get a healthy ureter, but then the length is insufficient. So we need to mobilize the bladder and adequately. Now, even with that, the ureteric reimplantation is not possible, so we have to raise a flap. The broad base and a narrower apex is the secret for having a good Bovary flap, because the pedicle has to be well vascularized. As I said, it's posterior lateral. So the base has to be broad enough, at least 4 centimeter. The apex can go up to about 3 centimeter. Then you can adjust the length as much as you want. Now you can see the flap is raised, and now the anastomosis is possible without much tension. The spatulation is done at 12 o'clock position so that there is a healthy wide ureter. Now the anastomosis of the posterior layer is done first with 3 vicryls interrupted sutures. Once that sutures are taken, then now that posterior layer is almost complete. Then a DJ stent is placed over a PCNL needle, and then the anterior wall is sutured again with 30 vicryl sutures. Once the anastomotic area is over, then barbed sutures like B-lock is taken 30, and the tubularization of the flap and the bladder closure can be done with these barbed sutures. It makes it much quicker and faster. This is the bladder closure using from the opposite end, and it taken towards the tubularized flap. The V-lock sutures is it makes life much easier, and the anastomosis is complete, and the second layer coverage with perivesical tissue can be given. This is the second layer coverage. Now this is the completed anastomosis, healthy tension-free anastomosis, watertight, drain is placed, and the port closure is done. This is from the INU team, Dr. Mallikarjun sir. A couple of points which really makes it little different. Now the length is assessed. This is the apex which is being assessed for the width. As I said, at least 3 centimeter. The length of the segment which is required. The base has to be broad enough so that the vascularity to the pedicle is maintained. Otherwise, there is a chance that it will undergo ischemic necrosis. The suturing technique is a little different. The tubularization is started from the bladder end, and it's taken towards the ureteric anastomosis. Now the tubularization is done with V-lock sutures, and the bladder closure also with V-lock sutures. Once the tubularization is done, the anastomosis, the suturing is taken towards the ureter, where the suturing is done with V-lock sutures. Here now V-lock sutures is taken as it's closer to the ureter. This is the tubularization being completed. Now the suturing is done to the ureter. The spatulation is done at 6 o'clock position, and then the posterior layer is anastomosed first using V-lock using vicryl stitches, and then a stent is placed, followed by the anterior wall suturing. Now this is the completion of the posterior wall sutures. The assistant is constantly helping by irrigation suction so that the field is kept clear. Now the stent is placed into the ureter through the tubularized flap into the bladder, and now the completion of the anterior wall, the flap, and then the bladder is done using V-lock sutures. Now this is the completed anastomosis. The flap is completed. Now the bladder is closed again with V-lock sutures, the barbed sutures, which makes it quite, it can be done very quickly. And then the second layer coverage with perivesical tissue is done. This is the completed anastomosis, tension-free and suturing. And a drain is placed and port closure is done. This is the completed anastomosis. So drain is usually in 24 to 48 hours. Orals are allowed the next day. Antibiotics for about 48 hours. Discharge usually third or fourth day. Catheter is retained for about 3 weeks. Stent removal at 6 weeks and follow up at 3 monthly and then annually to look out for any anastomotic strictures or recurrence of disease. So the concerns usually recurrence if it's any non-traumatic, infective or endometriotic cause. There is a high chance it can recur. Also, the anastomotic stricture, because such a long flap, and therefore can lead to loss of renal unit. Decrease in the bladder capacity is can be seen, although may not be that clinically significant. Same as with infection and VUR. These are theoretically described, but then clinically they may not be quite significant. Literature supports the procedure. Kamalingam sir has reported 3 cases with an operative time of 320 minutes. Castillo reported 9 cases with a good follow-up without much complications. Abraham et al. Reported delayed versus early repair, where early repair has definitely got more challenges. So laparoscopic body flap repair is definitely a procedure which can be completed with minimally invasive procedure. Long-term follow-up is essential. It is technically challenging, but definitely feasible. Thank you.
Thank you, Dr. Vijay, for a wonderful presentation. I have a question for you. When you are marking the Boari flap in the minimal access milieu, the bladder is actually distended. So has it happened to you that after the bladder gets deflated, the flap that you have marked appears thinner than or appears narrower than the one you had planned? And what would you do to overcome this situation?
Yeah, what we usually do is we take a little more extra margin. Whatever is required, we take a little extra so that it doesn't happen like that. If suppose it happens, we can just extend it a little more posteriorly, making sure that the base is still broad. We can just lengthen it a little more, but that safety margin which we keep more than what we actually require helps us to avoid that.
Thank you very much. Going ahead, now we have a talk by Dr. Ankit Fusukle. He would be demonstrating a video on laparoscopic ureterocalycostomy.
We are presenting a case of laparoscopic ureterocalycostomy in a salutary functioning kidney. This is a 60-year male presented with right flank pain with creatinine of 15 mg per dl. And we put a PCN. After 6 weeks of PCN, creatinine came down to 2.2. Standard port position with a fourth port of further liver retraction. First, the colon is being retracted. Mobilization of the colon was done. And the identification of the ureter and the gonadal complex is done. This is gonadal vein lifted and a window is created. Once this source window is created, we further proceeded for the proximal dissection. You can see the gonadal vein and further proximal dissection, lot of adhesions and inflammation. And this is the dissection at the level of PUJ. Because of inflammation, there is bleeding, and this is ureter, and this is duodenum is being mobilized, which is overlying the pelvic ureteric junction. And this is cicatrized and inflamed pelvis area. Further dissection of the ureter is done, and the lower pole perinephric fat is removed, which is overlying the ureter. Now the ureter and pelvis is free. And this is the area of huge obstruction. Now the lower pole of the kidney is being cleared. This is the perinephric fat which is cleared. And this is marking of the chalicostomy with the help of cautery. And the excision of the parenchyma is done. Calyx is open, small bleeder with the help of bipolar, taken under control. Parenchyma is excised, and this is a good opening of the chalicostomy. Now the ureter is lifted and dismemberment from the pelvis is done. Ureter is spatulated. And now the tension-free anastomosis is started. The first stitch is taken outside in, so the knot will lie outside the lumen. A good chunk of parenchyma is taken so that no cut through will happen. And this is the first and very crucial stitch in the ureter. And the knot is tied. So you can see the ureter is lying without tension. And the posterior part of the anastomosis is being completed. 3 interpreted sutures are taken for the posterior anastomosis. Now a guide wire is placed and a stent is probed over there. Now the stent is in place and the anterior anastomosis is started, and this is started from the ureter and will go up. This stitch is also very important. So again 3 interpreted sutures are taken for the anterior anastomosis. This is completion of the anastomosis. This perinephric fat is used to cover the anastomotic area. So whole of the anastomosis is covered with the fat. It may help to avoid the urine leakage. A small drain is placed. All the ports taken out. The patient was allowed orally on day 1 and drain was remaining nil. Hence follies and drain were removed on day 2 and patient was discharged on day 3. DJ stent removed after 6 weeks. Nephrostogram done. Patient is doing well with a stable creatinine of 1.6. Thanks for watching.
Thank you, Dr. Ankit, for a wonderful video presentation. I have a question for you. Does the spatulation in a ureterocalicostomy differ from the conventional spatulation in a pyeloplasty?
Sir, nothing much actually. this speculation is done on the posterior side, and the thing is too that it should be the lowermost part should settle on the lowermost part of the calicostomy.
Another question was, do you think in a thicker lower pole, there would be a need to
Yes.
take a few everting stitches to get the mucosa out?
Mostly what happens, these patients will be having a chronic obstruction, and eventually it lead to thinned out parenchyma in majority of the cases. And so far I have not done in any case. And moreover, when you take these stitches for the anastomosis, they will take care of the hemostasis and everything.
Thank you very much, Dr. Ankit. Now I hand over the mic to D. Ramesh sir for his expert comments.
Yeah, thanks, Dr. Singh. At the outset, I would like to thank USI and this Congress for inviting me over for the expert comments. Since morning, we have been seeing excellent talks and videos. Regarding the first talk by Dr. Video by Dr. Vijay Radhakrishnan, he showed us two videos by the best in the business. Both Malik and Dr. George P. are the best in the business in laparoscopy. And all of us have been reading about Bowery flap since we got into urology. And Bowery is a person who's an Italian origin, and he had never done a Bowery flap on a patient. So he discovered this procedure while working on dogs. And the first Bowery flap on a patient was done in Yale University, somewhere in the mid 1930s or 1940s, for again ureteric leak, uretrovaginal fistula. Instead of doing a nephrectomy, they attempted this Bowery flap and found it to be successful. The crucial part, of course, like Dr. Radhakrishnan said in the Bowery flap reconstruction, is to maintain the vascular integrity of the flap. And for that, different people have mentioned different ratios of the base and the length, but the ideal would be somewhere in the range of 3:1. People have gone to the extent of quoting even 5:1 in the literature, but I think a good yardstick to use would be a 3:1 ratio between the base and the length. But intraoperative, one can easily determine whether your vascularity on the flap is good enough when you take out the flap. So try to be a little more broader at the apex rather than very narrow at the apex, and then try to base it on the superior vesical pedicle on the ipsilateral side. If need be to take a longer flap, you can take a spiral shaped flap. That would be another recommendation that can be done if you want a longer flap. People have described that you could take this flap up to the pelvis, but then that would be stretching it a little too far unless you have a real capacious bladder. So ideal would be between L3, L4 is the level that you could go up to. And more often than not, currently, the Bowery flap is used in fistula, uretrovaginal fistula, where there's a lot of fibrosis in the lower segment of the ureter and you're not able to mobilize. Earlier days, tuberculosis is one of the reasons where Bowery flaps could be used when the bladder was, of course, not involved. Only the ureteric strictures were there. Could this be done if there is a bilateral pathology? Yeah, I sifted through this literature and we found some stray case reports of bilateral Bowery flaps being done. So what they would do is raise the flap in the midline and put in the ureters on both sides and bisect the flap midway and then close the bladder. That would be the way to do if you want to do it bilaterally. However, things would be complex if these flaps undergo necrosis, because the main complication in Bowery flap would be a urine leak. One would not want a urine leak. That's why I was surprised by Dr. Radhakrishnan's video that he would remove the drain as early as 24 to 48 hours. I think one should be a little cautious, especially when you do a laparoscopic procedure, because most of our anastomosis could be intraperitoneal. So you don't want an intraperitoneal leak. So I would go slow on removing the drains, probably wait for about 72 hours at the minimum, and then see how things go. But with experts like Malik and Dr. George P., I'm sure they would do a great job. So that would be my comments about the Bowery flap. Conventionally, it was an open surgery, but procedures have been done both laparoscopically and with robotic with comfort and ease. Regarding Dr. Ankit's video, wonderful display and presentation, Dr. Ankit. It was nice to see you do that. However, I found that there was a lot of thick parenchyma in your procedure. Most of us who do ureteric calicostomy do it as a salvage procedure. And when the parenchyma is quite thinned out and you want to retain the kidney, you don't want to do a nephrectomy in either a failed pyeloplasty or there's extensive fibrosis in the UPG area where you can't dissect. Generally, it would be under with thinner parenchyma than what we saw in your procedure. The largest series of this ureterocalicostomy I encountered was in a paper from SGPGI, Dr. Anish Srivasta's team. They had 70 cases of ureterocalicostomy which they have assessed, and they did the multivariate analysis, and they found the worst results are on patients who have a low GFR, below 20 mils per minute, and in people who have a thin parenchyma. So these two are adverse factors for doing a ureterocalicostomy in terms of outcomes. So I think one would need to counsel the patients appropriately. If the GFR is very poor or the parenchyma is too thin, I think one would tend to go in for a nephrectomy rather than doing a ureterocalicostomy, unless it's a solitary kidney or unless it's used as a salvage procedure when there's bilateral pathology. On the whole, both the videos which were shown were excellent, and I congratulate both the presenters and thank the moderators for having me over.
Thank you, sir.
Thank you, Ramesh, sir, for throwing more light on the videos. Now going forward, I would like to invite Dr. Abhishek Singh to give his talk on fellowships post MCH.
A very good afternoon to all the viewers. I am Dr. Abhishek Singh, and I thank USI and the U Council for this opportunity. I would be speaking on postdoctoral fellowships post completion of your urology course. My disclosures are that there is no central resource to gather this information. All the information presented is gathered by personal inquiry, and the data presented is also a reflection of personal experience and bias. As is with all these sporting legends, they are as predominant as were their coaches in their lives. Can you imagine Sachin Tendulkar without Ramakant Achrekar or Shivaji Park? What about Serena Williams? Is she an entity without Richard Williams? And we are in Hyderabad. Don't forget that whenever you talk about PV Sindhu, Pulela Gopichand will be there. So setting things in context, the subspecialties that we need to know about are robotic and laparoscopic urology, reconstructive urology, uro-oncology, renal transplantation, female urology, endourology, andrology, and pediatric urology. And you'll soon know why two subspecialties have been highlighted. Let's start with robotic urology. Vattikutti Foundation has 4 fellowships at Kokilaben Hospital, Mumbai, under proctorship of Dr. T.B. Yuvraj, at Max Super Speciality Hospital under proctorship of Dr. Gagan Gautam, at Medanta under the mentorship of Dr. Rajesh Alawat, and at RGCI New Delhi under the mentorship of Dr. Sudhir Rawal sir. The application process is to be done at scholar@vattikuttifoundation.com. You apply with a letter of recommendation and a letter of intent. Stipend would be about ₹1,00,000. The deadline is usually February. There is a new fellowship program initiative taken by Intuitive Surgicals. They have supported this fellowship at 3 centers, mainly RGCI, HCG Bangalore, and then Kokilaben Hospital, Mumbai. The proctors are Dr. Sudhir Rawal, Dr. S.K. Raghunath, and Dr. T.B. Yuvraj. It's a year-long program, and the stipend on offer is about ₹1.25 lakhs. You can apply through the Intuitive website or directly approach the program directors. The 2 other pipeline, the fellowships which are in pipeline, as an Intuitive initiative are by Dr. Hemang Bakshi and Dr. Raghavan at Apollo Chennai. There is another fellowship which has just started at Max Vaishali under proctorship of Dr. Puneet Aluwalia and Dr. Gagan Gautam. This is a year-long fellowship where the student will have to spend 3 days at Max Vaishali and 3 days at Max Saket. He'll get a stipend of about ₹1,00,000. And he can directly contact Dr. Puneet Aluwalia. The last date was 31st August, but they would extend it in case you are still interested. Then coming to laparoscopic fellowships, one of the most the oldest fellowships and the most recognized fellowships is run by Dr. George P. Abraham at the Lakeshore Hospital, Kochi. It's a 6-month duration fellowship. They take 4 candidates per year. There is no stipend and offer. The candidate has to pay a fees of ₹3,00,000 for the course, but then the hands-on experience is very good. The applicant can directly apply to Dr. Datsun George or apply to Sini Jacob, who is the program secretary. There is a university-recognized fellowship at Dr. Suresh Patankar's ACE Hospital, Pune. You have to apply through a MUHS, and it's a year-long fellowship program. Then there is a laparoscopic robotic endourology fellowship program at MPUH Nadiad. This is a World Endourology Society recognized 2-year program, has an intake of 1 student per year. You get a stipend of 1.5 lakh rupees to begin with, which is escalated to 1.8 lakhs for the second year. The program director is Dr. Ravindra Sabnis. MPUH also has a SIU fellowship, which is 6 months in duration. Another World Endourology Society recognized fellowship is run at Safdarjung Hospital. There is a 2-year program in endourology, laparoscopy, and robotic combined under the proctorship of Dr. Anup Kumar. And they also have a year-long program which is dedicated to advanced laparoscopy and robotic training. The trainee can directly contact Dr. Anup Kumar at the said address, and the stipend will be about 1.1 to 1.3 lakh rupees a month. There is a lab and robotic fellowship at offer at Max Hospital under the proctorship of Dr. Anand Kumar sir. The duration is 1 to 2 years. The applications are invited every year, and the selection is based on CV and letter of intent, and the recognition of the program is institutional. Coming to reconstructive urology, there are 3 centers in Maharashtra which offer fellowship in reconstructive urology, namely the Kulkarni Reconstructive Urology Center under the guidance of Dr. Sanjay Kulkarni sir, then Varna Institute of Urosurgery under the proctorship of Dr. Rajiv Kore sir, and at JJ Hospital under the proctorship of Dr. Venkat Gite sir. The Kulkarni Institute at Pune has 2 fellowships. One is recognized by MUHS, the other one is at GURS. The other 3 fellowships that I talked about can be applied through Maharashtra University of Health Sciences. Stipend on offer is about 1.1 lakh. Then coming to uro-oncology fellowships, the most prominent of them is at Tata Memorial Hospital. It's a 2-year program under the directorship of Dr. Ganesh Bakshi. Applications are invited every year. The stipend is about 1.1 lakh rupees. Selection is based on CV and personal interview, and the course starts at 1st October. There is another uro-oncology fellowship with Dr. S.K. Raghunath at HCG Hospital. It is affiliated to the Siddhartha University. They take 2 candidates per year. The selection is based on letter of intent, CV, and personal interview, and they offer a lakh of rupees as a stipend, and this is recognized by Royal College. There is a uro-oncology fellowship for 2 years duration at Amrita Hospital and under the proctorship of Dr. Ginil Kumar. Applications are invited every year. Selection is based on letter of intent, CV, and again on personal interview. The stipend on offer is 70,000 rupees. It is a university recognized program, and those who are interested can contact uro-oncology at aims@amrita.edu. There is another new uro-oncology fellowship at Indo-American Institute, Hyderabad, under the dynamic leadership of Dr. Rakesh Sharma. This is a 1-year duration fellowship. If you are interested, you have to apply through an entrance exam, which is an MCQ-based exam followed by a personal interview. The session runs from December to December, and you can get the details on this particular website. The new fellowship at Tata Memorial Center, Kolkata, has a intake capacity of 4 students per year. It is a 1-year fellowship extendable to 2 years, and you can apply to Dr. Sujoy Gupta. The stipend is about 1.25 lakh rupees per year. Last date of application was 31st August, but you could still try to apply. Then coming to the fellowships at Central Institutes, so SGPGI offers 3 fellowships. The first one is in pediatric urology. It is a 1-year program under directorship of Dr. M.D. Ansari. It has intake of 2 candidates per year, a summer and a winter admission, and applications are to be made to registrar of SGPGI. Similarly, there is another fellowship at SGPGI under the proctorship of Dr. Anish Srivastav, which is dedicated to renal transplantation and has a duration of 1 year. The third fellowship at SGPGI is under the leadership or proctorship of Dr. Uday Pratap Singh and is dedicated to uro-oncology. You can apply based on your CV and a personal interview. Recognition for all these 3 is institutional. Coming to the other Central Institute, All India Institute of Medical Sciences, they again have 3 fellowships under the aegis of urology department. They are uro-oncology fellowship, minimal access urology fellowship, and genitourinary reconstruction fellowship. The openings in this fellowship can be variable depending on the time of the year. AIMS also offers a fellowship in renal transplantation, which is under the aegis of Department of General Surgery. The application process for fellowships at AIMS is a 2-stage process. You write a written exam, which is a 60-mark MCQ, followed by a personal interview. The stipend on offer is about 1.25 lakh rupees per month. There is a July and Jan session, so watch out for advertisement as the number of openings keep on varying. Then you have an endourology fellowship at Global Rainbow Hospital under the proctorship of Dr. Madhusudan Agrawal. The duration is 1 year. They also offer a 3-month and a 15-day course. The applications are invited every year. Stipend is available for the 1-year program. The selection is based on CV and the letter of intent, and the applications can be made to Dr. Madhusudan Agrawal sir and Dr. Dilip Mishra. Then there is an endourology laparoscopic fellowship program at Preeti Hospital, Hyderabad. It is a 6-month duration program, and the program director is Dr. Chandra Mohan V. They take 2 fellows every 6 months. Stipend on offer is about 50,000 per month. You can contact the website of Preeti Hospitals for further details. Now coming to important fellowship programs which are non-existent for a urologist actually. Look at urogynecology. 2 centers offer that. One is the All India Institute and second is KIMS Hyderabad, but they are also selectively biased towards the gynecologists, and it's very difficult for a urologist to get into these programs. Sadly, andrology does not have a dedicated fellowship program for a year, but you can have short observerships, and of course international options still exist. World Endourology Society has many options outside North America where you can directly apply for fellowships. About 6 in Asia Pacific are there. Now, there is these short-term international fellowships are very, very important. To name a few, IAUH Chakraborty Fellowship, which gives you a grant for 6 weeks. Then World Endourology Society Fellowships, these are 4 in number, and non-academic urologists can also apply. JUA Fellowship offers about 1.5 to 3 lakh yen as a grant, and the duration can be about 1 to 3 months. EAU Fellowship gives about 3,000 pounds, and it is again 6 months to 3 months. And then similarly, you have SIU and UAA Fellowship. And there are centers which offer 1-week training in robotics, which is Atlas at the Roosevelt Park Cancer Center, Orsi in Belgium. Then you have the Declan Murphy Center and Global Robotic Institutes at Celebrations USA by Dr. Vipul Patel. USI is offering MIUC Traveling Fellowship and Member Traveling Fellowship, and there are a few fellowships also in the pipeline which you'll hear about soon. West Zone offers a MIUC fellowship also. The prospects after doing these fellowships are great. You can see these 3 individuals who got selected for Chakraborty fellowships are at pinnacle of their career and inspire all of us. These 3 gentlemen have done a formal training in a 2-year training fellowship program, and they definitely got better jobs with the corporate, had good visibility, have developed a subspecialty, and are climbing academic ladders. So I leave you with this parting thought: all the top athletes in the world, singers, have coaches, and why are we as urological surgeons ashamed of doing the same? Thank you for a patient listening. Now I invite Dr. Amit Gaur for his presentation.
Hello friends, I'm Dr. Amit Gaur. I would be speaking about mutual funds for financial goals. The basic concept of mutual fund. A mutual fund is a trust that pools the saving of number of investors who share a common financial goal. The money thus allocated is then invested in capital market instruments such as shares, debts, debentures, and other securities. Mutual funds have a fund manager who invests the money on behalf of investors by buying, selling stocks, bonds, etc. What's the basic concept of mutual fund? The income earned through these investments and the capital appreciation realized are shared by the unit holders in proportion to the number of units owned by them. Thus, a mutual fund is the most suitable investment for common man, as it offers an opportunity to invest in diversified, professionally managed baskets of securities at a relatively low cost and with returns that beat inflation. Classification. We classify mutual funds based on maturity period. It can be open-ended, you can enter in and out anytime. Close-ended, you enter in and you can only exit out after a certain duration. Second is by investment objective or type of assets. It can be equity, it is for growth, debt, it's for safety, balanced fund for both. So equity funds, depending on market cap, it can be large, mid, small and multi-cap. It can be sector funds, infrastructure, banking, pharma, etc. It can be index funds. It can be tax saving funds, also known as equity linked saving scheme. It can be arbitrage funds where there is absolutely no risk. What is arbitrage fund? It is a read up. It's like buying coffee from one person A for A rupees and selling it to another person for 6 rupees. So you get the profit of 1 rupees without even having to buy, having to prepare your own coffee. That is arbitrage, buying and selling. So money market funds or liquid funds. they are the type of mutual funds. They invest in short-term debt instruments. They are low risk, suitable for parking our surplus money over short term. These are an alternative for putting money in saving bank account. They are a best alternative for saving bank account. The another funds are debt mutual funds. They invest a majority of money in debt fixed incomes such as fixed coupon bearing instruments like government securities, bonds, debentures, etc. They have a low risk. There is general belief that among some investors that debt funds are like fixed deposit and are safe. It's not safe. The returns are not fixed, not guaranteed, unlike FDs where the returns are guaranteed and fixed. Balance funds. Balance funds are something which invest in both equity and debt. If 100 rupees is a portfolio, 65% will be in equity and remaining 35% in debt instruments. So they are balanced. Their allocation keeps changing based on the market risk. They are more suitable for investors who are looking for at a combination of moderate returns and comparatively low risk. However, they carry significant risk based on balanced fund because they have the equity part. 65% is in equity. Hybrid funds. They are similar to balanced funds, but in balanced funds, the equity asset allocation was 65. Here it is less than 65. Normally, it is kept between 20 to 25%, 20 to 35% based on the market conditions as gauged by the fund manager. So the equity allocation is less than balanced funds. They are suitable for investors who are retired and want a regular income with a comparatively lower risk. As the equity part is low, the risk is low. But remember, when the markets fall, there could be a significant fall in the valuation also, because they have significant close to 20 to 35% of the portfolio in equity. Gilt funds. Gilt funds are nothing but government securities. They are preferred by investors who are risk averse and do not want credit risk. Credit risk is if you lend money to someone, he may or may not give back money. But in government securities, the government is definitely going to give money after the stipulated time with the fixed interest. So there is no credit risk. However, they are subjected to higher interest rate risk. Why should we invest? Investment is important because inflation is eating away your money. Value of money is always falling. The money which you require now to buy some things for 13,000 rupees, after 25 years, you will require 1 lakh rupees to buy the same thing, considering inflation at 7%. It is getting compounded. 7% today, 100 rupees is the cost of commodity today, 107. Then the second year, 7% of 107. It's getting compounded. So investment is equally important. So if you spend 50,000 rupees per month today, after 25 years to maintain the same lifestyle, you will require 4 lakh rupees per month. That's why you have to invest. You have to beat the inflation. So in short, anything which is giving you less than the inflation rate, 7%, any investment post taxation, if it is giving you less than 7%, it is not going to beat the inflation and it will lead on to wealth erosion. That's why you have to invest. So before you invest, make sure you have 6 months of emergency as corpus fund in your pool. You can divide it into cash, saving bank, liquid funds, FDs. 6 months of your monthly expenses. Calculate your monthly expenses. Have 6 months of it. Monthly expenses include everything: the essentials, non-essentials, your EMI put together, and have a risk cover. Risk cover is having a health and term plan. It's like Sachin Tendulkar doesn't just go take his bat and score the runs. He wears the center guard, he wears the helmet, he wears the pads. Those are his risk protection. He has to protect himself. Similarly, you have to protect yourself. And third thing is understand the risk involved and know your risk taking capacity. Make goals and plan your investment. So make a timeline for goals, name the funds and track the goals. To sum it up, when you are investing, set up the goals, set up the time frame, know your risk profile, and then select the funds. Rebalance the funds as per the risk taking behavior by mixing equity and debt. Rule of thumb is 100 minus your age should be the percentage of your assets or your savings into equity. So if your age is 40, 100 minus 40 is 60. 60% of your savings should go into equity. Make realistic goals. Don't be unrealistic. Have realistic goals for returns, expected returns. Just make it 9 to 12%. Keep it simple. There are online calculators available to calculate the goals and the future amount required, and other plannings can definitely be done. Index funds. Both index funds and ETFs are investing in the same product. We speak about Nifty is up, Sensex is up. They are basically index. So these funds are investing in the indexes only. So index fund is mutual fund. ETF is from the demat account. For ETF, you need a demat account. For index fund, you have to go through the asset management company. So whenever you select the fund, there are two options: direct and regular. Always select direct option as you are saving 1% cost per year. So growth versus dividend, always select growth. Don't select dividend. Dividend is they will be cancelling the units, putting tax on it and giving you the dividends. So in short, when you're selecting the fund should be direct growth option only. In this example, I have given you access focused 25 growth option only, direct. So ideally number of funds should be 5 to 6 only. Don't keep larger number of funds. Keep track of changes in the policy of fund manager. Every 6-12 months review it. And if the fund is consistent underperformer for persistent 2 years compared to its same category of funds, its peers, exit off. That's a flexibility which the fund is giving to you. So equity taxation. Equity mutual fund is taxed at long-term capital gains is taxed at long-term capital gain is holding period more than 1 year is taxed at 10% of the profits over and above 1 lakhs in a financial year. Up to 1 lakhs is tax free. So debt funds, if the holding period is less than 3 years, the capital gains will be added to your income and taxed as per your bracket. More than 3 years, 20% with indexation. Indexation is taking into account the inflation. So equity component can be large cap, index fund, multi-cap, international, mid-cap. Debt funds may be public provident fund, Sukhana Samriddhi, RD, arbitrage, gold is ornaments and digital gold. So most important is how do you exit. So you exit few years before when the goal comes in. Don't exit when your goal year is in 2024. Don't exit in the same year. Exit slowly 3-4 years before, because when the goal approaches, if the equity market falls in that same year, you will have attrition in the value of the funds. So exit strategy is very important. It's like chakra viewer. You have to go inside and come out both successfully. Falling markets. When the wealth is creation for long term, don't stop any SIPs. Just go on investing in systematic way. Don't just stop investing. So it is important to be patient. Patient pays off. So whenever the Sensex is falling, people stop their investments, which is contrary. Don't stop your investments when the markets are falling. Keep investing. This chart will tell you the valuation of it. So those who have invested in the downs, they have created huge wealth. So keep investing irrespective of ups and downs in the market. So the bottom line is stay invested, keep investing. Don't worry about the markets. Have a wonderful day. God bless you all.
Thank you, Dr. Amit. Now I hand over the proceedings back to Dr. Dilip. Thank you.
Thank you, Abhishek and Zahid, for carrying forward this session. Now we would head over to the next session of andrology, which is to be moderated by Dr. Raman Tawar and Dr. Karthikeyan. I will invite Anil Ellen sir as an expert for this session, and Dr. Vinod KV sir will be giving expert comments online. So hand over to you, Raman and Karthikeyan.
Thank you, Dr. Dilip, for inviting us and for trusting us with the andrology subspecialty. Now, as Dr. Abhishek said, that this is a niche subspecialty that a lot of people are not practicing, and I am glad to have Karthikeyan with me. And since he looks to be on the go, so I will just start the proceedings. And I would like to introduce our experts, Dr. Anil Ellens. He's the principal urology consultant at Dhanvantari Hospital, Meerut. Now he's got a huge name in Meerut, and a lot of patients, take his name when they come over to Delhi and Gurgaon. He has been the past president of the North Zone Council of the USI and chapter of the USI, and he's been the past president of the U also, the Uttar Pradesh and Uttarakhand Urological Association. And along with him, we have Dr. Vinod KV, another veteran in the field of andrology. And he basically is the chief urologist at Cure Urology Center. And he's in Thiruvananthapuram, Kerala. And he's the council member for the USI, and he's a part of the guidelines committee of the male infertility for the USI. And he's always there whenever we have any andrology thing going on across the nation. And he's a leading expert for that. Now, with the permission of both the experts, what we will do is, me and Karthikeyan will introduce all the speakers also, so that the experts can give their expert opinion in the end, just to save time. And in between, if there are any things that they would like to, enhance the talk with, they're most welcome to do that. So Anil sir and Vinod sir, can we invite the first speaker for the day, which is Dr. Pramod Krishnappa. He's a consultant andrologist at NU Hospital and NU Fertility, Bangalore. And basically, he'll be talking about how to set up your andrology practice and lab. And his area of interest is mainly also, again, male infertility and prostatic urology. So with that, I would invite Dr. Pramod Krishnappa to deliver his talk.
Greetings from NU Hospitals, Bangalore. Myself, Dr. Pramod Krishnappa. I will be discussing about how to set up an andrology practice and few aspects about the andrology lab and not about the IVF lab. Andrology, as we all know, involves male infertility and male sexual dysfunction. We cover all these aspects in male sexual dysfunction. And we need to do an andrology observership or a fellowship before we set up the andrology practice, because we know that there has been no formal andrology training during our urology PG days. Hence, we need to get our concepts right before we start. In India, there are observership opportunities, but for fellowships, you need to look at these sexual medicine societies. And of all this, United States has the best well-organized andrology fellowship programs. My personal journey in andrology training started in Spain, where for 3 months, where I learned about the penile implants, artificial sphincters, and Peyronie's disease surgeries, and so on. In Belgrade, I learned about the penile reconstruction and the gender reassignment surgeries, followed by male infertility training in Chicago under Professor Craig Heidelberger. I will stress upon a few specific points required to start a good andrology practice, starting with the penile Doppler. Yes, of course, you don't need this in every case of erectile dysfunction or a Peyronie's disease. In fact, there are reports saying that if you do a good intracavernous injection test and if you have the EHS erection hardness scale, you can avoid doing duplex ultrasounds in all these patients, in majority of these patients. If you still would like to do a penile Doppler, speak with the radiologist and devise a standardized template. And also, sometimes you may need to help the radiologist for the intracavernous injection part. And in most Western countries, the urologist does the Dopplers, penile Dopplers, whereas in India, that may be an issue due to the government regulations. You can have this small fancy scale in your clinic just to know the degree of rigidity of the penis. Intracavernous injections plays a significant part both for diagnostic and the therapeutic purpose. I use alprostadil and I reconstitute this and it is kept in the refrigerator. And if somebody asks for the vacuum erection devices, if you're a high volume center, you can keep this in the pharmacies. But if not so, then you can give this website link so that they can purchase it online. And make sure that you know these devices in detail before you advise it to somebody. And there are various penile implants. Be familiarized with all the upcoming implants, malleable and the inflatable implants. And having a shockwave treatment or a PRP injections is not compulsory for an initial andrology setup because these are all still considered investigational. And forget about the collagenase, it is not affordable. And as of now, available only in the United States, it was withdrawn from the European market in November 2019. And also be familiarized with the various grafts that are used in penile curvature correction in the Peyronie's disease. And also inform the patients about the extra cost of these grafts. Penile traction devices are fast catching up and it has been promoted as a non-invasive modality to curvature, to treat curvatures in the Peyronie's disease. There are various models that are available. And having a psychosexual counselor in your department helps you to better treat your patients so that they take care of the counseling part and you take care of the medical or the surgical aspects. To do a varicocele surgery, I would always suggest to have a surgical microscope and a microdoppler. I personally use the Z surgical microscope, but if you're in a multi-specialty hospital, you can borrow it from the neurosurgeons or from the from the ENT or from the ophthalm surgeons. Microdoppler helps us to preserve the testicular artery better because it's easy to injure testicular artery during varicocele surgery. And you need a certain extent of skill to do a vasovasostomy and also even the micro TCF for surgical sperm retrieval. For the semen analysis, you need this laminar airflow and we use a cryocell sperm counting chamber. And of course, the centrifuge and microscope are also needed for semen analysis. If your facility also would like to have the sperm cryopreservation facility, you need to have these cryotanks, and of course various solutions to process the sperm for preservation, like radiant solutions, sperm wash, and the preservant, and so on. In an ejaculation case, you will require this penile vibrator. You can initially, to start with, you can use a local DC one, just a massager or a vibrator, which will cost you around 3,000 rupees. And once you have a good volume of patients, then you can switch on to this vibrate. But this is expensive, cost you around 35 to 40,000. Also get associated with one of the nearby genetics labs, so that you will have to do this genetic test in some of the azoospermia patients. Most important, if you want to have a full-fledged andrology practice, familiarize with the reproductive medicine consultants and the embryologist. Basically, get to know the language, terms like OPU, egg pickup, ovum pickup, and ET is embryo transfer, and so on. Because sometimes they will call up and ask you, doctor, would you like to do the sperm retrieval on the day of OPU, or you would like to do it before the OPU, and so on. So get familiarized with them, so that it will be really helpful in treating the couple in a better way. And also increase your referral base by approaching all these various specialties. And also oncofertility is fast catching up, where some of these cancer patients are being referred to the andrologist and the reproductive medicine consultants before the start of chemo or the radiotherapy. And also try to engage the general public, either by giving talks to the elderly clubs that are there, and also the software companies, so that you can educate them. There is something called a branch called andrology, and we are here to help you. And I work at the Henio Hospitals, Bangalore. So there are a few things that has really helped me to establish a full-fledged andrology practice. These are, this is an fertility hospital, dedicated hospital, and we do subspecialty practice in urology. We are full-time. We have 3 PGs per year, and the IVF lab is ISAR accredited, because around 30 to 40% of your andrology practice will be made in fertility. And we have a full-fledged reproductive medicine and the embryologist, and we also have a separate front office team to handle these sensitive patients, and try to highlight your department in the hospital, so that patients are aware of what andrology is. Thank you.
Time to move to the next talk. The next talk is basically by Dr. Vilvapati S. Karthikeyan, and he'll be talking about evaluating ED more effectively. And he's a consultant urologist and lead andrologist and men's health specialist at Sri Narayani Hospital and Research Center at Vellore, with his area of interest being andrology and men's health. So without further ado, let's hear what Karthikeyan VS has to say.
I thank the Youth USI for providing this opportunity to present on the topic, evaluating erectile dysfunction more effectively. Throughout this presentation, we will be seeing how exactly we can improvise on evaluating ED in the OPD. What are the goals of ED evaluation? To arrive at an etiological diagnosis, identify what is the pathophysiology and the severity of the disease, plan effective treatment based on these 2 factors, and also prognosticate what the success rate will be after the treatment. The typical case scenarios we see are a young male recently married with mild improvement with PDE5 inhibitors of 45-year-old middle-aged man with a 6-month history of ED with no much improvement with PDE5, and an elderly male diabetic with a long-standing history of ED with no response to PDE5 inhibitors. So how do we proceed? Routinely, what we do is we assess the duration. We do risk factor assessment in the form of sugars, lipids, and testosterone. Some ask for a cardiology consultation, and some of us even go for a psychiatric workup, especially in young couples. We routinely prescribe them medicines, and we call them for checkup. How do we refine our erectile dysfunction assessment? So it should be to identify the onset, duration, conditions associated with ED, severity, and also an etiological diagnosis. Identify problems other than ED, psychosocial status, signs of hypogonadism, and cardiovascular and neurological status. All these things are additional things which will guide the therapy. Coming to history, there should be a clear distinction between erectile dysfunction and premature ejaculation. The onset, the duration, the present severity, presence of libido, quality of morning erections, whether there is a difficulty in initiating or maintaining erection or both, what is the frequency of intercourse and the number of attempts per intercourse. All these things guide us in how do we plan the treatment. If there are multiple partners, what is the relation of ED with partners and whether the couple is consummated if it is a newlywed couple. What is the quality of erection with masturbation, whether there is any difference, orgasm and ejaculatory function. Also associated symptoms like short penis, curvature, plaque, all these things give an idea about the what exactly we are dealing with and what is the severity of the disease, the sexual orientation of the male, and also the partner's preference and the present relationship with the female partner. So all these things will guide us to plan our treatment. Hypogonadism can be assessed by this questionnaire, androgen deficiency in the aging male. Comorbidities, especially diabetes, the duration, control, what is the mode of therapy and complications will help us to assess the amount of damage which the diabetes has made. Cardiac assessment, other arterial diseases like stroke, peripheral arterial disease, etc. Prescription drugs, especially nitrates, so that we have to see how do we combine those drugs with our drugs. Over-the-counter drugs, especially PDE5 inhibitors, they give us an idea about what is the severity and what is the effect of the PDE5 inhibitors. Testosterone and personal history also has to be asked. Objective assessment can be done by the SHIM score to categorize the ED based on these categories. Similarly, the erection hardness score. So grade 1, the penis is not hard. It is hard but not enough for penetration. Okay for penetration, and this is maximum rigidity. So this gives a clear idea and very objective assessment of the erection function, erectile function in the OPD. Examination, specific things, BMI waist hip ratio, cardiovascular assessment, secondary sexual characters and gynecomastia. Also testis volume. All these things can give us an idea about the causation. Plaque, deformity and curvature indicates that there is more aggressive treatment necessary. At this stage, we have to differentiate between psychogenic and organic ED, though we cannot dichotomize the classes, the ED into these two specific categories. But we can to a fair extent identify what we are dealing with and we can plan the treatment. In summary, a comprehensive medical and sexual history with use of validated questionnaires and focused physical examination are important. We have to assess the causative things like reversible risk factors, cardiovascular cause, pelvic trauma, psychosocial distress. These are the causative things, and contributory factors like newly detected diabetes, hyperlipidemia, low testosterone, hypogonadism. So optimization of all these things will give a successful management in ED. Based on this panel, we can plan our investigations. Next important thing is the office sildenafil test, which is by far the most important test to be inculcated in the evaluation of ED. This assesses the quality of erection in the office after a 100 mg sildenafil dose usually, gives immediate result. Therefore, the patient also gets the confidence. We also get to know how good the drug is, whether there are any side effects. It can also help us in assessing curvatures, tight frenulum, masturbation ejaculatory latency time, and thus help us in differentiating psychogenic and organic causes in most people, but severe psychogenic ED sometimes will have a negative result on OST, and sometimes the clinic conditions are not suitable. Testosterone can help us in managing the ED, but this is not the only foolproof test. Similarly, SHBG is important, especially in obesity. When there is decreased SHBG, the total T may be reduced, but the free T may be normal. Just to bear in mind that always low T need not be treated initially. Intracameral injection is the second important test after OST, especially in diabetes, vascular disease, failed OST especially, in a very anxious or a preoccupied patient in unconsummated marriage, and for curvature assessment. This bypasses the neurohormone influences and therefore is more objective in assessing the penile vascularity. Goniometry for curvature assessment, cardiac evaluation, especially when there is angina, shortness of breath, inability to climb 2 flights of stairs in 10 seconds, and palpitations. If there is a failed OST or even the ICI, then ECG echo TMT can be planned, and we can obtain a formal cardiology consultation. The Princeton 3 guidelines can be used. Low risk and intermediate risk who pass the stress test can be prescribed drugs safely, while high risk category, they need more evaluation and withholding the drugs. Special diagnostic tests in special situations, penile deformities, young patients with perineal trauma, planning revascularization, complex psychiatric condition, etc. A psychodiagnostic evaluation is most useful in the recent times. Partner interview is very important. It can affect the diagnosis and treatment in up to 58%, provides new perspectives. Partner involvement and attitude can guide the patient's therapy, and also long-standing male ED can result in female sexual dysfunction. So based on the AUA best practice statement, we can conclude that to evaluate ED more effectively, we have to use the focused history, EHS, SHIM score, off-face sildenafil test, with or without the intracavernosal injection, cardiac assessment, especially using the Princeton 3 guidelines, female partner interview and expectations, and a shared decision making with the patient can actually effectively evaluate and treat ED in the andrology OPD. And effective evaluation and management of ED is a teamwork. Thank you.
Karthikeyan, for this wonderful talk. I think you've touched most of the aspects of how to evaluate ED more practically. And further on, I think we move to the last talk of this session before we move to the video presentations. And this talk is by Dr. Arun Karthik P. He is the director and consultant of Alpha Life Specialty Clinic, Androvan Men's Health Clinic in Salem and Namakkal. Now that's in Tamil Nadu. And his area of interest is almost all domains of andrology. He will be talking on the algorithm-based approach to the ejaculatory disorders. So over to Dr. Arun Karthik, please.
Very good afternoon, one and all. I would like to thank the USA and the youth organization of USA for giving me this wonderful opportunity. I'll be discussing today on management of ejaculatory problems. The various ejaculatory problems I'll be discussing today mainly on premature ejaculation, delayed ejaculation, and retrograde ejaculation. The premature ejaculation, earlier considered to be a complaint, is now to be considered as a syndrome. Earlier classification was lifelong premature ejaculation or acute premature ejaculation. Now there are two additions to it, which are variable PE and subjective PE as proposed by Waldinger. Of the four PE syndromes, the variable premature ejaculation and acute premature ejaculation are more common, whereas the lifelong premature ejaculation or subjective are less common. So diagnosis of premature ejaculation is mainly based on the patient history, preferably with the partner. We need to ask for the time for to ejaculation from the onset of penetration, the perceived degree of ejaculatory control, the degree of bother or the stress, the onset and duration of premature ejaculation, the psychosocial and relationship issues, the medical history to rule out the secondary causes like erectile dysfunction or any hormonal disorders, physical examination. As I mentioned, the history is the cornerstone of the diagnosis. Based on it, we can differentiate whether it's a subjective PE or variable PE. If premature ejaculation is consistent, we need to rule out secondary cause, erectile dysfunction or any other sexual dysfunction. If there are no secondary cause, we need to differentiate between acute premature ejaculation or lifelong premature ejaculation, because we can treat accordingly. The various treatment options available for premature ejaculation are the psychosexual therapy, pharmacotherapy, and treating the underlying cause in case of acute premature ejaculation, like PDE inhibitors in case of erectile dysfunction, antibiotics in case of bacterial prostatitis, and treatment of hyperthyroidism. So what has happened over the past 3 decades is a shift of treatment of premature ejaculation from psychotherapy to drug therapy. Daboxetine was the first compound which was developed for treatment of premature ejaculation. It's a selective serotonin reuptake inhibitor, which is fast acting and has a short half-life. There is level 1A evidence to support its efficacy and safety of on-demand dosing of daboxetine. Currently, it is the only approved medication available for premature ejaculation. So as the study shows that daboxetine at the dose of 30 milligram or 60 milligram, a significant improvement that is delaying in intravaginal ejaculation time, even from the first dose, and is persistent or it continues use over 24 weeks. So the off-label treatment options available for premature ejaculation are the sex therapy or the behavioral therapy, topical therapy with anesthetic agents, Apart from depoxytin, the other SSRIs are paroxetine, cetyline, fluoxetine, citalopram. Tricyclic antidepressant, antidepressant like clomipramine can also be tried. The other drugs which have been proposed are PDE5 inhibitors, tramadol, or the combination of all the medication which I mentioned above can also be used. So the meta-analysis of various placebo-controlled studies showed significant efficacy of paroxetine, the dose of 10 to 40, cetyline, the dose of 50 to 100, fluoxetine of 20 to 40, citalopram at 20, and escitalopram can be used. Of all the SSRIs, paroxetine shows the strongest efficacy. Local anesthetic agents, they were effective in 70 to 90% of the patient. They cause significant penile hyposthesia. In female, it can cause vaginal numbness or female anorgasmia because of transvaginal absorption. The male partner can experience local irritation and burning pain. So this prevents the men from preferring local anesthetic agent. Coming to psychosocial therapy, the main concept is we need to educate the man to identify and respond to the body sensations which precede the ejaculation. The other behavioral exercises which can be used are start-stop technique or squeeze technique, sensate focus, cognitive interventions, couple therapy can also be tried. Rather than psychosexual therapy alone, psychosocial therapy with pharmacotherapy will be a preferable option. In a study which compared dapagliflozin or dapagliflozin with sex therapy, the combination therapy proved to have a better outcome. The intravaginal ejaculate latency time increased better with the combination therapy. Coming to delayed ejaculation, the various terms used are retarded, inhibited, inadequate, difficult. Even anejaculation, anorgasmia can also be considered as a part of delayed ejaculation. It is the least common studied or understood male sexual dysfunction. The management is preferably lifestyle changes, as the patient to reduce alcohol consumption, ask him not to involve in a sexual activity when he is tired, decreasing the frequency of masturbation. Various psychosexual therapies also been tried in case of delayed ejaculation. When patient does not respond to medical therapy, it's better to refer to a proper psychosexual counselor. Then will be the pharmacotherapy. There are various drugs which have been tried, whether on demand or daily dosing. The drugs which can tried for the delayed ejaculation are cabergoline, amantadine, pseudoephedrine, reboxetine, bupropion, buspirion. Various drugs have been proposed, but none of them are effective in all. The reason being because few drugs may be beneficial of few may not help in some patients. So mainly because of this, the sexual behavior changes are according to situations, individual and dynamic. Especially the ejaculation is a complicated problem. So whenever medical therapy does not succeed, it is better to go for a psychosexual, real psychosexual counseling. Coming to retrograde ejaculation, the interesting thing about retrograde ejaculation is usually organic in origin. It's not associated with the psychosexual causes. It is seen in about 0.2% to 2% of infertile men. Medical management have been tried, like sympathomimetics, pseudoephedrine, phenylpropylamine and metrodrine. Anti-muscarinic agents like brompheniramine or imipramine have also been tried. Combination of both can also be used. The surgical options where bladder neck reconstruction or collagen injection into the bladder neck have also been tried. But both medical and surgical therapy have not much of benefit. So finally, though we are not able to achieve anticate ejaculation, we need to retrieve sperm in case of infertile men. So the various methods advised were centrifugation and resuspension of post-ejaculatory urine sample, Hodgkin's or modified Hodgkin's technique. Hodgkin's technique where ringer lactate was introduced in the bladder and sperm was retrieved from that. Whereas in modified Hodgkin's, instead of ringer lactate, sperm media was used. And patient also been asked to ejaculate on a full bladder. So various methods have been tried to retrieve motile live sperm from the urine. But if we fail, we can go for sperm retrieval technique, either TISA or PISA. So the management of ejaculatory dysfunction is not straightforward. It either sometimes pharmacotherapy can benefit or a psychotherapy can benefit. Sometimes combination can be used. So it is individual. So a detailed history taking either with the patient and along the partner is essential and needing to identify it and treat it accordingly. So thank you for this wonderful opportunity.
Thank you, Dr. Arun Karthik, for this wonderful talk. It was a very practical talk. And we will be moving on to the videos now. Dr. Karthikeyan Naganathan will be taking that forward. And we will have all the discussions by the experts at the end so as to, save some time and to stick on this schedule. Over to Dr. Naganathan.
Yeah, thank you, Raman. And we have come to the final session of the first day of the second edition of Youth Conclave. And now we are going to have the video presentation. We are going to have the first video presentation by Dr. Raghavendra Kosagi. He is a consultant andrologist at AIG Hospital, Hyderabad. He is going to demonstrate on microsurgical varicocectomy. Over to you.
Good afternoon, everyone. Thank you, USI Youth Wing and Dr. Raman Tarwal for giving me this opportunity. Now I am going to present a video on microsurgical varicocelectomy. So before going, what are the proper indications? Well-established indications for microsurgical varicocelectomy: a clinically palpable varicocele with documented subfertility with abnormal semen parameters, and testicular atrophy, a reduction of more than 20% of volume discrepancy, and chronic arcalgia. And the evolving indications like eye DNA fragmentation index and eye oxidative stress, and selective indications like hypogonadism or non-obstructive azoospermia. So these are the operating steps, anesthesia, which I'll be discussing in the next slides. So this is the operating microscope which I use, and position is very important. There should not be any neck bending so that you cannot work on a long-term basis, and your hand should be resting on the patient without any hanging movements. So the first step is identify after preparation and draping after spinal anesthesia, or it can be a general anesthesia, but routinely I perform with heavy sedation with local anesthesia supplement. The first step is identification of the external inguinal ring. So I can mark it. After marking, I can go the inguinal, subinguinal incision, where you can open fascia carpus and fascia camper with the help of diathermy. You can take help of the curved mosquito or curved medium hemostat to dissect these layers. You can dissect it further down. After that, you can use either Langenbach's or Gcnis retractor to identify the spermatic cord. Just you can separate the layers, you can go on to the spermatic cord, where you can see that spermatic cord. The next step will be, in case of 50% of the cases, you can see an external spermatic vein. After delivering the spermatic cord, you should check both sides on either side of the spermatic cord, even at the floor level, to look for any floor veins or external spermatic veins running parallel to the spermatic cord, or it can be piercing the floor of the inguinal canal. In this case, there is a external spermatic vein which I am ligating. So there is a vein, I am dissecting it and ligating with the silk sutures, 3 silk sutures. And after that, I will deliver the spermatic cord. Will take a medium curved artery. Some people will dissect below the within the canal itself, or some people use a Penrose drain, but I prefer this. After this, all the surgery will be under microscope. With usual, I perform at 10x magnification. This is one what I use during my surgery, intraoperative Doppler, to identify the internal spermatic artery. The first step, if it is visible, I will identify the internal spermatic artery and I isolate it. If it is not visible, I can ligate the main internal spermatic veins. I'll proceed further to identify the artery and lymphatics, where you can see the pulsations with the Doppler, which is very helpful and it will reduce the time of the surgery by easily identifying the artery. And this is another surgery which is a complete. I can present here. Other steps you can see in this, where I am delivering the spermatic cord. I am putting the hemostat or reverse of the forceps, and I am opening external spermatic fascia and internal spermatic fascia on both sides. In this case, it is easily visible an internal spermatic artery. You can see the pulsations. I am isolating with a silk suture. You can also use a vessel loop. So, and I am ligating the visible internal spermatic vessels. So, if you want to more secure, you can remove the segment of the vein to avoid recurrence or recanalizations. Where I am taking a piece of vein to avoid recurrence. You can see here there is one more artery here visible, the branch. So, with the help of papaverine and intraoperative Doppler, we can identify these arteries. And the crux of the story in microsurgical varicocelectomy is identifying the internal spermatic artery and preserving the artery, because more than 80% of the blood supply of the testis is from the internal spermatic vessels. You have to preserve these vessels for better outcomes. And these are the lymphatics. After that, I will run over the card under my finger to look for any small vessels to coagulate with the bipolar energy, even small vessels. After that, I will put the cord into the inguinal canal and I will close the spermatic fascia. And later, I will close subcutaneous tissues, and with subcuticular fashion, I will close the skin incision. Hardly it is a 2 to 2.5 centimeters incision. You can see here. It is a subinguinal microsurgical mini incision varicocelectomy. So, the complications may be it can be injury to the internal spermatic artery. In spite of all precautions, there is a possibility of recurrence and persistence of the varicocele. Sometimes you can see hydrocele or scrotal hematomas, but in microsurgical subinguinal varicocelectomy, these incidents are very rare. And this is the complications data from comparing the other modalities. When compared to other modalities, reasonably subinguinal microsurgical varicocelectomy is well established. So, the take-home message from EIU 2020 guidelines: treat infertile men with clinical varicocele, abnormal semen parameters, otherwise unexplained infertility in a couple where the female partner has got good ovarian reserve to improve the fertility rates. The take-home message: so, subinguinal microsurgical varicocelectomy is the gold standard procedure. So, probably we have to learn these microsurgical skills for better outcomes to our patients. Thank you.
Thank you, Raghavendra. That was an excellent video demonstration. We're now going to have the final presentation for today's program. It's going to be another video presentation by Dr. Rahul Reddy. He is the director and consultant at Androkar Andrology Institute, Hyderabad. He is going to demonstrate a video on sperm extraction techniques. Over to you, doctor.
Good afternoon, everyone. My today's topic is on sperm retrieval method. This is a very useful thing for any urologist for starting their practice, because most of the fertility centers now they need urologist help for sperm retrieval, and a very small place, district headquarters, towns, all these fertility centers are coming up. So now at least to help them, we should be aware of these procedures, even if you are not into regular andrology practice. So now let us see what the possible methods of sperm retrieval. One is TISA, which is percutaneous epidermal sperm aspiration. Second one is TISA, which is testicular sperm aspiration. Third one is microsurgical epidermal sperm aspiration. Fourth one is TISA, which is similar to our open biopsy, which is testicular sperm extraction. And fifth one is micro-TISA, which is microsurgical testicular sperm extraction. First four are easy to do. Only for the fifth one, you need some training and expertise. So what are the instruments needed? We need a 18 gauge butterfly needle or scalping needle for TISA procedure. But for TISA, you need a 1 ml BD syringe, and you need a 20 cc syringe, and sperm wash culture media of 90 forceps, microsurgical instrument, particularly if you are doing a micro-TISA procedure, and you need an operating microscope. Precautions are, most of the fertility centers, they don't encourage using beta-arginine or chlorhexidine for patient preparation. Generally, they don't use it inside the theater. So one solution is you can ask the patient to have a scrub outside the theater in preparation room, then wash it with the normal saline or water. And once patient walks in, once he's in theater, you can use normal saline to prepare patients. So now, what are the different types of procedures? So now this is first one is TISA procedure, which is percutaneous epidermal sperm aspiration. If you see here, my left hand is holding the epidermis, or I'm stabilizing the testis. Sometimes it's difficult to fix the epidermis. Your assistant has to hold the testis on the other side. So now once you isolate or hold the epidermis, then you just have to take 1 ml of culture media in the syringe. On the syringe, there are two ways. Either you can use an insulin syringe, or BD syringe, or a 2 cc syringe for aspiration with a 26 gauge needle. So lesser the needle, lesser the chance of trauma to the epidermis. So now once you aspirate, then you can send this fluid for the examination. But this procedure is particularly useful only in non-obstructive obstructive azoospermia patients and patients with CBAPD, that means congenital bilateral absence of vas difference, where you can get the sperms from the epidermis. But nowadays there is a study which says that these epidermal sperms, if it is obstructive azoospermia, because of the underlying infection, even this epidermal sperm can have abnormal DNA fragmentation. So most of the fertility centers, they prefer testicular sperm aspiration. So now this is how we map the testis into multiple areas. If you see here, this is just for illustration. For the information, we have drawn a picture, image. So now I divide testis into multiple regions like this. So always it's better to take samples from the midline, one from the upper pole, two from the middle pole, and third from the lower pole. If their sperm is not available, then you have to go for the peripheral areas. So now what happens is in peripheral areas, there is little higher chance of hematodermal. So coming to TISA procedure, there are two types of doing TISA. One procedure is when you need very little tissue, and second procedure is when you need little higher tissues. That means in obstructive azoospermia, you need only little tissue to get sperms. In second procedure, where particularly non-obstructive azoospermia, you need large chunks of tissue, then you can use the second technique. So in the first technique, generally what we do is we use only suction from the syringe. We don't aspirate continuously. Just put a needle and just what you need is only to and fro movements. Don't try to puncture multiple places. Just one puncture to and fro movement, you get the sperm. Second way is if you want more tissue, or if you want tissue, if IVF center needs more tissue to freeze the tissue, then you can follow this method. See here, I'm entering in the mid pole. So see, my needle is going only in one direction. I'm not going to multiple directions, because if you guide your needle into multiple direction, you will end up causing more trauma to the testicular tissue, and which may lead to inflammation. If you see here, there is tissue in the syringe and the tube, and more video. Yes, this is again video of Lisa. So again, I'm stabilizing the testis with my left hand. If you see here, testis is firm, and you test not moving the testis, and your assistant has to do continuous suction with the 20 cc syringe. And what you are seeing in this syringe is sperm washed medium. You see here, again, I'm not going to multiple directions, it's only in one direction. And once now you're seeing some tissue in the needle. Once you start seeing, then slowly you can pull it back. See, you can see testicular tissue here. And then with a fine tipped forceps, you can pull the tissue, you can send these tubules for examination. So now, this is after doing the procedure. How to do a dressing is simple. I learned this technique from Dr. Opinsha sir. It's very simple. Just put a gauze piece. Use the testicular skin, scrotal skin, as a for applying pressure. Just put a gauze piece, cover it with testicular scrotal skin, and put a simple plaster. This is more than enough for most of the patients who don't need a tight elastomer dressing. And you can remove this dressing after 4 to 6 hours, but ask the patient to wear a tight fitting undergarment for a couple of days. And this is how a tissue looks. And one small video to show how they tease the tissue in IVF lab. This is how they tease the tissue in IVF lab. Generally, embryologists have andrology technicians will do this. How the testis sperm looks in IVF microscope. See, after teasing, they'll you see, this is high magnification microscope. See, this is how a sperm is seen in, and most of these sperms are immotile. So testicular tissue, you only see, most of the times you see immotile sperms. You don't have to worry about that. There is embryologist's duty to take care of immotile sperms. And coming to MESA procedure, MESA means this just like a regular open procedure, but once we examine that, this is epididymis. What you're seeing here is epididymis. If you see dilated tubules here, you'll definitely get sperms here. What you can do is you can just put an insulin syringe with media into that particular area, or you can just open that area and take out tissue. Thank you, doctors. I hope this video will help most of the youngsters. If anybody has any doubt, they can always contact me directly. I can send these videos. And apart from this, there is micro-TCA, but micro-TCA you need expertise, and it takes a little more time for me to demonstrate. I'm stopping here. Thank you, doctors.
Thank you, Dr. Rahul, for a wonderful demonstration. Now it's time for the expert opinion. I now invite Dr. Vinod KV and Dr. Anil Helans to give their expert opinion. Over to you, sir.
Yeah, it was great to see andrology alive and kicking, and we see so many young guns doing good work. And we have had 5 excellent presentations. Dr. Pramod talked about setting up a andrology practice and gave a comprehensive list of all equipment that he would require in setting up that practice. One thing I'd like to add, that prior to getting all the equipment in, he didn't mention the need of having a space for doing the office sildenafil test, because that becomes a very prime investigation in evaluating ED. So having an adequate space and a room for doing the office sildenafil test, I think, is also a mandatory part of having your andrology practice, which I am, of course, he would have but forgot in his list of presentations. Karthikeyan VS talked about evaluating ED and again gave a very extensive evaluation of all possible factors which need to be covered. He talked of 3 index patients, and I feel in the first index patient where it was a young guy, married or unmarried, many of them would have anxiety issues, or many would have psychological issues, and it's very important to assess whether they have actually an organic cause and require some degree of counseling as well. So it's that part needs to be evaluated very judiciously. The second index case would be people in their mid-40s who would be prime candidates for cardiac evaluation, which might be a harbinger of ongoing cardiac disease also. So that needs to be taken care of both from their long-term perspective as well as giving them medication in the short term. And of course, the third index patient where we would be having much more extensive vasculogenic causes and would be ending up doing a surgical intervention since the responses to the drugs were not there. Dr. Arun Karthik spoke of the ejaculatory disorders, and again, an extensive discussion on all the possible ejaculatory disorders. He probably, out of lack of time, didn't talk much of anejaculation, where he stopped at retrograde ejaculation. Anejaculation also becomes a important factor and a very tough condition to deal with. And again, we might end up retrieving their sperms through whether using electroejaculator or doing getting their sperms out as shown in the subsequent videos. But for the point of view of having whether they are having their orgasm and having an adequate sexual life also needs to be treated, and that's a gray zone which still requires much more extensive in evaluation and treatment modalities to be developed. We had 2 excellent videos on Raghuvendra showed an excellent, straightforward, simple varicocele microsurgery. It was important to identify the artery first, isolate it, and then judiciously tie up all the veins, including the veins outside the spermatic fascia. Very well done. And Rahul Reddy showed and described the various different techniques of some sperm attraction and extraction. And of course, he mentioned that TSA needs to be done more with the advanced, and a budding andrologist would probably be happy to do these 4 procedures which he described in detail. So overall, a very extensive presentation and a very good one. Over to Vinod for your views.
First of all, I congratulate all the speakers for bringing out an excellent overview about mainly the andrology specialty. Now I will go from below upwards, from Rahul Reddy's video to next to Karthikeyan's video, and then take it forward because it is fresh in the minds of the audience. First of all, regarding Rahul Reddy's, I'm very happy that he has promised all the young colleagues to approach him for his video, because this is something which all urologists will be facing some difficulty when he's initiating his andrology practice. So we all will be helping you in pursuing your andrology practice. And I have a couple of comments about Rahul's video. One is regarding the MISA. In MISA, actually, it's initially intended to be a microsurgical procedure where you open up the epididymal tubule, take out as much aspirate as possible, and reconstruct it with a fine suture. But this was actually devised at the time when the ICSI was not available. You have an obstructive azoospermia, you have a lot of sperms in the epididymis. You want to do an IVF where you need a large number of sperms. It is not just possible with a MISA. That is why the MISA was popular at that time. But soon after it was devised and it was starting to get popularized, the ICSI came and now we need only a few sperms. So the importance of MISA has come down. And what Rahul was telling was actually an open fine needle aspiration, which we do even for a testicular aspiration as well as in an epididymal aspiration. This is also an acceptable procedure, and many people are doing that, the open fine needle aspiration. That is also a very good technique which is less traumatic and can be done by almost all urologists and andrologists. Another point is I don't know, maybe because of the lack of time, Rahul was not mentioning about the testicular mapping done by which was devised by Dr. Rubin Shah, which I feel is the most important and which should be the most discussed technique, because all urologists can do it and the harvest rate is very high. Because PISA is maybe a gynecologist will also do it at some occasions. The challenge comes when you are asked for a sperm retrieval in a non-obstructive azoospermia. There your PISA may not work. You may not have the facility of microsurgical sperm aspiration, your micro TC setting in that particular IVF lab. In that setting, you will be looking for the testicular mapping or SST technique, which Dr. Rubin Shah has devised, and that should be an excellent procedure. I think we can discuss it some later time, and that is one thing I wanted to point out in that. Thirdly, regarding the testicular aspiration, there will be some amount of controversies in that, because many people don't like going in multiple directions. Just like Rahul was telling about in the first setting, moving in a single direction multiple times. That will be opted by some of the at least some of the andrologists. But definitely this is also a discrete procedure. We can do it. For me, I will do only multiple aspirations in single direction. And if it is not yielding a positive sperms, I will go for a Rubin Shah's technique of open microsurgical, then multiple testicular aspirations by an open method under magnification. Then regarding Karthikeyan's video, it is an excellent video. But I for the beginners, I have a couple of points to focus. First, the importance of putting an incision. Karthikeyan has clearly shown that it should be at the correct position. Otherwise, what will happen is when you deliver the cord will be pinched at the external ring, and you can have spasms of the artery. So it should be at the correct position. And I have seen Karthikeyan using a hemostat to keep that to deliver that cord and keep it in place. I usually use a hernia clamp, which is a round shaped one, because it will not give that much tension to that cord, and it is a very useful instrument. And then also Karthikeyan was not describing about the micro instruments, the minimum amount of micro instruments we require when you are doing a microscopic surgical varicocelectomy. So a brief introduction of that would have been helpful, but we can definitely find out the necessary instruments and start doing the procedures. It's not a big deal for any urologist. But only thing is we have to keep on doing it. Then coming to the first set of 3 lectures, the first 2 were actually in tandem. Initially, we were discussing about setting an office. Pramod has clearly mentioned, discussed all the points, and I think Pramod is the best person to talk about that, because he has set up his own setup in an institute where such a specialty was non-existent. But if you are looking at that problem in a bird's eye view or in a bigger perspective, the main points we have to keep in mind is, whenever you are planning to set up an andrology department, an andrology facility, the 2 specialities, the 2 sub areas, groups in that andrology specialty, the erectile dysfunction and the infertility. we have to be sure which group of people we are catering, or are you going to cater both? That depends, that decides where you have to set up the department. If it is in a corporate setup, you are going to set up an andrology specialty and you don't have an reproductive medicine specialty there, you don't have an IVF specialty there, it will be very difficult for you to pursue the IVF, the reproductive medicine part, or the male infertility part. If you are setting it up in a infertility center, you may not find sufficient erectile dysfunction patients in that. So based on your availability and your structure of the city and the nature of the city, you have to plan which way you have to go. The second important point is bringing up your team. That is the most important thing. You should have a radiologist who knows how to do a penile Doppler. You should have a sex therapist or a sex psychology counselor. You should have a team for discussing with the patients. And you have definitely at the end of the presentation, Pramod was pointing out the necessity for a very good relation with the public to tell them that what we can offer, because this is not a very established specialty, even though we know that there are many quacks practicing andrology. Bringing it in a scientific way is a real challenge, as Pramod has clearly mentioned. And continuing with that, Karthikeyan was discussing about the ways to evaluate an ED in a practical way in a setting where you have an andrology setup. Practicing andrology in a routine OPD and in a specialty where in an andrology clinic is different. Your priorities are different, your facilities are different, your infrastructure is different, and your approach will also be different. So first you have to make up a team, make a good andrology clinic, make the process very clear, and you can start systematically, and you will get more patients. And there are a lot of patients who require a good andrology care. And regarding Arun Karthik's discussion, he has exhaustively covered all the problems of ejaculation. I don't think nobody can cover more than this at this very, very short time, and it is a very big topic. And on the whole, it was a very good show. And I think our young colleagues will be definitely benefited. And I thank USI and the youth of USI for giving me an opportunity to be part of this great andrology webinar. Thank you.
Thank you, Vinod sir. Thank you, Anil sir, for the icing on the cake, which was through your expert comments, where you very precisely pointed out what could be done better. And you really appreciated the talks of all the speakers. I just wanted to know from the conveners if there are any other questions from the audience or from somebody in the hall that we could address, because all the experts are here and all the speakers are here. And if not, then we could, we could conclude with the andrology section with the fine show that we've seen.
It was a good show, Raman.
Raman, there are a few questions, I think.
One minute, Raman. One question from the chat box.
There is a question to Arun Karthik. What is the preferred drug that you use for retrograde ejaculation? Often high dose of pseudoephedrine is needed and many times not available in pharmacy. Dr. Arun Karthik. Karthik, you have to unmute.
Dr. Arun? Dr. Arun, can you hear us?
Sir, I think Arun has not been able to understand the question or hear the question.
No, the preferred drug.
Is it okay if I answer it or any of the other experts answer it? So imipramine is a very good drug that can be given in situations where pseudoephedrine, ephedrine are not available, because usually they are medicines. So we usually use something for common cold. But then imipramine is a very good alternative for these patients with retrograde ejaculation.
I think Arun is online. Arun, can you hear us?
Sir, hello.
Arun.
Yeah, can you repeat that question for Arun?
Yes, Arun, there is a question for you.
Yes, sir, I got it, sir. There is my bandwidth was very low.
Okay,
Sir, Dr. Raman told imipramine will be the preferable, sir, because pseudoephedrine are not available. Imipramine at the dose of 25 TAD can be tried in cases of retrograde ejaculation, sir.
So what is the duration you prefer? Is it a single dose on the day, or you prefer 2 to 3 days before? And will you combine with any anticholinergic, other anticholinergics?
It can be combined, as you mentioned. It can be combined even with the pseudoephedrine that is usually available in a combination. What we use for the medication, we can actually combine with that. But still, it can be used as an on-demand or as a continuous daily dosing also. Even in spite of it, they may not respond to both the imipramine alone or a combination of both.
So how many days will you try before labeling it as a failure?
Sir, I usually give at least 1 month of complete course.
Okay, Raman, I think there are no more questions from the house or from the chat box. We can close this session. It was a very nice session. Raman, you can go ahead and close it.
Thank you, Dr. Dilip, for the opportunity. Thank you to the experts, to all the speakers for being there and putting up an excellent show. I really thoroughly enjoyed the sessions and I thoroughly enjoyed being a moderator. Thank you for this opportunity, and thank you USI for this opportunity. And if Naganathan wants to say something.
Thanks, Raman. It's a well concluded session, and we have come to the end of the second edition of USI Youth Conclave of day 1. It's a pride and privilege to be part of this great group. And over to Dr. Dilip, convener of OIVO.
Okay, thank you, Raman and Karthik. Nice session. I would like to thank Anil Allen sir, who has been sitting all the day waiting for this session to start. This was a post-lunch session. Everybody was a little sleepy, but it was a really good session. I enjoyed it thoroughly. For tomorrow, we'll be logging in at 9 a.m. We have one out-of-the-box session with nice talks on finance and 3D printing. And the next session is lower unit tax session, in which we have got a star talk by Professor N.P. Gupta from Medanta. So we'll be starting sharp at 9, and I hope to have all of you have a good evening. Thank you all for today's session.